disappear of the nidus. We can recognize it with this method. So cure rate is over 80%. Surgical mobility mortality rate is 18.8%. So finally, the future diagnostic and therapeutic strategies of brain AVM. So this is a molecular and cellular biology of the AVMs. So it's a congenital static lesion and the sporadic cause, the growth, remodeling, and the regression, the rupture event. The new genetic, molecular, and cellular factors have been demonstrated to be involved in the process of the formation, growth, and rupture of AVM. How can biology impact the potential future management? So risk of the AVM rupture, one is genetic mutations, intranidal aneurysm, exclusive deep venous drainage, and the restricted venous outflow, and the deep or infratentorial location. So this is a schematic drawing. Is the molecular and cellular biology of the AVM. The expose of the abnormal, the high flow plus shear stress, and smooth muscle cell and the brain and the cellular cell comes the proliferation and the remodeling. So this is the four cause of the AVM nidus become large. So this is genetic, and this is experimental therapeutics and formation and the growth and rupture. So many factors and so many causes can AVM enlargement. So molecular and cellular biology associated with the syndromic AVMs. Something we can experience about the HHT or CAMS. So AVM formation. So this is a single nucleotide polymorphism, SNPS, and also the TGF-beta. So, and also the endocrine ENG. It's a glycoprotein located on the cellular surface, crucial for angiogenesis. So as for the AVM growth and rupture, the role for inflammation and the extracellular matrix remodeling. Macrophage and the neutrophils tend to invade AVM tissue. So matrix method of protein does play a key role in the growth and rupture of several AVMs. Brain endothelial cells have a higher proliferation rate with a reduced apoptotic response to inflammatory mediators. Multiple mechanisms, including inflammation, remodeling, and VEC abnormalities, contribute to tendency to rupture. So, about AVM treatment. Kind of the treatment is open surgery and radiosurgery and endovascular treatment. But completeness is endovascular is 30%, and also the radiosurgery is about 40%. So microsurgical resection is currently recommended for spectral Pons class A or spectral Martin grade 1 or 2 AVMs. In combined treatment, spectral Pons class B or spectral Martin grade 3. The palliative treatment, spectral Pons class C or spectral Martin grade 4 and 5 AVMs. So new treatment idea is a new cellular and molecular biological therapies are under development. So aims to radiosensitization and the vascular targeting and the remodeling therapies. So understanding of the regulatory factors and the pathways is very important. That is modifying the natural history away from rupture. So experimental therapy so many drugs is appearing. So tetracyclines and doxycycline and VEGF, the focal hyperstimulation delivered by an adenovirus vector showed in inhibition of the MMP9 messenger RNA expression. Thrombospondin 1 is another important drug. So this anti-angiogenetic therapy, the thrombospondin 1, and also the VEGF-A antagonist, and bevacizumab is a very popular one. So in conclusion, in understanding the complex cellular biology, physiology, hemodynamics, and flow-related phenomena of AVMs is critical for defining and predicting their behavior, developing novel drug treatments, and improving the endovascular and surgical techniques. So, of course, for the moment, the main treatment, the tree is 3 categories, but we should think about the very basic the research for preventing the increasing of the avian virus itself. Offers conservative observation for younger patients with ruptured high-grade AVMs and long life expectancy. Once there is a rupture or high risk of rupture, the surgical mobility associated with the downgraded AVMs is reduced to that of post-radiosurgical preoperative supplemented the post-margin increase. So sometimes we think about the radiosurgery, especially the large or the diffuse type of the nidus. You can give the radiosurgery in divine, especially in between the 2-3 years. That is one of the options for such a very difficult type of the AVM. Thank you for your listening.
Thank you very much for giving me this opportunity to talk about the neuro and vascular treatment. I'm from Yas City, Shizuoka, Japan. Our hospital is the Memorial Neurosurgical Clinic started in 2005, 16 years ago. Our clinic is a kind of micro hospital because we have only 19 beds and some operation rooms. And we are doing a neurosurgical operation 120 cases a year, including an endovascular treatment. This time, Professor Yoko Kato gave me the subject for young neurosurgeons to become the neuroendovascular specialist. So I represented the procedure of the basic endovascular techniques and the essential theory. First of all, I will explain about catheter techniques, how to approach the guiding catheter. Next, I will show you the real scene of endovascular treatment with description. First, we have to approach and keep the guiding catheter to achieve the endovascular treatment, as well the guiding catheter need to be more stable with the aim of making treatment best. There are some types of outset anatomy, as you can see on the slide. These types were related to the degree of the difficulty to approach the guiding catheter. It's classified 3 types, and each type has the difficulty to perform cannulation. It is at the top of the aorta where the distance of brachiocephalic artery's origin is several times of common carotid artery. Type 3 distance is over as 3 times as type 1. Type 1 is the angle is bigger than the other one, so it's easy to approach than the other one. Type 3 is more difficult than the other one because bifurcation is the acute angle shaped. Bovarianity is one of the aortic variation. As you can see, less common carotid artery goes up from brachiocephalic artery. It means that there are nearly 10% or less. It has an acute angle from descending aorta. That's why it's difficult to approach and guiding catheter. Therefore, it is reported that has neurological complication more than the other types on the carotid stenting. Depending on the case, I think it is useful route transbrachial or radial artery because it is able to have possibility to pass easily and if we want to be more stable and guiding catheter. And now I will explain about the essential guiding catheter system. Recently, there are a lot of kind of devices, so I will introduce the typical image of the systems and that's all. This is the image of a basic guiding catheter system commonly used. First, you have to know the adaptation between each other devices. Also, I think it's a useful way to make your familiar system. Then you can compare with the other devices when you choose the other ones. Next, there are some kind of pre-shaped in the catheter. As you can see on the slide, the representative the ones Headhunters, Siemens, JB2, and so on. I usually use one called about countdown in the catheter on using over 8 French guiding catheter. It was good operability because it is made big as hand. Commonly, the size of 5 to 9 French guiding catheters are used during the vascular treatment, including balloon guiding. It's necessary to keep more stable guiding catheter before approaching the region for achievement more excellent treatment, and take position of guiding catheter where you can see in your monitor. Actual operation field tend to be more crowded, so organized and memorized these places. For example, situation occurring embolization with stent for cerebral aneurysms. It must be really confusing. As you can see in the slide, you need to use at least 4 wide connections, 3 triple wide stopcocks, and 2 or 3 irrigation systems with pressurized bag on the cooling with stent. I will explain about the basic theory of neuroendovascular treatment techniques. I think that operation result of determinative factors are divided into 3 classes, namely patient factor, devices factor, and operator's factor. On patient factors, depend on the patient. It might be difficult to perform the endovascular treatment. For instance, patients who have any basic disease or age tend to have atherosclerosis more severe. Also, it's difficult to be hard and middling vessels. In particular, type 3 or bovine aorta are not easy to pass the catheter I showed before. As you can see on the slide, this schema, type 3 has higher angle, so it has caps as many as the other ones. Also, catheter is going to be snaked, so catheter distance is not going to be enough. On the like at the type stress situation, if you add too much strength to go ahead forcibly, the catheter will snap to the ascending aorta. Because the catheter is going to be straight, but artery is going to be keeping. This principle is long action and reaction on the catheter operation. This snap-down situation is able to make the kinking of its catheters or threading down their treatment devices. So you must be conscious of this theory during a catheter operation. This catheter theory is the same as intracranial artery. It will only be small. As you can see, we often find like this situation. That is, for example, the A1 case which has a high angle shape from AC. Microcatheter side up to M1 with making room when it is added the strength to go ahead forcibly. Naturally, patient artery condition cannot change, but you are able to perform more easily if you use their devices by contrivance. There are many factors on devices, for example, catheter shape, distance, thickness, hardness, friction, and so on. Also, you can combine with each other factor to perform more easily. Needless to say, operator is the most important factor, and operator need to have skills, knowledge, experience, good relationship with staffs, and heart and gut. In my opinion, but the basic theory of the vascular surgery. First, you have to collect the patient's information before operation as much as possible. Next, get enough knowledge of the essential anatomy, characteristics of devices, and compatible specification during each device. Finally, make planning in detail before operation and consider thinking about what do you use and combine their devices at when kind of each cases. I will explain about the technical steps using endovascular simulator. First of all, you should use the seat as long as possible because it is making the first phase of the endovascular treatment and is able to perform the guiding catheter easily when the catheter is needed. When the top of the guide wire is weighted and brought to the different vessel when moving the table. When guide wire arrives the descending aorta, keep the guide wire. Next, follow this the inner catheter and guiding catheter. Select the target artery using inner catheter with guide wire where you want to go. If you cannot to keep the inner catheter, make a contrast image with injection from proximal and make rod mapping when necessary. It's difficult to approach so as to bigger side of guiding catheter because they have higher strength to be straight. Therefore, you should follow the guiding catheter with acquired force rotary. The catheter is going to go ahead through the bent artery over vessel wall. When the blood vessel is straight, catheter will go up straight, but blood vessel bent catheter is going to be curved. On this point, catheter goes ahead through the curve to the starting point. Because so, when there is an escape in the point of the curve, it falls easily. Therefore, brother have to control that balance with the blood vessel, which is going to maintain a catheter and shape that are going to improve. When the catheter doesn't go up with catheter bending, hold the wire and pull the catheter once. You can get the become straight the catheter easily. When like the situation, it is easy to go ahead, try to add and rotate the guiding catheter. I think different factors are hardness, mental vessels, law of action and reaction, friction resistance, balance between artery and the catheter, and so on. In solution method, when you cannot approach easily, you should try to change a different type of the catheter to material shape, hardness, or their friction. As the pressing and in the catheter doesn't fall. Also, when a guiding catheter doesn't follow, change the guide wire to stiff type because vessel is going to be straight and the next catheter will follow easily. Add the strength to go ahead with many forces, usually direction in the anti-clockwise rotation or push and pull depend on your feeling. Ask your assistant to keep the guide wire. I think the surgeon who can employ an assistant well has many excellent doctors. It is one of the ways to change the different road to transbrachial or transradial artery. There are some application methods, so you can try them when you never get the target vessel, but you should perform the endovascular surgery more simply. Next, I will introduce my real endovascular treatment theme broadly. I'm glad if you get the guidance of treatment loosely. This is the left carotid stenting case. I was planning each case and the found stop. In the middle of the preparing the devices, I could find my hand moving. Prepare the cis guiding catheter in a catheter and guide wire with irrigation system. I often use this stopping valve when I expect that difficult to pass. And I always prepare in deflator and by pre-dilatation ballooning catheter to according planning before I made it, because to be short the operation. We usually perform endovascular surgery on local anesthesia, puncturing the femoral artery when on level of the head of the femoral bone. Confound the back floor, insert the guide wire. And represent the cyst. I told before you should use the CS as long as possible because it will make the vessel treatment, then heparinization until twice time at ACT. Watch the guide wire on the sending out and for the next inner and guiding catheter. Select the common carotid artery within the catheter and follow the guiding catheter. Next, put a distal protection device on this catheter to use the easy filter. And then perform the pre-dilatation ballooning. Before the pre-dilatation, this is the injector purple brain for the bradycardia preservation. Next, press and open the stent. It was the easy filter stent. Because it was expected unstable plaque. So finally, perform the post-dilatation. Counting 10 seconds. Then correct the filter using capsule. Make image before get off the filter if there is no overflow of that. We always use the seal to get stopping the bleeding. Make image before using the angle seal if it was clarification or not. But I think angle seal doesn't guarantee hemostasis because I have experienced hematoma over 10% after ablation. So I'm researching the reason why it couldn't make hemostasis completely. It makes like a sandwich to use the collagen sponge but it's easy to break. Next, this is the 41-year-old woman, left internal carotid aneurysm, 6 mm distance. It was found on physical examination. On the case was performed on local anesthesia. First, inserted stent. After that, injected the heparin by it become twice time at ACT. Put on the side of the 7 French guiding catheter using 4 French in a catheter to carotid artery as deep as possible. And made a irrigation system using double wire connection. Next, made image to make the road mapping. was pressed the microcatheter into the artery to do the cutting. After that, the microcatheter was pressed on the distal ICA for putting the stent. The case was used to ascertain the microcatheter. And then stent was prepared. As you can say, it confirmed to remove from stenting cells if there is a year or not from at the end of the white connection. After placement, the stent coding was started. This case was used the neuroform ultra stent because it is very flexible in the artery. We already used the neuroform ultras on the case of the ICA. Called parking position doing, as you can see on the video, it is always really crowded on the coding with stent on the operation theater because it is using 4 collection and 3 triple cock stop with irrigation systems. So organize and memorize the pressure of the devices to avoid the mispressing. We always perform the vascular surgery with 2 surgeons for hand. It is important that making combination. The second doctor, Asataka Takeuchi, is very excellent surgeon. I worked with him for 15 years, so long. So we can make the best combination naturally for the endovascular treatment. This is the final view on this core embolization with stent. It was good cause. Finally, I will return to the before slide. I presented the vascular treatment theory, and I thought this presentation was for young neurosurgeons who want to be the neuro and vascular specialist. In conclusion, let's acquire experience. They are led to do the experiment the catheter angiogram recently because other inspection is developing now. So I think first, do more the catheter angiography when you suspect the brain disease because the endovascular treatment is on the run of the catheter inspection. Thank you very much for your attention.
Good afternoon, ladies and gentlemen. I am very glad to have this opportunity to introduce the work of the neurosurgeon team led by Professor Qing Lan in microsurgery of intracranial aneurysms via supraorbital keyhole approach. As we all know, since the publication of the result of ISAT research in 2022, the advantages of endovascular coiling in minimally invasiveness and functional prognosis have been highlighted, leading to more and more intracranial aneurysms treated by such strategy. But its long-term stability and recurrence rate are still worthy of attention. Microsurgical clipping can make up for the deficiency of endovascular treatment and also have advantages for lesions in some special locations and special types, such as large aneurysms causing space-occupying effect and distal aneurysms, requiring blood flow reconstruction. And let's take a look at the history of microsurgical clipping. The first reported case of surgical clipping of intracranial aneurysm in the world was performed by Professor Dandy in 1938. At that time, a posterior communicating artery aneurysm was clipped with an unadjustable silver clip, and the patient recovered well finally. Then, in 1976, Professor Yasagio established the standard pterional craniotomy, which is still the most simple and convenient classic surgical approach for lesions located in suprasellar and parasellar region. And the scope of craniotomy has been significantly reduced compared to previous approaches made by other neurosurgeons. In 1991, Professor Fukushima reported his successful microsurgical treatment of ruptured and unruptured anterior communicating artery aneurysms and anterior cerebral artery aneurysms via interhemispheric keyhole approach. This is the first reported of so-called keyhole microsurgery for intracranial aneurysms. Finally, Professor Panetsky summarized the various keyhole approaches for the treatment of intracranial lesions in different locations, and his manuscripts laid a milestone for keyhole microsurgery of intracranial aneurysms. And at present, a variety of standard keyhole approaches have been formed for intracranial aneurysms centered on the circle of Willis. Among them, the supraorbital keyhole approach is the most typical one and widely used now. Today, I will share our clinical experience of microsurgical clipping of intracranial aneurysms via supraorbital keyhole approach. The first issue is, can we manage intracranial aneurysm via keyhole craniotomy successfully? In other words, is there adequate effective surgical space under the small craniotomy of keyhole approach? And the visual field via keyhole approaches is small and can only be controlled through a predefined surgical corridor. The surgical angle cannot be changed at any time during the surgery compared to the conventional craniotomy. Actually, based on the studies by cadaveric anatomy and observation of surgery, we found that due to the deep location of intracranial aneurysms in Willis circle, no matter how large the craniotomy is, it is impossible to change the deep-seated narrow surgical space, and coaxial control is always required on the microscope. For neurosurgeons, it is very important to convert the conventional two-dimensional images into three-dimensional images and fuse them with bone, nerves, and other important structures such as vessels, so as to carry out intuitive preoperative planning. And we can understand the surgical field obtained by different approach directions by rotation of images, so as to facilitate the selection of the optimal surgical approach. That is what we do during surgery. And without removing the frontal gyrus, the anterior communicating artery complex is clearly exposed. And the next step, clipping, is simple. A U-shaped clip was applied to the neck of the aneurysm, and post-operative angiography follow-up showed that the lesion was cured. Another important and main controversial issue of keyhole microsurgery for intracranial aneurysms is how to prevent and control the premature rupture through a small keyhole craniotomy. Based on the literatures, premature rupture during surgery can occur in all procedures, and the incidence of free aneurysm is the highest. Even in the absence of any manipulation, rupture can also occur. However, such unexpected premature rupture is inevitable sometimes. As we show in this slide, this ruptured anterior communicating artery aneurysm ruptured again during removal of clot. 2 aspirators was used. A larger one controlled the ruptured point, and a smaller one cleaned the surgical field. Then the dominant A1 segment was temporarily controlled, and the aneurysmal neck was occluded permanently by a bayonet clip. Such strategy is also recognized by neurosurgeons. However, due to this strategy taken after premature rupture, we call it passive coping. Another strategy is to change a ruptured aneurysm into an unruptured one actively, just like this ruptured posterior communicating artery aneurysm. Through a keyhole approach, we tentatively clip partial dome followed by complete free of the aneurysm. Then 4 clips were used to temporary occlusion of the proximal internal carotid artery, the beginning of A1 and M1 segment, and the posterior communicating artery respectively. After that, a more suitable bayonet clip was replaced to complete obliterate the aneurysmal neck while protecting the posterior communicating artery and its perforators. ICG angiography showed that the blood flow of internal carotid artery and the posterior communicating artery was intact. The second issue is ineffectiveness. That is, what special aneurysms can be operated via supraorbital keyhole approach. The first type is giant aneurysm and thrombotic aneurysms. This patient harbored a giant incidental aneurysm of a posterior communicating artery. He was operated via supraorbital keyhole approach. Temporary trapping was carried out by occlusion of proximal internal carotid artery and A1 M1 segment, puncturing the aneurysmal wall followed by reducing the aneurysmal dome by suction. 2 right-angled fenestrated clips were applied to reconstruction internal carotid artery. But it is obviously not enough for such huge lesion, so it is reinforced by multiple fenestrated clips. And the patient recovered well after surgery, and post-operative CT angiography revealed total obliteration of aneurysm and intact of parent artery. Another patient harbored a giant thrombotic aneurysm, and obvious calcification of dome was noted on CT image. The neck was exposed after partial removal of anterior clinoidal process, and 2 clips was applied to occlude the neck. Then open the wall, remove the thrombus in aneurysmal cavity, and partial sclerotic aneurysm dome was also removed to eliminate the occupying effect. The second type is posterior circulation aneurysm, especially for basilar apex aneurysms. This incidental basilar apex aneurysm was diagnosed in this patient by digital subtraction angiography after subarachnoid hemorrhage due to a ruptured middle cerebral artery aneurysm. he experienced the surgery via right supraorbital keyhole approach. The ruptured middle cerebral artery aneurysm was clipped firstly, then opened the Liliequist membrane through the optic carotid window to expose the upper basilar artery. After temporary occlusion of the proximal basilar artery to control the blood flow, the apex aneurysm was occluded by a bayonet clip. Then remove the temporary clip. The patient recovered well after surgery, and the DSA follow-up revealed a satisfactory result. However, not all basilar apex aneurysms can be treated so easily, and this apex aneurysm is higher than previous one. During the surgery, the anterior choroidal process was drilled off firstly so that a clip could be applied upward from a relatively lower position. Then we have adequate surgical space to manage the apex lesion. And alternatively, removal of orbital roof is an available variation of supraorbital keyhole approach. More difficult is the need to drilling off the posterior clinoidal process to expose the proximal parent artery. This patient also detected an incidental basilar apex aneurysm due to another ruptured anterior cerebral artery aneurysm, and the optic carotid window was exposed firstly via right supraorbital keyhole approach, but it was too small to accommodate temporary and permanent clips. Then the posterior clinoidal process was drilled off to control the proximal basilar artery, and the lesion was clipped through optic carotid window. Follow that, the ruptured A1 aneurysm was occluded successfully. And as we can see from this case, after removal of the posterior clinoidal process, the exposure of basilar artery will be significantly improved. The third type is contralateral aneurysms. According to anatomical study, supraorbital keyhole approach is more convenient to control and cope with the contralateral lesions than terional keyhole approach. As shown in the pictures, the aneurysms suitable for contralateral approach mainly refers to the inferior M1 bifurcation aneurysms and the median ophthalmic aneurysms. This patient harbored 4 aneurysms, 2 of them on the left side, 1 of them on the right side, and she has also another anterior communicating artery aneurysm in the midline. And the left M1 segment aneurysm was clipped firstly, then the bifurcation of internal carotid artery aneurysm. And during the operation, we found that the anterior communicating artery aneurysm was ruptured one, so we clipped it successively, used 2 clips. And after dissecting the proximal contralateral sylvian fissure, it is also easy to clip a downward contralateral M1 bifurcation aneurysm. And the picture on the left side showed the anatomical marks on the scalp of the patient. For a medial ophthalmic aneurysm of internal carotid artery, it can fully exposed between 2 optic nerves before chiasm. And in contrast, during espilateral approach, due to the obstruction of internal carotid artery and optic nerve, it is necessary to drill off the anterior clinoidal process and push the optic nerve. Therefore, such contralateral approach excessively simplifies the surgical procedure and reduces the incidental of complications. So we can see we use a straight clip and a fenestrate clip can completely obliterate the aneurysm, and the DSA follow-up showed the satisfactory result. Finally, we will discuss the indications of supraorbital keyhole approach. First is the anatomical considerations. Compared with pterional keyhole approach, the surgical view of supraorbital keyhole approach is more anterior-posterior direction. As we can see from the pictures, in most cases, the origination of posterior communicating artery is located on the dorsal internal carotid artery and cannot be observed directly. Therefore, for rear-pointed posterior communicating artery aneurysms, in order to expose the aneurysmal neck and parent artery better, pterional keyhole approach is more appropriate. But for the anterior communicating artery aneurysm, which was located in the midline region, the supraorbital keyhole approach is more suitable. And about approach-related complications, during supraorbital keyhole approach, the location and the size of frontal paranasal sinus must be considered before craniotomy. And based on bone window image of computed tomography, we can actually mark the position of lateral boundary of frontal paranasal sinus and avoid opening during surgery. If inevitable, it needs to be repaired with various artificial or autologous materials to prevent cerebral spinal fluid leakage after surgery. If the sinus is too large, pterional keyhole approach is another available alternative. Olfactory nerve running close to the bottom of frontal lobe is easy to be injured during retraction of frontal lobe, especially in the management of contralateral lesions. And in order to preserve this nerve, it should be fully dissecting from frontal lobe before further manipulation. Finally, when it comes to supraorbital keyhole approach, we have to talk about the cosmetic results. This particular patient have two posterior communicating artery aneurysms, and a few years ago she experienced microsurgical clipping of left lesion via esophageal pterional craniotomy in the local hospital, and recently her right lesion was treated in our department. The left image shows the scar left several years ago, and the right image shows the skin incision of pterional keyhole approach the next day after the surgery. The patient described to us that the experience of the recent surgery, no matter the shaving range or the incision pain and discomfort, is much better than a few years ago. But bad skin healing is not as good as the longer incision in the hairline. The skin incision should be made in a crease or scar of the supraorbital area. Alternatively, an incision behind the headline is also possible. That's all. Thank you very much for your attention.
I am Hidehito Kimura. It's my great pleasure to be invited this fantastic webinar, and I deeply appreciate Professor Yoko Kato for giving me this great opportunity. My topic is bypass surgery step by step for reliable revascularization. Anastomosis, including step-by-step instructions and how to perform training by yourself. First, what is STA-MCA anastomosis? In this surgery, two superficial temporal arteries, so-called STAs, are anastomosed to the distal middle cerebral artery on the surface of the brain to secure the blood flow from the main trunk artery. Its indications is shown here. Bypass surgery still needs to be done for the patient with progressing ischemic stroke and moyamoya disease, complex aneurysms, tumor surgery for radical resection, and so on. For the patient with ischemic stroke, two past prominent randomized trials failed to show the superiority of the surgery over the medical management. However, several studies have shown improved cerebral blood hemodynamics after STA-MCA anastomosis and stress the efficacy to avoid the recurrence of the cerebral infarction. In Japan, we have JET study that proved the efficacy of STA-MCA anastomosis for the treatment of atherosclerotic cerebral occlusive disease. Here are inclusion criteria in JET study. This is a quantitative CBF study by IMP-SPECT at rest and acetozolamide activated images, which shows the left resting cerebral blood flow decreased 80% of normal CBF, and the increase of acetozolamide activated CBF is less than 10%. This severely hemodynamic compromised patient is a good candidate for STA-MCA anastomosis to avoid the recurrence of the ischemic stroke. The principles. The first is the temporary occlusion time of the recipient artery should be short as possible. The second is that do not injure the intima. Do not pinch the intima. We tend to pinch the intima with tweezer during the procedure, and then the intima will be injured easily, and the platelet aggregation will occur, and the anastomosis will be occluded later on. And the third is that both intima should be precisely matched. Let the intima making eversion and facing each other like this. I will talk about the actual surgery. This is a skin incision For the single anastomosis, when we perform a single anastomosis, we just need to make a linear skin incision just above the parietal branch of STA. When you perform double barrel anastomosis, there are two types of skin incisions. For the ischemic stroke patient, we do not perform indirect anastomosis. Hence, the extent of craniotomy does not need to be large. Then we just need to make two linear skin incisions just above the frontal branch and the parietal branch. And the frontal branch can be guided through the subcutaneous tunnel to the surgical field, where the parietal branch is dissected. For the moyamoya disease, we also need to perform indirect revascularization, so the craniotomy should be relatively large. The frontal branch of the STA is then usually harvested from the inverted skin flap. After the double barrel anastomosis, temporal muscle and the pericranium and the temporal fascia are also implanted over the hemodynamic compromised brain. This is so-called STMC anastomosis plus encephaloduromyal arterial pericranial synangiosis, EDMAPS. This patient is a 65-year-old gentleman. He suffered from a transient dysarthria and left mild hemiparesis. He had a history of diabetes mellitus and high blood pressure. Diffusion-weighted image demonstrated high signal lesion at the MCA territory. MRA demonstrated right severe ICS stenosis. The signal intensity of the right middle cerebral artery was lower than that of the left side. SPECT study showed impaired cerebral blood flow for the middle cerebral artery territory. These results were consistent with the indications of the JET study. So we performed the STMC anastomosis. For this patient, we selected single anastomosis. As I mentioned, I performed the linear skin incision just above the parietal branch of STA. Under the microscope, using a bipolar with a high-power coagulation mode, perivascular tissue can be coagulated and cut simultaneously. We call this method bipolar cutting method. About usually 6 to 8 centimeters of STA can be harvested. Heparin solution was injected from the end of the graft to avoid the intraoperative coagulation. Temporal muscle was cut along the STA, and tubal hole was made, and relatively small craniotomy was performed. Dura was incised, and choose a recipient artery that had sufficient diameter. Tiny perforators can be coagulated without any hesitation. Now place a rubber seat under the recipient artery. Blue dye is applied to the outer membrane using a skin pen to increase visibility. And for the donor, the perivascular connective tissue removed slowly and cut about 60 degrees. And another end was also cut at the same length. Before clamping the recipient artery, needle insertion of the donor artery with a stay suture was performed in advance. After clamping the recipient artery, arteriotomy was
down. Needle insertion should be done under the highest magnification. In tying the thread, you can do better under the lower magnification. Intraoperatively, you should change the magnification of the microscope frequently for the best procedure. Every needle insertion should be done in carefully confirming the lumen. Every needle insertion confirming the lumen under the highest magnification is very important. Once you can notice the lumen, needle insertion is not so difficult. After all sutures completed, declamping the recipient artery from the distal side, followed by the proximal clip, and the donor artery was opened. This is a bleeding from the tiny branch, not an anastomosis side, so coagulated. If anastomosis side, it should be sutured. To confirm the patency, either Doppler and the ICD-video angiography. The dura is closing to prevent the compression of the graft. Temporal fascia and the muscle piece was harvested and placed around the graft to compress the graft. And checking the patency again, the bone flap was replaced. The bones around the STA should be trimmed accordingly. Then suturing of the temporal muscle, also be careful not to compress the graft. The skin was closed in a standard fashion. Post-operative CD notes showed no new lesion. This really shows the extent of the craniotomy. MRA demonstrated the graft was patent, shown by yellow arrow. Spectra showed the improved cerebral blood flow, not showing the hyperperfusion.
The next is for the patient with moyamoya disease. This patient is a 17-year-old girl. She had no relevant past medical history and no neurological deficit. CT scan showed the low density area at the frontal lobe showing the old cerebral infarction. FLIR image also showed right frontal old infarction. DWI showed relatively fresh cerebral infarction at the same area. MRA demonstrated bilateral intracranial internal carotid artery stenosis. DSA for the right ICA showed moyamoya vessels around the basal ganglia. External carotid artery angiography demonstrated two main branches of the STA. Left internal carotid artery angiography demonstrated severe ICA stenosis and almost occluded middle cerebral artery. SPECT showed markedly decreased blood flow in the cerebral hemispheres bilaterally. The right side was more markedly affected than the left side. Acetazolamide activated image showed impaired cerebral vasoreactivity bilaterally. The right side was more markedly affected than the left side as well. The CBR of the ACA region and the anterior half of the MCA region was markedly decreased below 0. So we performed right STA-MCA double barrel anastomosis and encephalodural mirror arterial pericranial synangiosis, so-called ED maps, to this patient. As I mentioned, curved skin incision was a relatively large craniotomy. The parietal branch of STA is harvested beneath this skin incision. Under the microscope, I harvested the STA. As I mentioned, using a bipolar cutting technique, I harvested the STA. The parietal branch of STA can be harvested beneath the skin incision. The frontal branch of STA covered by the garrier, looking from the back side of the skin flap. This can be harvested from the skin flap by cutting the garrier and the surrounding connective tissue. Now I am checking the flow of the STA. If you found the slow flow, you just need to inject heparinized saline solution, and the papaverine soaked cotton will regain the graft. The periosteum is incised. To perform ED maps, the fascial and the temporal muscle is dissected separately. The medial periosteum is inverted anteriorly with a pedicle to cover the frontal lobe later on. I usually perform two-piece craniotomy to preserve the middle meningeal artery. The dura is inside radially and inverted under the surrounding dura. The arachnoid membrane is cut and small perforator was coagulated and cut. Place rubber seat. ST was cut and forming the fish mouth trimming. Blue dye is applied to the outer membrane using a skin pen to increase visibility. Clamp the recipient arteries, the inside the recipient artery. I'm using tensile nylon and suturing in confined lumen to avoid the misstitching. Checking the lumen is very important. After the compression, the declamp from the distal clip to the proximal clip. The STA was opened. ICG video angiography demonstrated good patency. Next, anastomosis. This was so tiny recipient artery, you can see, in about 0.6 millimeter. Even such a tiny vessel, all procedures in the same. Checking the lumen, needle insertion carefully. The ICG video angiography demonstrated good patency. The dura is incised radially and inverted under the surrounding subdural space. As I mentioned, medial pedicled periosteum was placed over the frontal lobe. The bone flap was replaced and fixed. Of course, the suturing of the muscle and skin, be careful not to compress the graft. And the skin was closed in a standard fashion. Postoperative CT showed no new rhythm. This 3D CT shows the extent of the craniotomy. DSA showed the two bypass grafts were patent and improved blood flow for the MCA territory. Now I'll talk about how to perform the training. This is the preparation of artificial vessel. First, place the donor artery like this. Place the artificial vessel and fix, giving the appropriate tension to the vessel. The length of the donor artery should not be too long or too short. For enlarging the aperture area of the anastomosis, first we incise the stump with the angle of 60 degrees. Further incision at another side for the same length to form a wider opening. We call this fish mouth trimming. The incision length of the MCA recipient artery should be matched definitely with the stump of the length of the STA. At first, we make stay sutures on both ends. The next suture will be just next to the stay suture at the 11 or 7 o'clock position, because at this time it is easier to check the lumen, avoiding the misstitching at the another side when inserting the needle. Interrupted sutures done using the tensile nylon in order. This is my recommendation. The suture insertion distance from the edge should be the same as the blood vessel thickness. The interval of the suture should be twice the blood vessel thickness. If you keep this manner, the bypass will work well. This is my actual training kit with a tissue box. Attach a single artificial blood vessel on the surface of the box. Then another artificial vessel is attached to the bottom of the box to perform STA M4 bypass. Under the microscope in the actual OR, I used to train every day after daily surgeries. Place the artificial vessel at the bottom of the box like M4 and confirming the lumen. The every procedure like actual surgery. Under the highest magnification, needle insertion was performed, and tying a thread under the lower magnification. The magnification should be changed appropriately. The opposite side suturing should be done in the same manner. Next suture after the stay suture should be done just adjacent to the stay suture. Now tying a thread under the lower magnification, needle insertion under the higher magnification. After compression of the bypass, to confirm the patency, I cut the artificial viscera to check the lumen. Okay. I trained frequently after the daily surgery. Instead of artificial viscera, you can use chicken wings. Place a chicken wing like this, and inside here, and you can find a ulnar artery and a radial artery to use the microvascular training. The difference with the artificial viscera is that the chicken wings viscera are very sticky. The connective tissue around the anastomosis site needs to be removed slowly in advance. Take-home message. In order to perform a safe and reliable bypass, the lumen must be properly checked, and the needle must be passed through all layers. Create bloodless surgical field for full visibility of anatomical structures. Frequent training by yourself is mandatory to become a good bypass surgeon. Thank you for your attention.
My lecture is about transcondylar fossa approach to the vertebral artery aneurysm. At first, I would like to introduce myself. I am a Vice Director of Department of Neurosurgery at Sapporo Teishinkai Hospital. Sapporo Teishinkai Hospital is located in north side of the Japan, and I have two mentors in my hospital, Professor Rokuya Tanikawa and Professor Hiroyasu Kamiyama. Professor Kamiyama is a pioneer of the bypass surgery, and Professor Tanikawa is one of the most famous vascular and skull-based neurosurgeons. I've been working with them around 10 years. So I'd like to start my presentation. At first, I will show you the efficacy of the transcondylar fossa approach. This is a left side approach with park bench position. This is just a lateral suboccipital approach, very narrow operative field because of the jugular tubercle. So then jugular tubercle is drilled. And to do this, the managing the posterior condylar emissary vein is important. After that, dura was incised towards the hypoglossal canal. Here you can see very shallow and wide operative field can be achieved. So the transcondylar fossa approach is very effective approach. This is today's topics. First topic is surgical anatomy and technique of the transcondylar fossa approach. At first, I will show you how to do a suboccipital muscle dissection. Then I would like to talk about surgical microanatomy of the occipital artery. And finally, I will show you the surgical microanatomy of the posterior condylar emissary vein. Second topic is surgical outcome for vertebral artery aneurysms. And finally, surgical strategy and treatment of complex vertebral artery aneurysm will be talked. At first, I'll show you a suboccipital muscle dissection and surgical microanatomy of the occipital artery. This is the vertebral artery pica aneurysm, and here you can see the posterior inferior cerebral artery is arising from the aneurysmal dome. So, if we perform a clipping, pica should be reconstructed. Left side park bench position. Skin incision was started just above the occipital artery. This is the subcutaneous layer of occipital artery. This is the occipital muscle. Skin flap is gradually elevated. And this is the sternocleidomastoid muscle. And this is the occipital muscle. Subcutaneous layer of the occipital artery is harvested. Then sternocleidomastoid muscle is elevated laterally. Under the sternocleidomastoid muscle, this is the splenius capitis muscle. Splenius capitis muscle elevated inferiorly. Under this muscle, longissimus capitis muscle was exposed. This is the intermuscular layer of the occipital artery. Here you can see occipital artery is running under the longissimus capitis muscle. Longissimus capitis muscle was elevated inferiorly, and this is the digastric muscle, posterior belly of digastric muscle. This is the semispinalis capitis muscle, elevated medially. At this third layer, the suboccipital triangle is exposed. In this triangle, vertebral artery will be harvested, secured. This is the superior capitis oblique muscle, dissected towards the C1. And this is the rectus capitis posterior major muscle. This is the vertebral venous plexus. And V3 portion of the vertebral artery is surrounded by this venous plexus. Extracranial vertebral artery was secured, then craniotomy was performed. And this is the hypoglossal canal. Then open the dura. Here you can see the posterior medullary segment of the pica was confirmed. And we know we have to sacrifice the pica, so at first, occipital artery to pica bypass was performed. Because of the muscle dissection, the operative field is shallow and wide, so it is very easy to do anastomosis. By fish mouth trimming, this is the heel side. And then do two sides. This is the stay suture. And doing bypass, the using of microscope by the foot pedal is very important. Highest magnification, tying the suture. Then again, highest magnification. Identify the inside of the vessel and intima to intima everting suture is essential. This is the last stitch. Stitch should be under the highest magnification. Bypass was finished and open the pica. Then go to laterally. This is aneurysm and proximal vertebral artery that temporarily occluded by the V3 portion. And distal to the aneurysm. Then neck clipping was performed. By this clipping, anterograde blood flow of the vertebral artery was secured, but sacrificed the pica. The pica was identified through the occipital artery pica bypass, and this is a post-operative CT angiogram. Now I will show you an illustration of the suboccipital muscle layer by layer dissection, illustrated by my colleague Dr. Cosmo Noda. Left side approach. At first, subcutaneous occipital artery and first layer was observed. Sternocleidomastoid muscle was elevated laterally and splenius capitis muscle inferiorly. And occipital artery was identified. Then longissimus capitis muscle elevated inferiorly, digastric muscle also. Then occipital artery was completely mobilized, semispinalis capitis medially, and then third layer was elevated. After that, craniotomy and expose the transverse sigmoid junction and hypoglossal canal. This is the transcondylar fossa approach. So we have to know the anatomy of those suboccipital muscles. This is the surgical microanatomy of occipital artery. As I showed you, the 66% of the occipital artery running medially to the longissimus capitis muscle, and 1/3 of cases the occipital artery running lateral to the longissimus capitis muscle. If you don't know about this surgical variation, you may tear the occipital artery. So we have to know the variation of the running course of the occipital artery. Then I'd like to talk about the surgical microanatomy of the posterior condylar emissary vein. I published this anatomic variation for operative neurosurgery. The posterior condylar emissary vein have many variations. At first, I'll show you this CT angiogram. The key of the transcondylar fossa approach is drilling the jugular tubercle. However, to drill the jugular tubercle, the posterior condylar emissary vein is dealing with posterior condylar emissary vein is essential. Like this. The posterior condylar emissary vein has some anatomic variation. This is a posterior condylar emissary vein originated from the jugular valve and originate from sigmoid sinus, originate from occipital sinus, and anterior condylar emissary vein, and marginal sinus. Posterior condylar emissary vein has many variations. The majority of cases are jugular valve or sigmoid sinus origination, but rarely occipital sinus, anterior condylar, or 1% of cases originated both marginal sinus and jugular valve, anterior condylar emissary vein and jugular valve, or occipital sinus and jugular valve. Now I will show you a video. Left side, this is the jugular valve originated type, left side approach. This is the vertebral venous plexus towards to the posterior condylar emissary vein. The drilling was performed, and this is the posterior condylar emissary canal. Gradually drilled and exposed the canal. And this is the posterior condylar emissary vein, coagulated by the bipolar, and then cut. And posterior condylar emissary vein dissected through the jugular valve like this. After that, we can drill the jugular tubercle and expose the hypoglossal canal. This is the marginal sinus. And hypoglossal canal. Then this is originate from the anterior condylar emissary vein, right side approach. The posterior, in this case, posterior condylar emissary vein was very small. You can see the posterior condylar emissary vein gradually.
The marginal sinus is very small posterior condylar emissary vein.
Open the vein.
Here the posterior condylar emissary canal.
The vein was leads to hemostasis, and drilling was continued. Because this posterior condylar emissary vein is not hypoglossal canal, anterior condylar emissary vein, so this is relatively easy to perform jugular tubercle drilling. This is the hypoglossal canal.
You have to understand the anatomy. This blue line is of occipital condylar.
Now this case is originate from the jugular valve and marginal sinus branching in the occipital bone. Left side approach. Doing the occipital bone. Here you can see the posterior condylar emissary vein was exposed gradually. This is the bifurcation in the occipital bone. I tried to coagulate by the bipolar, but could not because this is a bifurcation. Bleeding come at first using a bone wax, then drilling medially, This is posterior condylar emissary vein originated from the marginal sinus. Like this. For this branch, I use the bone wax, then go to laterally. This is another branch originated from the jugular valve. For this posterior condylar emissary vein, we do not have to use bone wax because bone wax may occlude the sigmoid sinus. Then I'll talk about the surgical outcome for vertebral artery aneurysms. During these 10 years, we performed transcondylar fossa approach for 84 cases, female for 52% and male for 47%. Mean aneurysm size was 10.8 millimeter. We treated little bit large aneurysms. About aneurysm location, vertebral artery pica aneurysm was observed in 46% and dissecting or fusiform aneurysm for 45%. Low flow bypass was performed 31 cases, and right column, the neck clipping was performed 39%, and proximal occlusion and trapping was performed 26 and 33% respectively. This is post-operative outcome and complications 3 months after operation. This is the details of the complications about lower cranial function, auditory disturbance, hoarseness, dysphagia were observed in 7%, 19%, and 18% respectively. The post-operative modified Rankin scale score was like this. The good outcome was observed in 79%. At last, I'd like to show you a surgical strategy and treatment of complex vertebral artery aneurysms. I published radical treatment for bilateral vertebral artery dissecting aneurysm surgical strategy. The key is treating bilateral vertebral artery dissecting aneurysm is that the surgery of first side is important. If trapping is performed for first side, hemodynamic stress of contralateral side will be increased and aneurysm will be enlarged. At this time, trapping of vertebral artery cannot be feasible, so reconstruction of vertebral artery of first side is important if possible. This is a good example. 25-year-old male with thrombosed large vertebral artery fusiform aneurysm. Here you can see the bilateral vertebral artery aneurysm and the vertebral arteries deviated to the left side. So we decided to treat left side first. Although the right side is a bit larger, we decided to treat left side first. Left side approach after muscle dissection and occipital artery harvesting, craniotomy was performed, and transcondylar fossa approach. Aneurysm was identified at first. Occipital artery pica bypass was performed. Here you can see this is the distal V4, and anterior spinal artery was observed. And under the hypoglossal nerve, proximal VA was identified. Then trapped the aneurysm and cut, and internal decompression was performed. After removing aneurysm, there is enough space to anastomose. The radial artery graft was harvested and end-to-end anastomosis was performed. And this is V3 to RA radial artery graft bypass. At this time, vertebral artery was reconstructed, and another day, the right side vertebral artery was occluded by just proximal clipping. This is the first operation. Left side aneurysm was trapped and dissected, and vertebral artery V3 and radial artery graft V4 bypass and occipital artery pica bypass was performed, and CTA shows a good filling of reconstructed vertebral artery. And this is the second session, just proximal occlusion for the right side. Now this is 8 years after surgery. The patient is still modified ranking scale 0. And this is another case, 42-year-old male, contralateral enlargement after parent artery coiling for ruptured left vertebral artery dissecting aneurysm. Because rupture case, the left side was occluded by coil, and gradually right side vertebral artery aneurysm was enlarged. So we decided to do a radial artery graft, high flow bypass, V3 radial artery graft, P2 bypass, and trapping, like this. This is another case, contralateral approach for thrombosed giant aneurysm. Here you can see this is the aneurysm of the right side, but the distal to the aneurysm V4 is deviated to the left side. So we decided to do a left side approach with bilateral V3 securing. The patient position is a park bench position, but skin incision extended across the midline like this. Then I'll show you a video. This is a rectus capitis posterior minor muscle, and this is a midline. This is a rectus capitis posterior minor muscle of the right side. Then this is the vertebral artery of the right side. And here you can see this is the vertebral artery of the left side. At this time, bilateral V3 was exposed. Then dura was opened. This is the medulla. At first, proximal temporary clipping was performed. Then identify distally under the left side vertebral artery. Here you can see the contralateral lateral V3. At this time, aneurysm was trapped. And doing internal decompression by the suction and decompression. After internal decompression, proximal vertebral artery was secured and proximal clipping was then performed, removing the needle and identify the inside. After removing thrombus, blood flow came. So then identified again. Here you can see the small vessel toward to the medulla oblongata. So clip was changed to the more distally. hemorrhage was stopped. If we sacrifice this small artery, patient may suffer the Wallenberg syndrome. And the patient discharged with modified Rankin scale 0. And this is the problem. How to dealing with thrombosis aneurysm with mass effect. This is our regretful case, 71-year-old male, thrombosis giant and calcified vertebral artery aneurysm. And the patient showed progressing quadriparesis and dysphagia. Because we do not want to touch the medulla may worsen the neurological symptom, we just do trapping without internal decompression. However, after trapping the aneurysm, proximal clipping of the aneurysm, mass effect worsen, and patient neurological symptom of the quadriparesis, dysphagia worsen. Also, the patient had a Ondine curse and need a continuous ventilator, and he died 1 year after surgery. So we have to know that trapping without internal decompression may worsen the mass effect, and it will be a last push for the patient. So this is a 91-year-old woman showed progressing ataxia and need a wheelchair. But her cognitive function is very good, so we did careful informed consent and did a surgery. Left side thrombosis giant aneurysm. Here you can see the thrombosis giant aneurysm, compressed medulla. Left side approach. And open after jugular tobacco drilling, open the dura. This is the accessory nerve. (1911) complex, and this is the distal to the aneurysm. Fortunately, pica is originated distal to the aneurysm, and this is the proximal V4. The far lateral transcondylar fossa approach is very effective. Then aneurysm was trapped. The pica is a good feeling by the ICG video angiography. And then we perform thrombectomy. Inside the aneurysm, and removing the thrombus. The goal of this surgery is just internal decompression, not a complete removal of aneurysm. So careful removing of thrombus as much as possible was performed, like this. Aneurysm was well decompressed, and temporary clip was altered to the permanent clip. Like this. the patient awoke without no neurological deficit, and ataxia improved, and he can walk without assistance. The post-operative CTA is good, and now she still walk and live with her family. Now 2 years passed. This is the last case, 37-year-old male vertebral artery dissecting aneurysm. He came to our hospital with WFNS grade 5 and respiration nearly stopped, and his pupil is pinpoint. And CT shows a thick clot in premedullary, prepontine, and interpeduncular system, and the brain stem is compressed by subarachnoid clot. So we decided this is a grade 5. However, the brain stem is strong to the compress, so we decided to do a surgery. This is a thick clot compressed brain stem. This is a CT angiogram. The left side vertebral artery dissecting aneurysm. However, the vertebral artery is deviated to left side. So I decided to do a left side approach. This is a right side vertebral artery fusiform dissecting aneurysm, but I tried to do a left side approach. Now I'll show you a video again. This is a sternocleidomastoid muscle elevated to the laterally. And this is the splenius capitis muscle. And under the splenius capitis muscle, longissimus capitis muscle is exposed. This is the longissimus capitis muscle. Then occipital artery was harvested. This occipital artery was running medial to the longissimus capitis muscle. This is the semispinalis capitis. And this is the suboccipital triangle, superior capitis oblique muscle, elevated inferiorly. And this is the rectus capitis posterior major muscle. Here is asterion. Wide craniotomy, large craniotomy was performed across the midline. Transverse sigmoid junction was drilled. Because high cranial pressure, dura was distended, but the approach should be completed. This is a posterior condyle emissary vein and the canal. This is the hip of the sigmoid sinus. We cannot identify the hypoglossal canal because of the high cranial pressure. Dura was opened, just like an angry brain. However, we should know this is not a cerebral infarction or venous infarction, just due to a subarachnoid clot. So open the dura widely, open the cisterna magna and lateral medullary cistern, and removing the subarachnoid clot like this. Gradually, intracranial pressure reduced. Open the cisterna magna. Again, subarachnoid clot is removing. Then go to laterally to see the aneurysm. Subarachnoid clot is removing again and again. And here you can see the hypoglossal nerve and distal, and this is the rupture point. This is the aneurysm. This is the vertebral artery distal to the aneurysm dissection. During clot removing, the rupture happened, but enough approach will help us. Just point sucking and perform more proximal clipping. And distal clipping. Hemostasis was achieved and confirm the surrounding structure. Clip was placed more proximally. This is the rupture point. Breathing calm, because here the pica is included in the trapping. So pica is temporarily occluded, and again identify the rupture point. This is the orifice of pica. Rupture point was located just distal. So clip was applied just distal to the pica, like this. Hemostasis is achieved and the blood flow of the pica is good. And ICG shows a good filling of the pica by the anterograde blood flow. Dissection point is trapped. Then subarachnoid clot was removed again. This is a pre-medullary system. Go to cranial side. Pre-pontine system also. This is the sixth nerve. And to identify the foramen luschka and majandi, this is ICA, and this is the choroidal plexus. And opening of the foramen luschka is identified here like this. The CSF come. This is the foramen luschka. Then go to medullary. Because craniotomy was large and across the midline, here this is the foramen majandi, and here you can see the right side pica is also identified. So if we have to trap the pica, sacrifice the pica, we can use this posterior medullary segment to the bypass. We can do occipital artery to pica bypass here. And this is a post-operative CT. Upper is a pre and lower is a post-operative CT. The pre-medullary and pre-pontine system is decompressed, and the patient recovered well, and he will be socially rehabilitated. Finally, I'd like to talk about a wound closure. And this is a dissecting aneurysm case. The dura was closed, and mastoid air cell, sometimes opened, is packing by the fat graft, and using a fibrin glue and pack. After that, bone flap was applied, and suboccipital muscles should be reconstructed as it were. This is a semispinalis capitis muscle. The occipital muscle is very important to reconstruct the suboccipital muscles. These semispinalis capitis, splenius capitis, and sternocleidomastoid muscle should be sutured with occipital muscle like this. This is the splenius capitis muscle, also sutured by the occipital muscle. Like this. This is the sternocleidomastoid muscle, also anastomosed to the occipital muscle. This is very important to prevent the muscle atrophy, and we do not cut the muscle fiber. The post-operative wound pain is very rare. This is the 3 months after operation. Left is a surgical side, and right side is a non-surgical side. Here you can see there is no atrophy. This is take-home message. Transcondylar fossa approach is useful for vertebral artery aneurysms. To achieve complete operative field of transcondylar fossa approach, understanding of surgical microanatomy of suboccipital muscles, running course of occipital artery, posterior condylar emissary vein, and skull base anatomy is important. Suboccipital muscle dissection is essential for making shallow and wide operative field, harvesting occipital artery, reducing post-operative wound pain, and minimizing muscle atrophy. When treat thrombosed giant aneurysm with muscle effect, trapping and internal decompression should be considered. If you have interested in our work, we have a clinical observationship program, so please contact. Thank you for attention.
My name is Yoshimasa Niya. I am working in Otaru General Hospital as a neurosurgeon. My subspecialty is surgery for cerebrovascular disease. Otaru is a port town near Sapporo, northern part of Japan. We have 7 neurosurgeons and 7 operating rooms, including hybrid operating room, 2 MRIs, and 2 CT scans. We hope you young neurosurgeons not only learn about some useful tricks in cerebral aneurysm surgery, but also have any interest in its tricks or artistic aspects of its technique, if possible. In this lecture, I would like to talk about various strategies for cerebral aneurysm decompression. Aneurysm deflation is very effective in surgery for large aneurysms. There are several methods for aneurysm deflation. Transient parent artery occlusion, including temporary clipping, is the most common method for aneurysm deflation. We are using adenosine-induced transient cardiac arrest as an alternative method. Rapid pacing using extracorporeal pacemaker is also a good alternative method. Of course, prolonged parent artery occlusion may need bypass surgery. In this study, we describe our strategies for large aneurysms. We have over 500 cases with cerebral aneurysm who had been performed craniotomy. At first, temporary clipping. This is the most simple and common procedure. This patient had diffuse SAH and huge ICH in the left temporal lobe. 3D CTA showed large left MCA aneurysm. Left front temporal craniotomy was performed. The aneurysm was partially exposed. Minor leak from aneurysm was observed. So we apply a temporary clip at M1. Remarkable softening of the aneurysm makes some space around the aneurysm. So we can place a permanent clip in the aneurysm neck. Postoperative 3D CTA demonstrated complete clipping of the aneurysm. Next case has ruptured left ICA large aneurysm with small ACA aneurysm. The left ICA with severe atherosclerotic change and the aneurysm was exposed via distal transsylvian approach. Cervical ICA was exposed for cross-clamping and cannulation to superior thyroid artery for suction decompression. The aneurysm was shrunk by suction from cannulation. We could complete the clip application. Next, adenosine-induced transient cardiac arrest. Adenosine is a prenucleoside that suppresses atrioventricular conduction. It is used to treat arrhythmia such as supraventricular tachycardia. Its half-life is about 3 seconds. Bolus intravenous injection of adenosine provokes brief cardiac arrest, and it causes aneurysm decompression. This is a representative case. This patient had a large left MCA aneurysm. MEP electrode is placed after craniotomy. The aneurysm and the parent artery is exposed, but the vein and perforating artery is in the M1, so we avoid temporary clipping. The adenosine is administered. Then the pulsation stops and followed by a marked softening of the aneurysm dome, so we can place the straight clip like this. To avoid the parent artery temporary occlusion, adenosine use is very effective. Additional clip was placed, and intraoperative ICG angiogram shows complete clipping of the aneurysm like this. Postoperative 3D CTA showed complete clipping of the aneurysm. This case had ruptured right MCA large aneurysm. After opening the right Sylvian fissure, the aneurysm is exposed, and bolus injection of adenosine causes cardiac arrest. So remarkable softening of the aneurysm is observed like this. So we can place a straight clip securing the opposite side of the aneurysm and both M2. The pulsation returned spontaneously, as indicated in the ECG. Postoperative 3D CTA shows well-clipped aneurysm. Next patient had a middle-sized left ICPC unruptured aneurysm. The aneurysm located in very low position and adhered to oculomotor nerve and skull base. Complete exposure of the aneurysm is hard. But atherosclerosis in the ICA is severe, which made it difficult putting temporary clip. Only the orifice of the PCOM and the aneurysm neck was made free. In this movie, ECG is not shown, but the pulsation disappeared after bolus injection of adenosine. Then the aneurysm became soft. Straight clip was applied like this, avoiding the origin of the PCOM. Postoperative 3D CTA shows complete clipping of the aneurysm. This case has severe SAH with subdural hematoma and intracerebral hematoma. Three-D CTA showed large right MCA aneurysm. The patient showed rapidly exaggerating neurological symptoms. Bleeding from premature rupture of the aneurysm continued from the point of dural opening. Bleeding obscured the operating field, so adenosine is administered. After the cardiac arrest, the bleeding decreased. So we can place the temporary clip in M1. After that, marked softening of the aneurysm dome is accomplished. So we can place the straight clip like this. Adenosine is very effective to control the bleeding. Postoperative 3D CTA shows complete clipping of the aneurysm. This is a summary of the cases. Until now, we have used this technique in 62 cases. Adenosine is used in any aneurysm, regardless of its location. Mean aneurysm size was around 10 mm. Mean adenosine dose is 60 mg and mean arrest duration was about 18 seconds. Multiple adenosine use in one operation was observed in 11 cases. In this table, adenosine use cases were plotted. The longitudinal axis shows dome-neck ratio, and the transverse axis means maximum aneurysm diameter. Adenosine tends to be used in small but wide neck aneurysms or slightly large aneurysms. Regular-sized narrow neck aneurysms can be clipped directly as shown in upper left area in the table. However, we need temporary clipping in large-sized aneurysms as shown in right side of the table, because you need longer deflation time. Adenosine-induced cardiac arrest is useful in between them. It is said that 0.4 mg per kilogram adenosine bolus injection causes around 10 seconds flow arrest. This table describes dose and arrest duration relationship, which shows poor linearity. There are several reports, including ours, about adenosine use in cerebral vascular surgery. In brief conclusion, the limitation of adenosine-induced cardiac arrest is the difficulty in precise arrest duration control. There is another method to control the cardiac output: rapid ventricular pacing. Rapid ventricular pacing up to 200 beats per minute leads ventricular contraction without ventricular filling and results in cardiac flow arrest. Pacing lead is placed by cardiologist after general anesthesia induction. It takes only a few minutes, but a little invasive procedure. Test pacing was performed. The green line shows ECG, and the red line indicates arterial blood pressure. As the pacing rate elevated, the arterial pressure decreased, and finally the red line flattened, and it means cardiac flow arrest. Of course, pulsation returns immediately just after stopping the pacing, so you can control the arrest duration at will. But it is better to be limited within several 10 minutes at most to avoid whole brain ischemia. This patient had ruptured broad neck aneurysm in vaginal tip. The vaginal artery and vaginal top aneurysm was exposed by a right front temporal craniotomy. Preparing the clip and asked the anesthesiologist rapid pacing. As pacing rate elevated, cardiac output decreased and finally disappeared. So I placed the clip like this, and the normal heartbeat returned when pacing was stopped spontaneously. Postoperative 3D CTA demonstrated complete clipping of the aneurysm. There are some reports about rapid ventricular pacing for cerebrovascular surgery. Adenosine-induced cardiac flow arrest is a relatively simple procedure, but precise duration control is impossible. In patients with asthma and severe IHD, adenosine use is contraindication. Otherwise, rapid ventricular pacing can accomplish perfect duration control, but slightly invasive procedure because it needs pacing lead placement. In case with permanent parent artery occlusion, bypass surgery will be needed. This is a patient with unruptured right ICA cavernous portion aneurysm. In this case, aneurysm trapping is appropriate treatment. We perform right EC radial artery M2 bypass and trapping of the aneurysm. The aneurysm is obliterated by this operation. This patient had a ruptured giant ICPC aneurysm. In this rare case, we used extracorporeal technique. STA-free graft was made end-to-side anastomosis to M2 portion, and arterial blood from brachial artery was sent through the roller pump, as indicated in the figure. By this technique, you can avoid the invasion of permanent high-flow bypass. This technique is better than permanent high-flow bypass for the patients who does not need permanent bypass, because it is less invasive. In other words, this is a temporary use of high-flow bypass. The patient was placed on the operating table in a supine position. For French cannulation was placed in the left brachial artery for arterial blood supply of the extracorporeal circulation. Preparation of right radial artery for permanent bypass if the parent artery was to be sacrificed. But in this case, this is just a preparation. After right front temporal craniotomy with harvesting the STA-free graft, STA-MCA and two-side anastomosis was made. Back flow is good. Then the extracorporeal circulation begins. This is the roller pump. Then the carotid artery was cross-clamped under circulation. The flow rate was controlled around 100 mm per minute to maintain near-infrared spectroscopy value before the occlusion. Multiple clipping was done under 50 minutes temporal ICA occlusion. Intraoperative ICG angiography shows good patency of parent artery and complete obliteration of the aneurysm. Postoperative 3D CTA shows well-clipped aneurysm and good patency of the right ICA. No cerebral ischemia lesion was observed. We have used this extracorporeal circulation technique in 4 cases and got good outcome in all cases. This is a key slide of this lecture. If you choose permanent parentally occlusion, permanent bypass will be needed. If you need over 10 minutes aneurysm deflation, you had better consider bypass surgery. If you need several minutes of temporary occlusion, temporary clipping will be needed. If you want several 10 seconds of deflation, adenosine use or rapid ventricular pacing will be good choice. In conclusion, brief deflation with adenosine injection or rapid pacing facilitated the aneurysm surgery. Bypass surgery is effective in prolonged parent artery occlusion. Thank you for your attention.
Ladies and gentlemen, I'm Dr. Simva P.C. Shi from Taipei Veteran General Hospital. First, I would like to thank Professor Yoko Kato who invited me to this great educational program at WNS-CNS. This is Taipei Veteran General Hospital, and we have more than 200 beds in our department. And actually, I have done fellowship at UMS Little Rock in the States between 2007 and 2009. At that time, I had 3 great mentors in the world. As you have known, that Professor Yasaki, Professor Mafti, and Professor Krish. I learned all these microsurgical concepts and techniques from them, and also from their friends, Professor Johan, Professor De Oliveira, and Professor Dolenk. And as you know, the cavernous sinus was deemed as the nomen Israel because its complex anatomy is a complex venous channel by the side of the cellar and paracellar region. But with increasing knowledge of the anatomy and improving microsurgical techniques, people nowadays can do surgery in and around the cavernous sinus, especially we follow the pioneer work of the Professor Dolenk. But the most important is how you can apply your anatomy to your daily routine, because the anatomy is not the terms that you have to memorize. It's the term that you have to use to as a guide in your daily surgical surgery. I did pretemporal approach as my teacher, Dr. Chris, did. We using the pretemporal is a little bit different from the tyranno approach. In this approach, you need to lower the temporalis muscle down to the zygomatic notch to expose more of the space in the pretemporal region. And sometimes you have to cut the zygoma so that you can lower the temporalis muscle further to expose the temporal base. And as you know, the lateral wall of the cavernous sinus has a double layers of dura. The temporal dura is attached to the wall of the cavernous sinus by two bands of the artery. The first one is meningo-orbital artery within the dura fold, close to the cerebral-orbital fissure. So the first step to expose the cavernous sinus is to identify this dura fold, coagulate it, and divide it. So you can expose the region down the cerebral-orbital fissure. Then you can find the dura groove between these two layers of dura, and using a sharp dissection to make a cleavage plane between these two layers of dura beneath the cerebral fissure. So as this picture show, I'm using the sharp dissection to find the cleavage plane, and I keep this cleavage plane using the blunt dissection to push the dura backward until you expose the anterior clinoid, trochlear nerve, and first and second division of the trigeminal nerve. If needed, if you want to expose the whole lateral wall of the cavernous sinus, then you turn your microscope to the middle meningeal artery. This is the second attachment of the temporal dura to the cavernous sinus. So you have to identify the foramen spinosum, and you have to dissect the middle meningeal artery. Then you continue the peeling of the dura backward to expose the third branch of the trigeminal, and also you have to follow the direction of the GSPN from anteriorly to posteriorly until you expose the so-called anterior petrous region, so-called Kawase triangle or Kawase rhomboid. So in this way, you can do the extradural exposure of the lateral wall of the cavernous sinus. You can see the anterior clinoid, cerebral-orbital fissure, trochlear nerve, V1, V2, V3, and Gasserian ganglion and macroscaphe, and the anterior petrous region. And since you already make a big space outside the dura, so you cannot do the dura opening as usual, like a dura flap. Then in this way, you will lose the space outside the dura. So it's obviously you have to cut the dura along the lateral, along the silvian fissure, then down to the base, then extend the incision bilaterally towards the optic nerve and oculomotor nerve. So in this way, you can expose widely of the cavernous sinus wall along with the intradural space. So you can see all these nerve and vessel structures in and outside the dura. So in the past 10 years, I get my experience about the cavernous sinus surgery. So based on the anatomy of the cavernous sinus, you have to know some key landmarks. For example, in dura structure, you have to know how to deal with the inner ring, outer ring, tendorium. To deal with the bone landmark, you have to do the anterior clinoidectomy. You have to know how to remove the anterior petrous. And of course, you have to know all these important neurovascular structure penetrating the dura into the cavernous sinus. And this is very important to free all these nerve neurovascular structure at the beginning of the surgery. If you had the basic techniques, for example, you know how to peeling the dura off the cavernous sinus, if you know how to do the anterior clinodectomy, if you know how to remove the rings, then you can do the basic approach to the cavernous sinus to deal with some simple pathologies. And gathering your experience and improving your microsurgical techniques, then you can do more extended approach, like a transcavernous approach within the cavernous sinus, or you can divide the tendon or open the Mako's cave, or you can do combine with Kawase triangle removal to expose and lock the whole area surrounding the petroclival region. So this slide shows different pathologies, including tumors or vascular lesions in or surrounding the cavernous sinus, and you can use in different approach. And actually, it's all based on the anatomy of the cavernous sinus. And I suggest the people that when they do the cavernous sinus, you are better starting with a simple level. So I classify the learning curve of the cavernous sinus surgery into 4 levels. For beginners, you're at level 1. Then you have to do the tuberculin sella, sphenoid meningioma, of course, the Simpson grade 1 resection, or you can do the ophthalmic apical aneurysm. And gathering your experience, then you can do more complex pathologies. And to the upmost level, at level 4, and you can do the petroclival meningioma or the cavernous sinus meningioma. Today, I would like to talk about a symptomatic intracavernous aneurysm is around the level 2 and level 3. Because at each level, you have be equipped with some special techniques. And for the intracavernous aneurysm, you not only you have to do the extradural peeling, anterior clinodectomy, removing the outer ring, but also you have to know how to open the Parkinson triangle to free the oculomotor nerve and tracheal nerve totally and from the aneurysm and the wall of cavernous sinus. So each level has a specific area that you can deal with. For example, the basic approach at level 1 and level 2, the pathology surrounding the crinoid, usually the surrounding like a paraclinial aneurysm or the apical aneurysm or the spinal ridge meningioma. But if you have experience about the level 2 or level 3, then you can deal with some trigeminal schwannoma because you already know to open the Mako's cave. And if you're level 4, you can totally unlock the petroclival region so that you can do the petroclival meningioma. But I have to emphasize again that all the nerve and vessels that penetrating the dura into the cavernous sinus, they are always the ring-like structure, forming the ring-like structure surrounding this neurovascular. So this is the intra-op photo. For example, the optic nerve, they're forming the phosphor ligament surrounding the optic nerve. They're forming the outer ring surrounding the carotid nerve. And also you have the oculomotor triangle. They are all ring-like structures surround these vessels or nerves. Then you have to free all these neurovascular structures from this ring-like dura. So you can mobilize or you can pull this nerve to increasing the window between these structures, and also you can minimize the traction injury to this nerve. So this is very important concept and techniques when you do the cavernous sinus surgery. So I would like to show some cases to show how I open the cavernous sinus safely and to successfully to deal with this intracavernous aneurysm. This is the first case. The patient presented with a right eye ptosis, and also it's my first case when I do the intracavernous aneurysm. So the video shows I already removed the anterior clinoid. Now I try to dissect the outer ring of the carotid artery. So I cut the outer ring along the carotid artery and towards the medial aspect of the carotid towards the optic strut, because outer ring is attached to the strut and just proximal to the takeoff of the ophthalmic artery. So you have to be careful not to cut the ophthalmic artery. Then I continue the dissection of the ring of the carotid in its lateral and in ventral side. And in this aspect, the inner membrane surrounding the oculomotor is fused, is continuous with the outer ring. So I open the inner membrane, I cut the inner membrane, and also remove the ring and the membrane of the oculomotor nerve. So I follow the direction of the oculomotor nerve to cut the ring. And I already see some part, the distal part of the aneurysm torn down the carotid. I try to widely open the space proximal to the inner membrane, so I cut the ring and try to push the oculomotor a little bit. So in this way, you can free the optic nerve from the ring structure. You can push the optic carotid. Carotid. Push the carotid upward. So now you can see the distal neck of the aneurysm, and it's oozing from the cavernous sinus, so you can inject the TCO. So I push a little bit of oculomotor nerve so I can see the aneurysm, almost part of the aneurysm, and I can dissect the aneurysm of the so-called carotid cave, the space in the carotid cave. Now I can put a pilot clip to shrink the aneurysm to facilitate the inspection into the space proximal to the aneurysm. So I push a little bit down the aneurysm so I can see the proximal side very well. And I dissect the aneurysm totally off the base, the skull base. So that I can put a final clip to obliterate the aneurysm. So in this case, as you can see, I try to remove the inner membrane and outer ring so that I can mobilize the carotid and the oculomotor nerve a little bit to widen the space in this clinal region so that I can have a good inspection to the aneurysm. But since this is my first case, at that time I have no experience, so limited experience, so I didn't open the Parkinson triangle to get a proximal control. But it is very dangerous, especially for the ruptured aneurysm. And this is both a photo, and the patient is actually doing very well. And this is the second case I had for the symptomatic intracavernous aneurysm. This aneurysm is larger than the first one. So in this case, I have to open the Parkinson triangle. As you see, I already removed the ACP, and this aneurysm is large and push the oculomotor and trochlear upward. And I open the Parkinson triangle to localize the carotid. Now I feel confident because I have the proximal control already at hand. And now I try to remove the tissue, the ring-like structure of the carotid. I put a proximal control and I put a pilot clip on the aneurysm. And I try to shrink the aneurysm by coagulation, but I cause premature rupture. But since I had the proximal control, I put a temporary clip, then I control the situation, and I put a clip to stop the bleeding. Now I open the dura, and to cut the outer ring of the carotid, so I get a bigger space to have a good view to the aneurysm, and I can put a final clip. So in this case, I got improved because I know how to open the Parkinson triangle to find the proximal control. But in this case, I didn't open the dura at the beginning because I'm still afraid if the aneurysm rupture causing massive bleeding, then it will cause the intradura hemorrhage. But since you didn't open the dura at the beginning, so the space is limited, maybe you still chance to cause the traction-related injury to the nerve. But this is both a photo, and actually the patient is doing very well.
你眼睛往
妹妹，俄语站。
往右边，右边，往左边，往下面。
So this is the third case, also the large and complex intracavernous aneurysm causing the symptom of the ptosis. In this case, as I mentioned, I drilled the spinal ridge, spinal wing, and exposed the lateral wall, orbital wall to expose the superior orbital fissure. Then I found the dura groove. I coagulate the groove and divide and cut the groove, as well as the meningo-orbital artery. And I found the dura groove beneath the superior orbital fissure between the double layers of dura. I using the sharp dissection to find the cleavage plane. And I keep the dissection, keep within the plane to expose the V1 tragus nerve and down to the tip of the ACP, anterior clinoid. So as you can see, I already see the tragus nerve and V1 is bulging by the aneurysm. You can see this bulging part is the aneurysm. Is the tragus nerve, the V1 is overlying the aneurysm door. So I continue the peeling of the dura down backward and expose the V2, V1, tragus nerve, and this is Gasserian ganglion. Then I remove the ACP. I already detached the ACP from the spinal ring at the beginning when I removed the lateral wall. Now I detach the ACP from the optic canal. Then it becomes mobilized because usually the optic strut is fragile. I can easily fracture the ACP, remove the ACP by small bone rongeur, and expose the clinoid portion, the carotid. Now I cut the dura down to the base and extend the incision toward the optic nerve to expose the carotid of the optic nerve. And I open the inner membrane. Now I can see the distal neck of the aneurysm. I open the inner membrane and the distal part of the aneurysm is exposed. And I continue to cut the outer ring along the inner membrane toward the oculomotor triangle. You can see the aneurysm here. And I free the carotid. Now I have to free the oculomotor nerve from this ring structure. As you can see, this is intradural oculomotor nerve. I cut the ring-like structure. I open the oculomotor triangle, and I free the oculomotor nerve. And you can alternatively using the sharp dissection by knife and scissor. And I free the trochlear nerve towards the edge of the tentorium. And I open the Parkinson triangle between the trochlear nerve and V1. I open the Parkinson and localize the carotid artery in the proximal segment. So now I have the proximal control. And I free you can see the trochlear nerve is crossing over the oculomotor nerve. So I can open the window between the trochlear nerve and the oculomotor nerve. It's just overlying draping over the aneurysm door, so you have to be very careful. So I free the trochlear nerve and also free the oculomotor nerve, so I can mobilize the nerve and free from the aneurysm. As you can see, I dissect the oculomotor nerve off the aneurysm door. So now the aneurysm, you have a very good view to the aneurysm, and also I free the oculomotor down to the SC zone from the brainstem. So the nerve is like a string of the guitar. So you loosen the string. Then when you play the guitar, you won't cause the string, tear the string. And you can put the pilot clip on the aneurysm to facilitate the dissect of the aneurysm of this nerve structure. And you can free the aneurysm from these structures, from the ventral side of this structure. And you can have a very good inspection to the proximal part of the aneurysm to localize the proximal neck of the aneurysm. Then you can put the final clip to shaping the aneurysm to catch the whole length of the aneurysm. So you can see all the nerves overlying the aneurysm are slack because I free all the nerves from the aneurysm and all the anchoring point by the dura structure. So in this way, this is post-op photo. The aneurysm is totally obliterated, and the patient is actually doing very well.
眼睛往上看，往右边，往左边，往下面，所以看起来。
And this is a similar case, but it's on the left side. I found the dura fold, cut the meningorbital artery. Then I remove the spinal ridge to expose the suborbital fissure. I open the suborbital fissure to find the dura group beneath the fissure, and I'm using the sharp dissection to find the cleavage plane. Then I push the dura backward to expose the V1, V2, and the trochlear nerve. In this case, you already see the aneurysms here, and the trochlear nerve and V1 is bulging. So I continue to push the dura and using the TCO to stop the bleeding, and continue dissection to expose the anterior wall or the cavernous sinus. And I remove the ACP, skeletonizing the optic canal, and make the ACP eggshell paper thin. Then I dissect the ACP and is easily detached from the optic strut. And I remove the optic strut to facilitate the exposure of the clinoid carotid. I open the inner membrane and inject the TCO to stop bleeding. Then I cut the dura in the inverted T shape. And you can see all the structure in and outside the dura. I free the optic nerve first and cut the outer ring surrounding the carotid. And along the inner membrane, try to free the oculomotor nerve. And I open the Parkinson triangle. So I found the proximal carotid to have the proximal control. So I can see very well the oculomotor and the trochlear draping over the aneurysm here. Here's the aneurysm. So I remove this tissue off the neurovascular structures and free them from the dome of the aneurysm. Like I showed in the third case. So I totally free the oculomotor nerve, as you can see, and almost down to the entry zone, and widen the space between the trochlear and oculomotor, and widely the space between in the Parkinson triangle. So you can see I free them, all of them, from the aneurysm dome, and I can find the proximal neck of the aneurysm. I put the proximal control, then I can put a pilot clip, a distal control, and put a pilot clip and a permanent clip. So it's the similar techniques when I use the opening the cavernous sinus to deal with such a complex intracavernous aneurysm. And this is post-op picture, and the patient is doing very well.
好，这所以你是眼睛往上看，眼球往上看，眼球往右、往左、往下。
And actually, since September, we have done the program, including the lectures and cover dissection, and hosted by Club Academy, to show how we do the cavernous sinus approach from microscopic and endoscopic way. So you are welcome to log in this program, and actually we have finished the episode 1 and 2. And next January will be the episode 3, the advanced cavernous sinus approach. So all of you are welcome. And today I simply introduce some important concepts and techniques to safely widen the cavernous sinus. And I have to emphasize again that all these nerve and vessel structure, when they penetrating the dura into the cavernous sinus, there will be a ring-like structure anchoring this structure to the cavernous sinus. You need to free them at the beginning of the surgery to widen the space or this window between these structures and minimize the traction-related injury to these nerves. So you will make the cavernous sinus surgery safe with the minimal post-op neurologic deficit. And thank you very much. And thank you again for Professor Yoko Kato inviting me to this great educational program. Thank you very much.
Hi everyone, I'm Dr. Lee from Taiwan. It's a great honor to give this speech in WFNS Autumn Seminar. And today my topic is Modified Endoscopic MIST approach for evacuation of hypertensive intracerebral hemorrhage with modern techniques. The outline is Introduction, Material Method, Surgical Technique, and Case Sharing, Results, and conclusion. We all know that stroke around the world has geographic variations, especially in Asia, In Taiwan, our country, the ischemic stroke accounts for 71% of all stroke events, and most of them, around 40%, are associated with small vessel disease. Another 28% is hemorrhagic stroke. For ischemic stroke, we all know that we have a very modern device, the thrombectomy device, to improve the patient outcome and their neurologic status. And for intracerebral hemorrhage, we all know that it affects more than 2 million people per year. And compared with traditional craniotomy, the minimally invasive interventions for ICH evacuation reduce surrounding brain damage, shorten operation time, hospital stay, and of course infection rates, and it also improved functional outcome. So for hemorrhagic stroke, we have the most popular MISTY-3 randomized trial, which was published in Lancet Neurology, and the surgical performance regarding the MISTY procedure published in Neurosurgery a few years ago. And their enroll criteria is spontaneous ICH, volume more than 30 cc, age older than 18, coma scale less than 14. The pre-bleeding MRs was limited to 0 and 1, which means a relatively better neurologic status before the operation. Normal coagulation test was necessary. Vascular lesion was excluded by CT scan before the operation. They enrolled total 250 cases in MISTY group, 249 cases in the control group. In summary, they did a small burr hole and aspirate the hematoma with navigation guidance. In the end of the procedure, they insert an EVD into the surgical cavity. They arrange postoperative CT immediately to confirm if there is any residual hematoma and the EVD position. If the position is secured, they started to inject etoprest, which is a thrombolytic agent, every 8 hours for 3 days. You can see the good outcome is associated with more than 70% of the hematoma was evacuated, and less than 15 cc of the residual hematoma detected on postoperative CT scan. However, the flaws and the weakness in this study is that because of their limited surgical wound, it's difficult to control the breather. And also because the limited surgical field, and if the blood clot is relatively hard, it's difficult to remove. So the evacuation rate in their study is relatively low. And they injected postoperative thrombolytic agent into the surgical cavity, so the post-op thrombolysis-related hemorrhage is relatively high. And how about brain pass and endoprocistern? It facilitated by manual approach, which is good for breather control. So their study achieved more than 90% of evacuation rate in 72% of patients. But we all know that it will need a larger craniotomy and will have more cortex destruction. And because the hematoma is located in a deeper location, so the light and the vision of the surgical field is also an issue. And could it be better? Is there any device that can provide a clear visualization with simultaneous suction and irrigation function, even with a flexible module to control and to make a more satisfactory breather control with minimal invasiveness and navigation function. Yes, we have ClearMind Axon Pen system, which was approved by FDA this year. It has three major components. The Axon Pen component, which is the most important part of the device, Axon monitor, and the ClearPath. Let's watch the introduction video.
Axon Pen system includes an Axon monitor, an Axon pen, and an Axon access kit, ClearPath. Axon Pen comes with 2 tubes and 1 signal cable, which is for connecting to the container, saline bag, and transmitting the video signal to Axon monitor respectively. Activate suction by pressing the blue button. An extension tube will stick out simultaneously and start the aspiration. If the tip gets jammed by a clot during aspiration, push down the blue button repeatedly so the clot can be teared off by the reciprocated movement of the extension tube. You can irrigate and rinse the camera lens by simply pushing down the white button. Hold Axon Pen with one hand and shift lever left or right with another to bend the sheath. Along with 30 degrees of flexion in both directions, Axon Pen allows you to navigate in the target area. ClearPath incorporates a see-through sheath with a graduation of 1 centimeter per grid. Once the ClearPath is located properly, peel the sheath and stick it on the scalp. Retract dilator. The pathway is then ready for surgery. Advance Axon Pen slowly in the sheath until it reaches the target.
So we started a clinical trial, an open-label, non-randomized single-arm pilot study in Taiwan since last year. Our inclusion criteria is that also, of course, spontaneous ICH aged from 20 to 80, GCS from 6 to 14, and the volume ranged from 30 to 80 cc, and the surgery must be done less than 48 hours. The reason we chose 48 hours is that we know that early endoscopic intervention will promise a better outcome, and also after 48 hours, the blood clot may become hard, which is difficult to remove radically. Our exclusion criteria is that if the patient has coagulopathy, spot sign, or vascular lesion detected on preoperative CT scan were excluded. And if the patient has cancer, severe CAD history, or has active infection or pregnancy, were excluded as well. And if the patient underwent major surgery in the recent 2 weeks, was excluded. And if the patient has drug history of anticoagulation or antiplatelet drug, were excluded. So, since last year, we enrolled total 6 patients under strict assessment criteria. Our intra-op procedure is that we put the patient in a supine position with helping fixation. We prefer a linear wound near cochlear point under navigation guidance. We did a small craniotomy around 2.5 centimeter. Then we puncture a clear path to hematoma center under echo and navigation guidance. In the first case, we used echo for confirming the location, but we found with the aid of preoperative CT navigation, it is better for us to localize the hematoma and the longer axis for more radical hematoma evacuation. So we use CT guided navigation in the following cases. Besides, the clear path is very minimally invasive. However, in a situation that if the blood clot is harder than expected, or we need more space to control breather, we will use a Vicker for larger surgical space and surgical freedom to make sure that the patient is safe after our operation. And then we insert axon pen and use its irrigation and suction function to remove the clot. And then hemostasis was made. EVD insertion is optional based on surgeon preference. This is our linear one around the right cochlear point based on navigation guidance. And we did a 2.5 centimeter craniotomy, open the dura, insert a clear path, and please watch our demo.
收掉。
如果还可以的话，有那个
所以水有出来吗？有。
你现在还是有血水这样从后面往前流。应该是说气息到底放多深？对啊，你会不会担心就是不在那个姿势？我看里面都是刮痛，应该是还好。你黑色都是刮痛，就这样。我如果一直前进，刚刚 Brand 已经出现了，应该往右。对，已经 Brand 出现。所以基本上吸都是在 Q 里面出现，就是用水去冲，然后 Q 里面吸，这样比较不会吸到别的。在hematoma.
Can see the brain tissue and the quality of the surgical field is very good. Consistent. And we confirm with the echogram if there is any residual, and we found some residual around our surgical cavity. So we use some pen to remove the residual.
所以荧幕要防护装置，上面要做隐修。
The previous surgical cavity, and we confirm it again. And it did not reveal any sizable hematoma. Finally, we use flow seal for satisfactory analysis, close the dura and close the wound. And 6 hours after the operation, we will arrange CT scan. With this modified modern technique, in case 1, a 49-year-old male with right side weakness on March 11th, common scale was M5 with left side hemiplegia. CT scan showed a right putamen hemorrhage which dropped into ventricle. The hematoma size is around 67 cc. And 6 hours after the operation, CT scan showed a 3.75 cc of residual hematoma. The evacuation rate is as high as 94%. The preoperative CT showed 67 cc with dropped into ventricle. And in a CT scan, you can see there is no vascular lesion or spot sign on this study. And 6 hours after the operation, you can see around 3.75 cc of the residual hematoma. and the evacuation rate is around 94%. We insert two EVD. One is in the ventricle, the other is in the surgical cavity. This is the final CT scan of this patient. So, this is a summary of the patient history. You can see around 4 days after the operation, the patient's consciousness improved to M6, and around 1 week after the operation, his MS was 5, GOC score was 3, and the patient recovered day by day, and in around 1 month after the operation, his consciousness is full clear obey, and with MS score 4, GOC score 4, and in around 3 months after the operation, his MS is 4, GOC score is 4, and the left side muscle power improved to grade 2 to 3. The case 2 is a 44-year-old male with right side weakness on April 2nd. Coma scale was M6 with right side hemiplegia. CT scan showed a left peritoneal hemorrhage around 72 cc. 6 hours after the operation, CT scan showed around 8 cc of the residual hematoma. The evacuation rate is around 90%. You can see a 72 cc in preoperative CT scan, and also there is no vascular lesion or spot site based on CT scan. So 6 hours after the operation, the CT scan showed around 8 cc of the residual hematoma and 90% of the evacuation rate. This time we did not insert any EVD, and the patient recovered well as well. So the patient recovered very well in the following days, and in 1 month after the operation, the MS score was 5, GOC score was 3, and he also has full clear consciousness. And in around 2.5 months after the operation, his muscle power improved. Right upper limb improved to grade 1 to 2, right lower limb to grade 4, MRS score 3, GOC score 4. And the following are our results: the post-op events, post-op outcomes, and the functional outcomes. You can see our patient age ranged around 45 years old, and 4 of them are male patients. The preoperative ICH volume is around 50 cc, and the preoperative GCS score is around 9 score. The postoperative event, we can see the mortality rate is 0, rebreathing rate is 0, mobility rate is 0. And the postoperative outcome, we can see the ICH volume from preoperative 50 cc reduced to 5.5 cc immediately after the operation. And you can see after 3 days of the operation, the residual hematoma volume reduced further to 4.7 cc. And the GCS score from the preoperative 8.8 improved a lot 3 days after the operation to 12.2 scores. And how about the functional outcomes? We can see the MIS score improved from immediate post-operative 4.8 score to the day 40 to 4.0 scores, and the GOSC score improved from postoperative 3.2 to postoperative day 40 3.8. So our conclusion is that time is brand, and early endoscopic assisted surgery is associated with low rebreathing rate and improved functional outcome. Most importantly, minimally invasive procedure with modified modern techniques will promise a better outcome. And could it be better? Yes, we think we have many press to improve regarding the first generation Axon pen system. For example, the length of the cable wire and the length of the Axon pen. And for more satisfactory breeder control, we must adapt a more bipolar device to ensure a better hemostasis. There are so many press to improve, so we believe that the next generation Axon pen will be the best choice for spontaneous ICH in our patient. Thank you for your attention. Thank you.
Asian Congress of Neurosurgical Nurses (ACNN) was started in 2019 with the aim first to enable more neuro nurses from developing countries to participate in ACNN with a lower cost. Secondly, to educate to improve knowledge and skill of neuro nurses from developing countries on handling neuro patients. Third, to encourage more neuro nurses to participate in neuro nursing research and neuro nursing innovation. Last but not least, encourage networking among neuro nurses in the developing countries. This is the committee of ACNN with Professor Yoko Kato as a patron of ACNN. Our activities such as first ACNN was held in Indonesia, organized by Professor Eka on the 21st of August 2019, followed by second ACNN was held in Chennai, India on the 1st February 2020, organized by Professor Krish Sridhar. And the third, which is the first feature ACNN, also held in Chennai, India by Professor Krish Sridhar. And the fourth ACNN, which was the second feature ACNN, organized by Professor Krishna Sharma, Nepal, on the 5th and the 6th of August 2021. The next one will be March 2022 in Shanghai, China. The organizer will be Professor Bing Su. Hope there will be more participation from the nurses. Other activities such
Hello.
Yes, hello, Liu. Anything, Liu? Hi, Liu.
Hello, Sharon.
Yeah, hi. Can you hear me?
Yeah, I can hear you. Yeah. Yes. Yeah. Do we have a speaker? Do we have any speaker? Yes, I saw Professor Kimura is there.
Okay. Yeah, I saw you. Yeah, correct.
Yeah, I'm here.
Yeah,
Nice to see you.
Professor Kimura, thank you for nice lecture, Professor. I want to ask you one question, Professor.
Yeah, thank you. Nice to hear.
Yes,
Yeah.
for young neurosurgeon to do practice, what microscope can they use? Can they use the table microscope used by the microbiologists for practice?
Yeah, for practice. Yes. For practice, very important factor is to cheap and easy access to, you can training every day, that bypass training. Very important factor to improve your technique. Yes.
What microscope can be used, Professor? What your recommendation? Microscope.
Oh, microscope. On the table, you mean?
Yes.
Yeah, table. Yeah.
In my laboratory, we use our Japanese handmade microscope, but I think Leica may produce the similar table microscope for the training.
Liu, Kimura Sensei.
How are you? Hello. How are you?
I'll just show you one of the microscopes, which is called Al Micra microscope. That is good one, I think.
Yeah, really.
Yeah. It is very.
Yes, expensive, not.
Not so expensive. I'll just try to share it. I think that. Can you see this?
Yeah.
This is a very good and cheap also. Al Micra stereo zoom.
Attacking a microscope, look for the word up or an arrow which designates the top. Let's install the head. Screw the ocular viewing port cap.
Oh.
Then plug the power cord lights. The knob on the right. The calibrated knobs on either side of the head control the zoom from 0.7 times. Focus adjust. Ocular tube has a silver ring. The diopter must be set to just above that ring to maintain focus throughout the zoom range. To test the focus accuracy, focus on a test subject at low magnification, then move to the highest magnification to fine-tune the focus point. Now move through the zoom range, making minor adjustments to the diopters as needed until focus is relatively consistent. Field of view is a measurement of the sample area that is visible through the microscope. Your eyepieces will be marked with two numbers. The coin series head accepts a range of ball they attach to the head's threaded lens port.
So that is it. It's a very good microscope.
Yeah, yes. It seems like very nice microscope for training.
It costs around 30 to 40 Ks in Indian rupees.
30 to 40?
40K in Indian rupees.
Do you train the technique using this microscope in your lab?
No, actually, this was recommended by our former fellow, Dr. Sandeep. So it costs around 540 USDs. That is a great microscope to work with.
Yeah.
In our place, there is always one microscope free in the operation theater. So I use that, either Provido, Leica, or the Pentro 900. one of them I use.
A very good, nice idea. When I was a younger neurosurgeon, so I use in the directory, I return to the OR and training the using a surgical microscope, just without this like a table microscope. Yes, for younger neurosurgeon, every younger neurosurgeon can train by themselves, return to the OR suite, and using the actual operative microscope, you can train that on the operative table, just sitting. Yeah.
But that transition from practice to real is totally different. So we must practice as close as to the reality of the operating time. So that is why I use practice sessions in the operation theater. One very interesting article that popped up in the operative neurosurgery recently is the needle parking technique. Did you go through that? By Professor Tomohiro Inno actually is a proponent of that technique, the needle parking technique. Like you take the first stitch, okay, anchor stitch, then you take the second stitch and then you cut the first stitch and tie it. Then you take the third stitch and then you cut the second stitch. That is a very nice technique, actually. Easier.
Easier. Yeah, we need every kind of technique to improve our surgical skill. Yeah.
Yes.
Yeah. Anchoring is very nice. Yes. Yeah, I understand what you mean. Yes. Yes.
Right.
That's I know.
Most common error we make is the mismatch between the donor and arterial side. So, what are your tips regarding how do we do that? Because in your place, you always mark it with the ink, isn't it? The gentian violet ink.
Yes.
But many places, many places they do not have this. So, what are your tips regarding to avoid mismatch between donor and recipient arteries?
In my Japanese colleague as doing as well. So we usually the stitching needle inserting the stitches to the contralateral side of the wall of the donor artery was placed inside the lumen to prevent the misstitching. Can I make sense? So the donor artery and the recipient artery, the contralateral side of the donor artery was inserted inside the lumen to avoid the misstitching contralateral side of the wall.
Okay. So regarding in side to side anastomosis.
Side to side.
Yeah. So how do you take the inner wall? You take the stitches intraluminally or revert the stitch after anterior wall and put extra luminally. What is your technique?
You mean how can we take the intima?
No, I'm asking about the deeper wall. There are two walls, no? So once you anchor in side to side anastomosis, do you prefer to take the stitches intraluminally inside the vessel or outside the vessel? How do you prefer?
Yes. Inside intraluminal suturing technique is also important, especially inside in the deeper surgical field. So I use, but more importantly, more important. So the side-to-side anastomosis is needle insertion is not so far away from the cutting edge. Yeah, if you insert the needle, so like this is a side-to-side anastomosis. This is the final view, final anastomosis. So this lumen connect each other, and if you need to insert so far away from the cutting edge, so this is advantageous invert inside the lumen. It causes to thrombosis inside here, visceral wall here. It's not a good phenomenon. So make a eversion like this is to make this eversion formation. You should insert needle not very close to the cutting edge, like here. Okay.
So so far here, needle insertion here. So after that, the tying here. So under the adventitia come into the lumen. And finally, this area is a platelet aggregation will occur, and this anastomosis will occlude it. So needle insertion not so far away, very close to the cutting edge. And finally, the adventitia is everting. Intima can make forming a everting technique, everting formation like this. This is for me a very important message to make a successful anastomosis, even in the side anastomosis.
That's correct. That's very good technique, but it takes some time to master those techniques of eversion, right?
Not so sometimes. You just keeping in my mind eversion. We need to always make paying attention to the eversion technique, eversion formation, making a bypass.
That's
important.
True.
Yeah.
As Professor Mustafa Baskaya says, it is a cobra head. The cobra head should be formed in the end to side.
Cobra head.
Yeah. Final anastomosis look like it is like, or the elephant feet, or the cobra head, like it tapers and then it expands over the donor.
Yeah.
That's the eversion is very, very important in that.
Very, yes, I see.
So in a ruptured case, how would you balance your anticoagulation?
Yeah, important factor. Yeah, in the ruptured case, originally the patient suffering the hyper coagulation status. So in that situation, we need to use a heparin solution to inject the heparin solution. But during the clamping time, I usually of course, before administration of heparin, we need to complete hemostasis in the intraoperative field. So after that, we can administer the heparin solution about 2,000 international unit, about 3,000 international unit, depending on the patient body weight. We can by administering the heparin, the patient hyperaggregation status may be improved. And finally, even you perform the bypass not occluded in the acute phase, in the ruptured case. This is my comment.
And also, it is as important as to set a stage for bypass than doing the actual bypass, because the field should be, as you said, less blood and less CSF. What are your tips to make the field clear?
Oh, make the field clear.
Yeah.
Yeah, Professor, every other master says, like Professor Roque Tanikawa, and we should perform making a hemostasis, no bleeding, no oozing in the every stages, we need to complete every hemostasis. So finally, we can manipulate the accurate surgical technique in every surgical field. And of course, to avoid the brain swelling, and of course, we need to evacuate adequate CSF around the surgical field. We can get the struck brain even in the acute phase. So this is second technical tips to make a good surgical field.
Yes, that is very, very important. In Japan, mostly you see when bypass is set, they put a gel foam on all sides of the intended bypass, small piece, and they tuck a small feeding tube, suction feeding tube.
It's suction feeding tube.
Yeah, beneath that, so that whatever CSS comes, it is being sucked up through that tube, and then they put that mesh with markings, and then they start this anastomosis. So that is very, very important. Setting a field for bypass is as important as doing a bypass, actually.
Yeah, important. Yes.
Very, very important.
Very, very important. Thank you. Yeah.
What are the sutures you take what is the size of the suture? It is 10-0 or 9-0?
10-0. Yes, I usually 10-0 nylon.
10-0 nylon.
Yeah, yeah. Yes, yes. In some cases, yes, as you know, in some cases for the patient with a moya moya, in the child case, we need to 11-0. However, you know that 11-0 is very so thin, so very difficult to visualize it, and even in the microscope. So I recommend to, I recommend to use the 10-0 nylon as possible as you can.
Yes, in our last webinar, Professor Tomohito Hishikawa, who showed that pediatric moyama, he uses 11-0. It is very thin and very precise.
Yeah,
very
even
difficult.
in the microscope.
Yeah, and also the instruments that we use should be good quality to prevent magnetism. There is always this magnetism where the small needles get stuck to the instruments. So non-magnetic sharp diamond tip forceps are very important. So
important.
And they are costly too, isn't it?
Yeah, costly. Yes.
Yes.
Yeah. Titanium made of titanium.
Titanium.
Yeah.
Right.
Very fine forceps made with titanium. Important. Yeah.
Yes. What is your experience regarding IMAX, using IMAX as a donor?
IMAX?
Internal maxillary artery.
I have not experience using an internal maxillary artery. Yes. In some, of course, I know the technique. During the skull base in the lateral, anterolateral triangle or something like that, we can expose the maxillary artery using a donor artery. You can use that artery as a donor artery, you mean?
Yes.
Yeah.
But it is bit more challenging because it is deep inside the
more challenging.
skull. Yeah. We have to take stitches from more likely you have to do a parachuting technique of anastomosis.
Parachuting.
One donor is here and the recipient is here to take bite. Finally, you tighten and these two come together. So for the IMAX, it is a different technique where you use your parachuting technique, right?
Parachute technique.
Yeah.
Yeah.
Generally used by the cardiovascular surgeons. It is their favorite technique that they use.
I see.
So most of the tips we take is from our thoracic surgeons, cardiovascular thoracic surgeons.
I see.
In our place. Right. So Liu, when are we going to start our next session?
Yeah, we can start now. Can we thank you for those who are now in the Zoom session. Actually, there are some other speakers that we couldn't have a question to you, but we send the question through the email if there's any question from the audiences. May I invite Dr. Sachin? Dr. Sachin, we moderate the session, and he will call upon Professor Kato to give the opening speech before we announce the winner. Sachin?
Thank you very much, Liu. Am I audible, Liu?
Yes,
loud and clear.
Okay. So this is the YNS session we're going to have today, and it's a pleasure that I was moderating this session. I'm very proud to say that this time we had almost 22 participants from different parts of the world, and all the papers have been very energetic, very innovative, and for the first time we had too much of lively interaction during the question and answer session. So I would like to congratulate all the participants that they actively participated in the session, and I would like to invite all the participants to be the one of the reviewer for the young neurosurgeon papers, whatever young neurosurgeon papers we're going to have, whether it's a case report or a original article. Those case reports will be sent to you as a part of Young Neurosurgeon Journal or Asian Journal of Neurosurgery. And I would like to thank all the our panelists and judges for being there for 2 days and listening to all the talks very carefully and being critical analytic of all those papers and come up with the reports. So I would like to thank Professor Alberto Filetti, Professor Raja, Dr. Sandeep, Professor Abhidasha, Dr. Sharon, Dr. Niranjana, Dr. Ishu, Dr. Itichai, Dr. Adi, Dr. Thomas, and I was also there. So with that, I would like to ask Professor Yoko Kato to say a few words, and then we'll go ahead with the awards.
Okay, so hi everyone. It's a time for award time for YNS session. I congratulate all the participants from many continents, and also that everyone is representative of each country. Every paper is excellent. I listened deeply, and you can be I think the future, your country, and also your continent, and also the world representative, the good neurosurgeon. So maybe Dr. Liu and Dr. Sachin will present who will be the winners, and also what is the reward for the winners. So we decided, and also the 6 judges. I thank you very much for very precise judgment for papers. Thank you very much.
Thank you, Professor. So the awards for the winners will be first, they will get the certificate that they awarded with that particular position. One thing, this particular paper will be accepted in the Asian Journal of Neurosurgery with the free publication. They don't have to pay anything for that. And as I said, they'll be invited to join as a young reviewer for the AGNS. But there is a qualification for that. The young neurosurgeon has to be not more than 35 years of age. And all the winners, not only the winners, but even the participants who participated, I would like to invite them to submit some fresh articles, some fresh papers in an upcoming conference. We're going to have a conference dedicated only for the young neurosurgeons, women in neurosurgery, and medical students. So it will be first World Young Neurosurgeon Congress. That will be, we're planning to have it in the May, most likely on the 6th and 7th of May. So I'd like to, and there'll be more award categories apart from this, and there'll be a lot of papers. It'll be a beautiful platform. At the moment, we're trying to have it maybe in the hybrid fashion. Let's see how it depends on how the COVID goes. I would like to ask and invite all the participants and the winners to have their fresh publication in the upcoming World Neurosurgery Journal, World Young Neurosurgeon Congress also. So with that, I would like to ask Dr. Liu is there if he can announce the 3rd position award for the Young Neurosurgeon session. Dr. Liu, can you announce the 3rd position?
Hello, sorry, Sachin. I think we have our judges supposed to announce the result. I think we have few judges here with us. Dr. Sharon is there. Prof. Adiba is there. I'm not sure whether there's other judges. We have yes. Can you share the result in the chat box with our judges, Dr. Sachin? So we let our judges have the honor to announce the result. For your information to all YNS, we have a total of 6 judges who look into your video. They spend more than 2 hours plus to look at your video before this seminar. And we thank a lot for their time and their evaluation. So can you share with them? Probably we get Miss Sharon out the 3rd and 2nd place, and Prof. Adiba to announce the first winner, and also a special ACNS Encouragement Award. Sachin?
Yes. So, Dr. Sharon, I've just sent you a message. Would you just check the message and take a pleasure to announce the third position award, and then Dr. Abida can announce for the second position.
Okay, so shall I start? Shall I go ahead?
Sure. Go ahead.
Yeah, so good morning, everyone. One of the judges for your great case presentations. We went through them. I think, yeah, like what Professor Kato said, it was, yeah, very, very good. And I'm very, very proud to say that, you know, you are the young generation of neurosurgeons coming into this field. Very proud. So the third place winner goes to Niranjana Rajagopal. Yes, your presentation and your research is very good. Is Niranjana here?
Yes, sir. Yes, madam, I am.
Yeah, thank you. Very good, very good. Very proud to be in the same category as a woman neurosurgeon as you.
Thank you very much.
Yeah, keep up your good work. We hope to see more research from you.
Thank you very much.
Maybe I think, Niranjana, you can say some few words, please.
First of all, I want to start off with Yoko Kato madam being the inspiration for a lot of things in my life. Not just my career, for which she has given me so many tips and so many ideas and the correct guidance over the last, I think my first interaction with madam started in Chennai NSI in 2015. Since then, I have kind of been in touch with her, and she's guided me at all the times that I have been in doubt or, you know, any issues that I've had. And I think one of the best times that I have had as a fellow and personally was when I had gone for a fellowship under madam. The amount I have learned in 3 months, I think it's been the best. And Hirayama's has been one of the topics that has been very close to my heart, especially after coming to Japan and I guess coming back here. Thank you very much, madam. I don't think I could have done this without you, and I hope to do much more in the future. Thank you very much.
Well done. Congratulations.
Thank you, madam.
Congratulations.
Thank you very much. Congratulations, Dr. Niranjana. That was a wonderful paper about one of the very rare entity, Hirayama disease. Thank you for that. May I ask Dr. Abida Shah or Dr. Liu to announce the next award, second position award. Dr. Abida Shah, you're there?
Yes, I'm here, Sachin. Good morning, everybody. Sachin, I have not yet received the name. I got your message, but it didn't have the name. Can you resend it?
Dr. Liu?
Or do you all want me to go ahead because I got your message?
Yeah. Please, Dr. Sharon, you can go ahead. Yes.
I hope you send to Abida she's supposed to announce the first winner. Okay, anyway, the second winner goes to Dr. Ng Chat Fong. Ng Chat Fong, are you there? Your research and study was very good, very inspiring. I enjoyed it very much. A lot of hard work. Great. Congratulations. Okay, to you.
Yep, thank you so much. And I would also like to thank you, Professor Yoto, and also the organizing committee for this meeting. It's a very wonderful platform for me to share the study, and also for our young neurosurgeons to learn about different aspects. I'd like to thank you all again, and also thank you for my my supervisor and Dr. Kelvin Mack in my home country, in Queen Elizabeth Hospital. And thank you for the team for the great work.
So Dr. Fong, congratulations. Just you can tell us, so what is the overcome point? So what was your difficulty during your writing paper or researching work? Just can you tell us or tell your colleagues?
Yeah, I think it's mainly due to, because like every day is a very busy day in our unit, and we need to sometimes when we do research, we need to enter the data from scratch, and we need to create our own data bank, and we don't have a very useful I would say, a useful computer platform for us to retrieve the data and really to see each case by case, and then use our and to explore different way to try to in terms of computer, for example, using a different software to regenerate, for example, doing the 3D reconstruction for the measurement, all of these way to think it from scratch. I think if we can cooperate with some engineer, some have a special interest in neurosurgery, then will be easier for us.
Thank you. Congratulations.
Thank you so much.
Go ahead.
Thank you, and congratulations, Dr. NG Chat Form. And now we have the first prize award. So may I request Dr. Abhida Shah to please kindly announce the first prize award.
Yeah, I got the results, and I must say that it was quite a hard time judging all your presentations. All were great, and we really had a tough time selecting the best one. And I'm very happy to see so many young presentations and so many beautiful videos by the operating young neurosurgeons. I mean, it's quite nice to see and showcase your own work. And it's really proud. It's a really proud moment for ACNS to have so many young presentations. And the first place goes to Dr. Garufilina Askatonova. I think her paper was on anticlinoid process. I'm not sure. Sachin?
Yes. It was about anticlinoid process.
Yes, it was a beautiful demonstration and CT scan demonstration of the paper. And congratulations for your work.
Dr. Garifulina, are you there? I think she's from Russia, so I think the time there must be very early morning. So I'm not sure whether she's there or not, but she's training under one of our ACNS executive member, Dr. Supinov, and he also has a training center. So one of a beautiful paper done by her about and beautifully presented. Being a Russian, her English was flawless. It was very good in presentation also. So congratulations, Dr. Garifulina, for very successful paper. Thank you. And apart from that, I would like to announce that Professor Yoko Kato wanted to give a special encouragement award to Dr. Reddy Rahmani. So he's basically from Albania, but now he's training in USA, and the kind of a struggle he had for education is definitely very encouraging for all the young neurosurgeons. So congratulations, Dr. Reddy, for a special encouragement award. Thank you. Professor Yoko Kato, you want to say something?
Thank you so much. Oh, you're here. So maybe you can say something, please. Before me, please.
Professor Kato, Professor Sachin, thank you so much. I really appreciate it. I'm new here, but I think I haven't presented this work to the United States at all. I think the important thing is that neurosurgery is a global profession, and us sharing our work on a platform like this is very important for all of us to learn from one another, not to keep it in just one country. So I really appreciate it. It's a very extreme honor for me to be involved in this, and thank you again. I really appreciate it.
So, already congratulations. I think you are from Albania originally, so maybe you can reward to your country and also the Balkan Peninsula. So many maybe still underdeveloping the situation in neurosurgery. So this award is in the means. Thank you. Thanks so much. Congratulations.
Thank you.
Any of the participants or any judges or faculty want to say something?
Yes, definitely. I would like to say, first of all, let me congratulate you and Liu for organizing this wonderful feast, and also Professor Yoko Kato Sensei, yoroshiku onegaishimasu.
Konnichiwa. Hi.
Konnichiwa. So good to see you.
Yes.
So
Hi.
all the lectures were excellent, and the judges had a really good time. And in fact, I learned so much watching those lectures. They were top quality, and it was really very, very difficult. I wanted to give awards to everybody because all were excellent. And I must congratulate the winners, and they make their country so proud. Congratulations, everybody. Thank you very much.
Thank you, Dr. Raja, for the support, as you've always been there. Anybody wants to say anything?
Maybe the Sharon, at the viewpoint of the female neurosurgeon, please say a few words. Please.
Basically, when I was judging it, yes, it was not easy. But what stood out to me was, I'm not being gender biased here, guys, but the women neurosurgeons really amazed me because they have a lot of top-notch work. Their presentations were good. They were very, comfortable and fluent. And the hard work put in shows that everyone can do good job if they're given the opportunity. And actually, the main point is we are working together to build the future of neurosurgery in this world. And we want everyone to have the opportunity. And Sachin and Liu, thank you so much, together with Prof. Kato, to giving all these young neurosurgeons the opportunity to learn and also to showcase their work. I think it's very important, because, back in when I first started, we didn't have all these opportunities. So I hope all the young neurosurgeons will take this opportunity and make the best out of it, and we will hope for a better future. Thank you. That's all.
Thank you. Just finally, I want to ask Dr. Liu and Sachin, because you are most hard worker for this the seminar. I want to ask you, both of you, what is the key who can be the good neurosurgeon at the stage of young age?
I think the time is changing, and so yes, Dr. Liu is a senior to me, and I'm his younger brother. So Dr. Liu, you first, and then I'll speak.
Thank you, Sachin, for giving this chance to me. Thank you, Professor Kato, for also giving me this chance. For me, as a young neurosurgeon, it depends. Some are getting more opportunity in their early stage of the career, where they can. Please, my advice to everybody is please go out from your country, go and visit other country, learn from other, because there are so many things that not in the textbook. You can learn from them. That some of the tricks and tips are not even been written, and some of the professors don't even know that there is a special where there have been the routine for them. So if you have chance, go and visit. And for those who are latecomers, please don't feel bad. Learning is continuous. I remember when I did my fellowship with Professor Takizawa, we even have a Japanese counterpart who are at 50 years old doing attachment with Professor Takizawa. So it's never too old. I believe a young neurosurgeon is always young in the heart, even you are at the 50s. And please remember, respect your teacher. And whatever knowledge given to them, to you, are valuable, and treat it as a valuable thing. And please pass on to the next generation, to a younger colleague, to your residents, to the other medical students. And my last word to all the young neurosurgeons is, I congratulate all of you, because we make the announcement just 1 month before the program, and you all can come up with a very nice video presentation, and it's a high compliment from all of us. And it shows that you are dedicated, even with a short notice. I would like to inform all of you, for our honorary speaker, we have given them 3 months to prepare their video, and for you all, only 1 month. Congratulations. Thank you, Professor Kato.
Thank you so much. Very nice word. Yes. Sachin?
Thank you, Liu. I don't have anything to say. I perfectly agree with whatever Liu has said. But apart from that, I think a new generation young neurosurgeon, they should not be just a young neurosurgeon or a neurosurgeon. They should be leaders. The neurosurgery is changing. And how we are different from the other specialties or other surgical specialties are neurosurgery works like a team. You have your whole team together, your nursing team, your rehabilitation team, your ICU team. So as long as the ACNS YNS committee is concerned, we are not just producing a neurosurgeon. We are producing a leaders also. So even in our webinars, it's never me and you are there for the support, but most of the moderators are always new young neurosurgeons. So we are here to create new leaders, and please come up and let's grow all of us together.
So one more people, the Dr. Abida Shah, because I know her since the last 20 years. So now she became a big. So I knew him. I knew her since she is still the very young age. Abida?
Yes, Professor Kato, now I know you for so many times and you have watched my career. I first met you and I remember you straight took me to the operation theater as soon as I landed in Japan in Nagoya. And I think that is the best experience that I have had. For all the young neurosurgeons, there are two things that are important. Know the anatomy, go to the cadaver lab, practice yourself, and see as many surgeries as you can. Have a good teacher to follow, have a good mentor, so that you learn good things and you learn to train well. So when you're going to the operation surgery, you first learn the anatomy yourself. If you have time, you practice it. If not, at least read it and go in, so that when you are seeing or when you're assisting or when you're operating, you are aware of what is happening. And these are the two main key things to become a good neurosurgeon: to have good anatomy and to know your surgery well. And remember that whatever idea you get, even if it is a small one, remember to publish it, because that helps you grow yourself. It helps you think, it refreshes your mind, it gives you a different idea of thinking. And it does not matter how small it is. If it is peer reviewed and accepted, it will make you feel good and it will encourage you more. So I'm very happy to be part of this ACNS, and Professor Kato is doing a great job in encouraging all the young neurosurgeons from all over the world and all developing countries to participate in this and showcase their work. Thank you very much.
Thank you, Abida. Very good word.
Thank you. Thank you very much, everyone. I think we've started with our next session. So we can wind up the Young Neurosurgeon Award session and let's move on with the next talk. Thank you, everyone, for the participation, and all congratulations to all the young neurosurgeons.
Thank you so much. Thank you.
Depends for a great deal on the right approach to the lesion. And when we look to the anterior cranial fossa, we have different possibilities. That's either from above through the skull or from below through the nose. The microsurgical techniques, craniotomies, the approaches are manifold, as you can see here. I will not go into detail of all these approaches, but just show you. You probably know that the largest one is, of course, the bifrontal and subfrontal, but you can do frontolateral, pterional, but also, which was especially in the end of the 80s and early 90s, very, very common skull-based procedure, the orbitozygomatic craniotomy. And it's still a workhorse for basal surgery. Another one that I also used for many, many years, more than 3 decades, was the supraorbital craniotomy through an eyebrow incision. And you can reach quite a wide area of the anterior skull base, like orbital roof, with the clinoid processes, anterior and posterior, and also the frontal base, although sometimes the olfactory groove can be a little bit difficult to see, depending on how the orbital roof is located. But this is a good possibility to reach tumors of the anterior cranial fossa. It's an eyebrow incision. The technique is, I think, nowadays rather well known. complications from the frontal lobes than from coming from below. For me, it is if there is a brain edema, but still a cortical cuff present between the meningioma and the major arteries of the circle of Willis, and when it is hyper intense on T2, which points to the fact that it's more soft, more cellular, and that is more easy to approach from endonasal route. If you have a long dural tail, especially in tuberculum, cell-meningiomas, planum, sphenoidal-meningiomas, they can extend a very long way. Or if there is no cortical cuff, so the arteries are fully attached and adherent to the capsule of the tumor, or when it is hypo-intense on T2, which points to the fact that it is more fibrous, more difficult to remove. And of course, if there is vascular encasement, then I would choose a craniotomy approach, and very often the supraorbital approach. So next to this, it's also, and this is something that we were not so well aware of, but it's also about the patient's expectations and the choice. Especially nowadays, we see more patients coming and asking for an endoscopic endonasal approach, although neurosurgically that is not the best approach to do. And finally, it's also about the surgical experience. So it's your personal experience. And of course, this is an ongoing process. You will gain more experience, but a medium-sized olfactory groove meningioma should not be your first endoscopic endonasal case. As I mentioned, with this level 3 and 4, you have to go through the first two levels to gain experience. So I give you some examples of choices that we make. This lady consults an ENT surgeon because she has a nasal obstruction and on the left side, and she has this typical whistling tone during the breathing, and also more recently some periorbital pain on the left side. She is known with the nasal polyposis and some other internal medical problems. But she gets an MRI scan, and you see it here. You see this meningioma, but on the coronal plane we see this, the meningioma, and another lesion. And actually the radiologist from that hospital said this is an extension of the meningioma into the periorbital area and the paranasal sinus. But this is of course not, as you can see in the T2. Actually, the problems of this lady was this mucocele and not the meningioma, not at all. So this is something we referred to the ENT surgeon who removed this mucocele. And the meningioma, you see there is already some encasement of the carotid artery, so that we would opt then for a craniotomy. But her visual acuity and visual fields are completely intact. So at that moment, there is no reason to immediately go for surgery in such a case. But of course, if there would be a visual field defect, and if the vision in the right eye starts to decline, then we would choose the surgery. But as I mentioned then, it would be the supraorbital approach because of that encasement of the carotid artery. Because if you think about endoscopic endonasal, always remind yourself that it is a from inferior to superior trajectory. And that means this is a good trajectory for lesions that are either confined to the cellar boundaries or have, of course, extension already in the sphenoid sinus and have a direct midline extension and are below the chiasm or retrochiasmatic, because that is more easy to approach through the nose. And therefore, The craniotomy approach, and this case is the approach, gives you more microsurgical control and freedom for vessel dissection and nerve dissection, and also exposure from lateral sides to the internal carotid artery. So this is much better for lesions pre-chiasmatic and suprachiasmatic, or lying over the chiasm, or with paracellular extension. Larger lesions, at least this is my personal experience, if it is larger than 3 centimeters, and all the lesions with vascular encasement. Some examples. This is a 53-year-old female. She lives in another European country, but this was very interesting. She is an acclaimed star restaurant chef and is also the owner of a nationwide catering service. And her problem, not only that she is obese and has hyperventilation and hypothyroidism, her smell is diminishing. And in this profession, that's a serious condition. And actually, especially on the left side, it is worse. And she has an MRI scan made in her home country. And we see this more or less small 2 by 2 by 2 centimeter olfactory groove meningioma. So what are the possibilities? If you would do that, well, and if you compare now, when she presented to us, it had grown 3 millimeters in each direction over the past 3 years. So there is a growth rate of about 1 millimeter. But her smell is further deteriorating. On the left side, it is nearly absent. And on the right side, it is still present, but diminished. And in her profession, as mentioned, this is a problem for her. So she was offered Gamma knife to control the lesion, offered a bifrontal craniotomy, also an endoscopic endonasal approach, but that would absolutely jeopardize the remaining olfaction that she has. And of course also supraorbital craniotomy, but then of course from which side? The side where the smell is already nearly absent, or from the better side. So we operated on her. This was in 2016, but there is something I point out here, and I will translate it because this is the operating report in Dutch. The olfactory nerve was identified, and at the bulbus, the nerve is coated with fibrin glue. That is a technique that we described in 1998, that in cranial-based surgery, the nerves that are at risk of operative trauma or a long exposure to the air is coated and hence protected with a very thin layer of fibrin glue. And that helps to reduce the trauma to the nerve. Well, and this was her email when she returned home, and for me it was new, but she did apparently smell training with 10 different smell oils. You can do that, like it is citrus and coffee, and so a little etheric oils that you can train your smell. That was interesting to see. And she was extremely happy because the smell came back on the left side. And on the right side, we approached it from the right side, it was still good. And she said, when I went to the supermarket, I thought it was in a candy world. So this was a happy result with the removal of the small meningioma, but not only preservance of the smell on the right side, but even improving the smell on the left side. And she allowed me to show this picture. You can see this is the scar is visible. This is just about 6 weeks after the surgery, and you see, but it is a nice cosmetic result, which we more constantly see with supraorbital approaches. This is going very well. Another lady, a younger lady with also loss of smell already for 4 years. But she is now seen by an eye doctor because of visual complaints, and her vision is really, really bad. On the right side, it is only, well, black and white she can diminish, and on the left side, it is 10%. So that same day, a CT scan was made. And this is the scope, and you see already this larger calcified part from cribriform plate all nearly up to the tuberculum. It's a huge meningioma, but here I think that because of the loss of smell already for 4 years, this could be approached from below. But since there was no cortical cuff here, we chose a craniotomy approach for this large tumor, despite the fact that there was quite some edema. But there is no chance of dissecting these vessels properly. And also in some sizes, if the tumor extends lateral of the optic nerve, you cannot approach this endonasally. It's no safe way to dissect that. The last one was a 66-year-old male patient with fever and epileptic seizure. He was, well, somehow mentally deteriorating, according to his wife. And the CSF was positive in PCR for herpes virus, but he became drowsy after the lumbar puncture, and therefore they made a CT scan, and you already can see this here. This is a meningioma with a calcified part, and according to the size and there is a thin cortical cuff here, this is a good candidate for approach endonasally, going through this large area of the sphenoid sinus, drilling the planum. And also because there is quite an edema with this rather small meningioma, and you saw this picture before. And actually, because of this, and a return was the we performed here a combined endoscopic and endonasal and supraorbital approach, because that is also one of the possibilities. You need then 2 neurosurgeons, of course, and quite some cumbersome amount of different instruments. And as you can see here, you have to work very closely together. So one neurosurgeon approaching it through the nose, the other supraorbitally. So you work rather close together from a not fully sterile to a sterile field, but still this is very feasible for such kind of lesions. And then finally this, and also closing the skull base defect is much easier with such an approach, because it's already helped from below to allow watertight closure. So in conclusion, outcome of surgery for skull-base meningiomas depends on careful case selection, and that selection is certainly also influenced by your own surgical experience. Both approaches are possible and will achieve good results if the selection was done appropriately, as shown in some of these cases. And selecting the right approach means understand the oncological principles of surgery for meningiomas. And you should be, if you are a skull base surgeon, be familiar with open and endoscopic approaches. And you should choose the best reconstruction of the skull base defect. And you should always be capable of combining the approaches or switch from one to the other. And at the end, this was also a request from the organizers, I will give a short message to the young neurosurgeons. I can tell you from my 40 years experience in neurosurgery that it is a medical field full of opportunities. The great thing is it is rapidly changing. We will now see artificial intelligence, robotics will evolve more. The possibilities of functional and restorative neurosurgery are increasing now. And yet still it is a very demanding specialty, but I can tell you from my own experience that it is extremely rewarding. And end by telling you this quote from Mark Twain. 20 years from now, you will be more disappointed by the things you didn't do than by the ones you did do. And I will tell you, explore, dream, and discover. And by this, I thank you for your attention.
Hello everyone, my name is Takashi Maruyama. Today I'm going to talk about glioma surgery for young neurosurgeon. Before my presentation, I would like to say a special thanks to Dr. Yoko Kato to have this great opportunity. I was working in Tokyo Women's Medical University as a glioma surgeon for 20 years. Let me introduce myself briefly. Before pandemic of COVID-19, I had a regular exchange program with Bedok Hospital in Vietnam, where I regularly gave lectures and performed surgeries. After several preliminary preparations, we successfully performed the first awake surgery in Vietnam in 2019. I hope that today's lecture could help young neurosurgeons to treat glioma patients. In my oral presentations, I always emphasize that what is needed in glioma surgery is a balance. We have to make a balance between patient QOL and survival for glioma surgery. We all know that extent of resection improves patient prognosis, but there are not so many prospective comparative studies. As for the significance of removal for GBM, Mitchell-Berger published the relationship of extent of resection and prognosis in 2011. In this paper, the statistical threshold for removal was reported to be 78% or more, but GBM surgery should be planned to achieve total removal of gadolinium-enhanced area whenever possible. This is the RPA classification. We all know that there is a subgroup who have benefit with maximum resection in high-grade glioma. This case was a 40-year-old woman with a large tumor in the dominant hemisphere with calcification. The patient showed only mild recent memory disturbance. Such a symptomatic time course can suggest that the tumor has grown slowly, so that this patient may have longer survival than usual GBM. The goal of surgery was to achieve removal of the T1 low lesion to avoid further damage to the language and cognitive function. She was diagnosed as GBM with oligodendroglial component at that point, with IDH mutant 1p90q-LOH. She is surviving for more than 10 years. If you predict longer survival, we should stay safe side of surgery to keep patient QOL stable. Looking back at the past 250 cases at our institution, we have verified that when there is obvious calcification, the probability of 1p90q-LOH or IDH mutant is nearly 90%. Inevitably, The tendency is to remove the tumor on the safe side without causing any complication. The WHO classification is updating based on these histological and genetic diagnosis to improve the diagnostic accuracy. Prognostic relevance is moving forward to integrate radio image, histology, and molecular information. However, molecular information usually comes after the surgery, so we have to achieve maximum safe surgery anyhow. In glioma surgery, it is necessary to cut into the brain. We must understand both the function and the structure of the shallow layers of the brain, mainly the sulci and gyrus, and the network of functional fibers in the white matter. And in order to assess and protect brain function in surgery, monitoring such as MEP and SCP, AVEC surgery, and brain function mapping techniques are required. Since time is limited, I will present a case that illustrates the concept of two typical types of gliomas in the frontal lobe that occur most frequently. One is a large diffuse tumor, and the other is a localized tumor requires functional evaluations. Let's start with a large frontal tumor. Point is, molecular diagnosis will come after the surgery. Do not worsen the symptoms by surgery, but take what you can. Removal target must be done not for flare high, but within a T1 low removal. This is a case where the patient survived for more than 5 years after the surgery and radiochemotherapy. There are many lessons to be learned from this case. The patient shows only mild disorientation. The fact that she lived with her family and did not show many symptoms suggests that the tumor growth rate was slow and that her brain had a compensatory mechanism. The point is that the preoperative image shows that the ventral structure were not invaded by the tumor. The ventral side of the brain contains the sublaminar area, which is responsible for higher brain functions, mainly the corpus callosum, cingulate gyrus, and anterior commissura. In the ventral part of the frontal lobe, there is an important network that is directly connected to higher brain functions such as cognition or working memory. In this case, the tractography showed that the coordination between the left and right frontal lobe was maintained. Her ventral structure was not damaged by the tumor, so we have to be careful not to damage ventral structure and preserve the limbic system as much as possible. Frontal marginal sulcus and the inferior frontal sulcus was a milkmark for the removal. Also, we preserved the contralateral side of the corpus callosum. For large frontal tumor removal, point of surgery is step-by-step removal following key structure during surgery. Try to reach lateral ventricle first. Once open the ventricle, we could handle third brain easily. Then dissect lateral margin. In this case, inferior frontal sulcus was the lateral border. On the anterior border, if you can confirm frontal marginal sulcus, you should stop to go beyond the sulcus. Then open the interhemispheric fissure to the corpus callosum. Corpus callosum was invaded by the tumor. However, removal must be stopped in the center of corpus callosum, not to damage contralateral side, to preserve limbic system structure. branch of ACA was cut. Then unroof the lateral body of ventricle. This is a simple way of frontal large tumor removal. The point of surgery is keep your orientation based on the key structure. Tumor was diagnosed as IDH mutant GBM. We intentionally remain contralateral side of corpus callosum. Patient was returned back to the normal life and stayed without recurrence for 3 years. Large frontal glioma sometimes involving good surgical result and long survival. We sometimes have this type of frontal glioma. Tumor is mainly in lateral inferior part. Ventral fiber network usually involve insula and temporal stem, and tumor sometimes invade into central part of frontal lobe. Main region of the tumor is in the outer part of frontal base. However, diffuse flare high area is extended into the medial basal portion. I intentionally try not to damage the central part to avoid to cause cognitive dysfunction. The anatomy of the frontal base plane is not often given much attention. The plane is divided into 4 parts such as anterior, lateral, posterior, and medial orbital gyrus. There are several variations in this area. Medial orbital sulcus and orbital sulcus is the key structure to not to damage medial side of frontal. Tumor removal start from lateral orbital gyrus, then continue to the posterior orbital gyrus. Once reached to the medial frontal orbital sulcus, then decide whether you should remove this part based on the preoperative evaluation. The point is that there is an important structure around anterior commissura. We know that if this area were to be carelessly removed or damaged, some patients cause severe cognitive dysfunction. It is still a difficult part of tumor removal. This is another case of GBM with IDH mutant. He is surviving for 9 years without recurrence. This is a left frontal grade 3 glioma case. She was diagnosed as anaplastic oligodendral glioma, IDH mutant, and LOH. She is surviving more than 10 years without recurrence. In such large frontal case, try not to be extend flare high, but stay within T1 low. Chemo and radiotherapy sometimes work quite good. Now let's move to the localized low-grade glioma. Relatively well-defined tumors. The goal of surgery is to maximize flare high lesion removal without any complication, with functional assessment whenever possible. In low-grade glioma, functional evaluation and mapping guide resection could contribute to the better outcome. Eloquent location sometimes shift to the outside of tumor. It is now clear that the assessment of brain function can contribute significantly to improving the rate of safe and aggressive removal. Glioma of the frontal lobe can cause a variety of neurological symptoms. In the case of middle frontal gyrus tumors, these symptoms can be evaluated while removal. Therefore, I will introduce the characteristics of frontal lobe tumor removal with typical examples. Tumor mainly in the middle part of the frontal lobe, usually silent. However, this area is surrounded by a variety of nerve fibers from motor to speech, including SMA superiorly, operculum inferiorly, pyramidal tract posteriorly, and SLF deep within. Surgery is usually considered for flare high removal. We believe that these nerve fibers run in the border area, and we choose awake surgery if possible to prevent surgical complications. Trophotography showing that the tumor was surrounded by barriers of networks. We made a cranial window on the left upper half. Tumor locating in upper half of the middle frontal gyrus. Let's back to normal anatomy. 90% of brain have intermediate frontal sulcus. Of 30 to 40% of intermediate sulcus leads to the precentral sulcus, and the sulcus separate middle frontal into upper and lower. This tumor mainly locating in the upper half of the middle frontal gyrus. Brain mapping evaluate precentral gyrus. Hand motor response.
はい、顎。下が動いたね。
Facial motor response.
唇のところ動いたね。はい。ない。あ、動いた。動いた。はい。はい。
So we evaluate the pyramidal tract and also precentral gyrus, a primary motor area. We usually remove tumor as directomy fashion. Open the sulcus with subpial dissections. Now I open intermediate sulcus, suprafrontal sulcus, and precentral sulcus with subpial fascions. Once we reach to the bottom of sulcus, we stimulate white matter and confirm whether I could go further.
はい。いちご。カメ。小学期。はい。はい。はい。犬。うさぎ。馬。牛。はい。はい。
At the bottom of sulcus, inferior part of the tumor, patient showed speech arrest and naming error. We took the tissue from this part and confirmed that there is no remarkable tumor cell invasion. Here you can see that we go further deeper in the bottom. Now you can see the conjugate deviations. Again. It is not so often, however, sometimes you can observe conjugate deviation at the bottom of the tumor cavity in the middle from the gyrus. After the main mass removal, we are going to the border of tumor and normal brain, confirming the brain function around removal cavity.
自転車。シマウマ。
手が動いてる？手が動いた。
He showed wrist motor response.
もう一回しますよ。ちょっと待って。今どう？手が動いてる。はい。
Still positive.
大丈夫。ちょっと動いた。
Still positive.
大丈夫。
Near the bottom and next to the pyramidal tract, we stimulate the hand motor response.
大丈夫ですか？せーの、はい。
取る。
せーの、はい。
咲く。
せーの、はい。
取る。
魚を取る。
Speech arrest with verb generation tasks. again. Here is the wrist motor response area. And next, conjugate deviation area. And bulb generation data. Well, we take some small specimen from the removable cavity and confirm there's no remarkable tumor invasions. So this is the final view. As you can see, the deep white matter of the frontal lobe is crisscrossed with various nerve fibers. We usually stimulate function before incised deep white matter. By continuing the conversation during tumor removal, you can observe if there are any disruption in the conversation or speech. The postoperative diagnosis was oligodendroglioma with 1p19q-LOH. So, the patient was decided to be followed up without any postoperative treatment. His epilepsy was under control. There are several function networks in the middle frontal gyrus, so that if you remove tumor in this frontal area, you have to pay attention to preserve such functions. If you can choose AVEC surgery, I definitely recommend to select AVEC surgery for the patient. Aphasia can be caused by a variety of factors in addition to the language network. Due to the time limitation, I cannot show you the detail, but it is important to have a team to observe them carefully in the AVEC surgery. Last year, Mitchell Berger's group published a paper about AVEC surgery setting, so you can follow how to manage patient in AVEC surgery. Finally, I just want to emphasize that we can consider multi-step surgery. The aim of surgery is volume reduction of tumor mass, correcting diagnosis, and select most effective treatment for patient long survival. This is an epilepsy onset young patient with left superior and middle frontal gyrus tumor. Initial surgery, patient awake condition was not so sufficient. We removed the anterior half of the tumor. Then we start chemo and radiotherapy. After the treatment, we did watchful waiting for her. Because of the uncontrollable seizure, we decide to do second AVEC surgery. With 3 years follow-up, a second removal was performed. We removed most of the flare high area without complications. This is another way to handle grade 2 and 3 glioma patient. I showed two different types of glioma surgery. Large frontal tumor, especially in diffuse type, sometimes include slow-growing or beta molecular subtype. Removal target is T1 low area, not to cause any damage, fair compensating brain function. Localized frontal tumor. Dominant hemisphere contains many functional fibers. Functional evaluation will help to avoid unpredictable neurological deficit. We have to consider whether should we remove flare high lesion or T1 low lesion, depend on preoperative evaluation and predictive diagnosis. This is the last slide of take-home message. Predictive diagnosis by preoperative imaging is important, while the actual diagnosis comes after the surgery. Molecular subtypes include slow-growing tumor type or tumors that respond to chemoradiotherapy. Don't be fooled by size or preoperative findings, but do the best you can and sometimes don't try too much to achieve complete removal. For patients who may become the next long-term survivors, we have to make a good balance during tumor removal. Thank you very much for your attention.
Hello, everyone. My name is Ming Li. My presentation title is Local Targeting of AD Metabolism Changes Tumor Immune Microenvironment and Enhance Checkpoint Immunotherapy in Glioma. Actually, this work was done in the Mass General Hospital Neurosurgery Department. Right now, I moved back to the China Department of Neurosurgery, People's Hospital of Zhengzhou University. This presentation includes the following parts: background, 6 parts, and acknowledgement. This is the outflow of the AD metabolism. From here, we can see if we block an NAMPT, AD level will decrease, the ATP will decrease, the cell will healthy and aging. In our previous work, we found that if we use NAMPT inhibitor, IDH wild type are resistant to the NAMPT inhibitor. IDH mutant cell lines are sensitive to the IDH mutant cell lines. Sensitive to the NAMPT inhibitors. We use the 2 types of the model, MGG152 and HT1080. We found that NAMPT inhibitor can have some survival beneficials. However, there are some toxic effects. How to overcome the toxic effects? So, because the toxic effects was caused by the systematic systematic side effects, we think maybe local treatment is one of the good way to solve this problem. How to solve this problem? We think the non-attack is one of the best way. This is the outflow that we will use in the future. This is during this outflow. During this we use biopsy to get the samples and test the genetics status. If we found the drug, if we found this tumors have some IDH mutant, we resect the tumors and put the drug there to release, to control the tumor growth. This is our partner from the MIT, Professor Traverso, who made the particle for us. We tested these particles in MGG152, and we found that this particle can release slowly and have a good result, good survival result. In our previous work, we found NAMPT inhibitor have some effect on the tumor cells. Because in the tumor tissue, there's some other cell types. For example, immune cells. How does the NAMPT inhibitor modulate the immune microenvironment? That's the project that we want to answer. The first part, what is the model we should select? Most times, there are 3 types of the GBM model selection. 005, CD2, and GS31. We found, as we all know, PD-L1 is one of the important marker for immune. So we test the PD-L1 level. We found GX261 have not very high level, not a very low level. So we use this cell line to test. Second part, can NAMPT inhibitor change the PD-L1 level on GBM model, on GBM cells? From here we found we use this we use this dose dependent. We found NAMD inhibitor have some time dose dependent. First, ND level decrease. ND level NAMD inhibitor increase, ND level decrease, PD-L1 increase. We found the NAMD inhibitor have some dose dependent to the PD-L1. And we also found NAMD inhibitor have some time dependent. If the NAMD inhibitor dose if the time increase, the ND level time increase, the PD-L1 level increase. So we found that there's some time dependent. And what's the best way to use? Because we know if we block NAMD, ND level will decrease. From here we can see AMA is the downstream of this pathway. If we end the AMN, I think ND level will increase. From here we can see this phenomenon. And we also can see AMN can reverse the PD-L1. So we confirm this phenomenon through this pathway. If we block NAMD, ND level will decrease, PD-L1 will increase. So, and we tested some human GBL cell line. We tested MGG23 and MGG119. We found that as the NAMD inhibitor dose increase, PD-L1 also increase. Conclusion: NAMD inhibitor upregulate PD-L1 expression on human and most GBM cells in vitro. PD-L1 expression treated with NAMD have dose-dependent and time-dependent. The MA can reverse PD-L1 expression on AD level of GL treated with NAMD inhibitors. Third part: can NAMD inhibitor change the tumor immune microenvironment? First we made the new particles with green color. This is Kumar 6 particles. We inject these particles in GL261 mouse model and observe the particle under the fluorescence microscope after 2 hours. We can see the green colors dispersed in the mouse brain tumors. And this is the first animal experiment. First, we made the model GL262 model, and at day 16 we treated with the new particles, and 4 days later we sacrified the mice and do IgG-RF. We found that NAMD inhibitor GMX group have the high PD-L1 level expression. For further, we found those PD-L1 positive cells from the nesting positive or ARG1 positive cells. And the GMX 1778 particles can change the T cell infiltration. We use 3 markers: CD3, CD4, CD8. We found that CD3 increase, CD4 and CD8 also increase. That means GMX particles can change the T cell infiltration. And the GMX 177 particles can polarize the tumor-associated macrophage toward to M1 phenotype. We use 3 mark CD16 in those AIGY. CD16 is the total macrophage. From here we can see the NAMD inhibitor can increase the total macrophage and M1 macrophage and decrease M2 macrophage. From this part we can see NAMD inhibitors upregulate PD-1 expression on GBM cells in vivo. NAMD inhibitors CD3, CD4, CD8, cell infiltration, namely increase total macrophage, and M1 macrophage decrease M2 macrophage. First part is namely static to the tumor-associated macrophage in vitro. Here, this is the workflow of the tumor-associated macrophage treated by namely inhibitor. From here, we can see we remove the tumor from the mouse brain and dissociated those tumors and count and plate and treated with namely inhibitors day 1, day 2, day 3. We do F for those markers. Here, from here, we can see that NAMT inhibitor can decrease the nesting positive cells and M2 macrophage. Conclusion: NAMT inhibitor not only kill tumor cells but also kill tumor-associated macrophages in vitro. In the previous work, we found that NAMT can upregulate PD-L1. What's the effects of combination NAMT inhibitor with systematic anti-PD-1 antibody? Here we run another survival. That day 6 we treated the mice with the GMX177 nanoparticles. Day 8, day 10, and day 12 we inject with the anti-PD-1 antibody. We found that combination group have a good effect, and the body weight shows there's no side effect. Luckily, there's one mouse was killed in combination group. Combination therapy also low PD-L1 expression compared to the GMX are low. And the combination therapy can change the T-cell infiltration, CD3, CD4, and CD8. Combination therapy also polarize the macrophage mark. Conclusion: combination therapy significantly increased the survival of GM261 model. Combination therapy increased CD3, CD8 T-cell infiltration. Combination therapy increased the total macrophage and M1 will decrease M2 compared to blank group. However, polarization of the macrophage in combination therapy is similar to the GMX1778 alone. So what's the mechanism of PD-L1 upregulation on GBM cells? A relationship among so the relationship among the AMD, autophagy, and PD-L1. In our previous work, we found that if we block NAMT, AMD level will decrease and induce the autophagy. And in my research, we found that if we block NAMT, the AMD level decrease and induce the PD-L1 regulation. So is there any connection between the autophagy and the PD-L1? So we made the following experiment. We use 3MA, which is autophagy inhibitor. If we combine the NAMT inhibitor and 3MA, we can see that autophagy can partly reverse the autophagy and partly reverse the PD-L1 upregulation here. So conclusion, autophagy can partly rescue the PD-L1 change of mRNA and the protein level. Final conclusion, NAMT inhibitor upregulate PD-L1 expression on GBM cells. NAMT inhibitor increase CD3, CD4, CD8 of T-cell infiltration. Total and M1 macrophage, while decreasing M2 macrophage. Combination can significantly increase the survival of GBM models. Autophagy inhibitor partly rescue PD-L1, change MI and protein level. Thanks. This is the lab that I worked in Harvard. Thank you.
Hello, my name is Revat Mapitak from Thailand. I would like to thank to Professor Yoko Kato and WFNS and SNS for inviting me to this presentation. It is my great honor for this opportunity. So let me introduce myself briefly. I have practiced neurosurgery since 2012, and now I work at Thammasat University Hospital, Pathum Thani, Thailand. I'm also a co-director of skull-based surgery program at Thammasat University. My work mostly involved in the field of minimally invasive surgery, including the keyhole neurosurgery and neuroendoscopic surgery.
Yeah, my friend.
Today, I'd like to talk about the minimally invasive surgery of the anterior skull-based tumors.
Huh? Yeah, no, don't talk and then all of
the
push
anatomy. We all know that the skull base can be divided into three zones: the anterior, middle, and posterior skull base. For the anterior skull base, it can be further divided into two compartments: the midline compartment and the lateral compartment. In the midline, it consists of the crystalline cribriform plate and the pronounced sphenoidal posterior. For the lateral compartment, it consists of the orbital plate, the sphenoid bone, and the anterior trinal process. This is the anatomy from above. You can see this view through the craniotomy. But if you want to see the anatomy from below, you have to go through the nose. This model shows that the nasal cavity is related with the anterior skull base. Which problem is the sinus. So if you want to see this from below, you have to remove the ethmoid sinus. This is the endoscopic view. After removing the ethmoid sinus, you can see this is the cribriform plate and the crystal galli in the midline. And please note that the anatomy through the nose is limited by the middle wall of orbit in both sides. And after removing the cribriform plate and crystal galli, we can see the frontal lobe dura, and we can cut it, open it, and we can access the frontal base. In the posterior, we can access the optic chiasm, the acom, and the pituitary gland. In addition, the anterior skull base can be visualized from the orbit. From picture, we can see that if we use the eyebrow or eyelid incision, dissect the eye growth from the superior of orbit, we can access the anterior skull base from superior of orbit. We can see that the foramen of anterior ethmoidal and posterior ethmoidal can be identified through the superior eyelid approach, and also the optic canal and superior orbital fissure. And after leaving the superior wall of orbit, the frontal dura can be identified, and the frontal skull base can be accessed through the orbit, like these pictures. For the pathologies, the most common pathology of the anterior skull base require the surgery are tumors, in which meningiomas are the most common. They consist of olfactory groove, planum, tuberculum cellae, and crinomeningiomas. Moreover, we can find the sinonasal cancers, esthesioneuroblastoma, or even the rare tumor like sarcoma or skull-based lymphoma. Other than that, we can use the skull-based approach to the anterior skull base to treat intracranial aneurysm or CSF leakage. Traditionally, we have the craniotomy for the access of the anterior skull base, in which for the midline lesion, we can use either interhemispheric or subfrontal approach to the midline, or we can access the lateral lesion through the frontolateral approach, terminal approach, or orbital psychometric approach. But nowadays, we have the very specialized instrument, especially the endoscope. And we also have the advanced endoscopic instrument, like the ankle instrument, which we can minimize the spherical exposure. And this can be applied for the minimally invasive technique to access the anterior skull base, in which the minimally invasive surgical approach to the anterior skull base can be categorized into 4 categories. The first one is about the keyhole craniotomy, like the supraorbital keyhole or mini-turinal approach. The second is the endoscopic endonasal approach. The third is the transorbital approach, like the diagram that I recently showed you. And the last one, for the complex or the large tumor, we can combine all of this modality to manipulate the tumors, like the simultaneous endoscopic endonasal with transorbital approach. The considerations for minimally invasive technique consist of tumor, neurological factor, and patient factors. The tumor factor is very important, especially the extension of the tumor. I think it's more important than the size, because the more extended tumor, the more complicated to use the minimally invasive technique. In addition to the extension and size, we have to consider the tumor consistencies and the previous treatment of the tumor. For the neurological factor, we have to check the involvement of the critical neurovascular structure, either the cranial nerve or intracranial arteries. Moreover, we have to check the brain edema, especially for the keyhole approach, in which this is the limitation for the keyhole approach. The last one we have to consider is the patient factor. We have to consider the age, comorbidity of the patient, and we have also consider the cosmetic appearance and the function of the patient. For the anterior skull base, we have to check the eyebrow function and the smelling function for the patient. First, let me talk about the first minimally invasive technique. It is the keyhole procedure. Here, the supraorbital keyhole approach is very good for assess the anterior skull base tumor, in which we can use the eyebrow or eyelid incision, and we can also make more exposure by removing the orbital rim. This is so-called the mini OC, in which we can reduce the degree of frontal lobe detection. The supraorbital keyhole approach is very good for the ipsilateral or the midline lesion. For the contralateral lesion, we can use the mini-turinal craniotomy, or we can use the variation of supraorbital keyhole craniotomy. However, the main disadvantage for the keyhole approach is the degree of brain edema, in which I cannot use the keyhole procedure when the patient has very severe brain edema. Let me show the example case. This is the first case, the olfactory meningioma, which is very large. You can see that the posterior margin of the tumor is very adhere with the ACAs, and the anterior margin is very close to the crista gallis. This case, I decided to use the frontal craniotomy, the subfrontal approach, but I accessed the tumor to the unilateral left subfrontal approach, because you can see the left side of the tumor is very close to the surface. So I can avoid the brain detection when I went to the left side. This is the video. Here, the left side subfrontal approach. After I opened the dura, I opened only the left side. I started dissecting tumor from the skull base, try to devascularize the tumor, and follow it from anterior to posterior. This is the skull base, then this is the tumor. This is the midline. You can see this is the dural fold of crista galli. I remove it, try to decompress it. Go to the posterior part of the tumor, dissect it from ACA here. And then go to the posterior, identify the left optic nerve. And after that, the tumor was removed. Okay, and here is the post-op scan. The tumor was totally removed, but I could not preserve the olfactory nerve, and also the both frontal lobe is very severely injured, but the tumor is very large. Okay, let me show you the second case. This is smaller than the first one, the olfactory meningioma. You can see that the tumor was located in the midline, no lateral extension, but the anterior margin of the tumor is very close to the posterior table of the frontal sinus. I think this is very difficult to see to the nose. So I decided to resect this tumor by the supraorbital keyhole approach. Although the patient had the degree of brain edema, I think it's not so severe, and I never use the lumbar drainage for the keyhole approach. Here is the video. After open the dura, I started to dissect it posteriorly, try to release CSF from the optic cistern, the carotid cistern. Here is the carotid cistern. After that, I identify the tumor in the midline, dissect it, identify the right optic nerve, and then I follow the A1, dissect the tumor from the artery. This is A1 and A2. This is the Hubner artery. I dissect the tumor apart from it, and this is the olfactory nerve. This is the right side. Unfortunately, I cannot preserve it, and I had to cut it. And this is the frontal base. I coagulate the frontal base and then try to peel the tumor from contralateral side. This is the left olfactory nerve. Also, I had to cut it. Olfactory nerve and the tumor. And then lastly, I dissect the tumor from the attachment, try to identify the contralateral optic nerve, the left side. Here is the left optic nerve. Okay. Then the tumor was totally removed. Let me go forward. Okay. Here is the last view. Okay. This is the last view. The left. Okay. The left optic nerve. Left A1. And this is the light A2, A1, and the light Hubner artery. This is the contralateral A2. Okay. Here is the post-op scan. This is my craniotomy. I use for this case, I use the supraorbital keyhole with the orbital lip extension, so-called the mini OC, because I did not want to retract the frontal lobe, so I go very low to do this approach. And this is the post-op scan. You can see the tumor was totally removed, and I can preserve both frontal lobes. This is her incision, the eyeball incision. So for the endonasal technique, I can use the transcripiform transpanum transtuberculum approach for resecting the tumor. The endonasal technique is very good for the midline lesion, for the lateral extension, or the tumor with severe vascular encasement, or the patient with intact smelling. The endoscopic endonasal technique is quite contraindicated. Let me show the example case. This is the tuberculum cellae meningioma. You can see the tumor was confined in between the ICA bifurcation, both sides. And although the tumor was just quite go lateral to the right, but I think it's not went through beyond the optic nerve. I think this is still accessible for the endoscopic endonasal technique. Here is the video. Okay. I use the transcellular, transtuberculum, and pranam approach. This is after removing the bone, open the dura above the cellar. This is the key advantage of endoscopic endonasal technique. We can assess the base of the tumor first, so we can coagulate and cut the arterial feeder. And it's really easy when the tumor was devascularized. This is I open the pranam dura. Okay, starting Then I started to remove tumor, peel it from the left optic nerve here, decompress it, and try to dissect it from the light. Okay, then I remove the tumor from the optic chiasm and pituitary stalk. Sorry, what's that? Okay, this is the final view after removing the tumor. The optic chiasm and pituitary stalk were identified. And here is the post-op scan. You can see the tumor was totally removed and the vascularized fat was very enhanced. Okay, this is the next case. It's like the first one. This is the tumor meningioma. You can see that the tumor is quite lateral to the right, and it may involve light A1, but I checked the CTA. The light A1 was disappear. So in this case, I chose the endonasal technique. Here the video after opening the dura, the tumor was identified and was removed. For this case, I started removing the tumor from dissection the tumor from the left A1. I protect the blood vessel first. And here is the left A1 and left optic nerve. Then the tumor was removed from the right optic nerve and optic chiasm. Let me go forward. Okay, this is the last part of the tumor, the superior part of the tumor. I can see there was one arterial supply, arterial feeder of the tumor. So I coagulated it and cut it. Okay, and then the tumor was removed. Here is the last view after removing the tumor. You can see, although the CTA in the preoperative image cannot identify the right one, but intraoperatively I can see it. Okay, and here there was a post-op scan. So the last one is about the transorbital approach. As I said, I can use the eyelid or eyebrow incision. Going above the eyebrow, dissect the eyebrow from the superior wall of orbit. This is a very good candidate for the HDX-covered tumor with the lateral extension. This is the example case. You can see that the tumor is really is located quite lateral to the right, to the left. Yes, and the arterial feeder was coming from the left. So this is really good for transorbital approach. Here I use the eyelid incision. Dissect the eyebrow from the superior orbital rim and superior orbital wall. Then I dissect it behind during the superior wall of orbit, opening the dura and remove the tumor. Okay, let me go quickly. This is after removing the tumor. I can identify the optic nerve, but in this case, I could not identify the olfactory nerve. I think they were cut. This is the last view. Okay, let me move forward. And here is the post-op scan. The tumor were totally removed, and you can see this is my exposure. The superior wall of orbit was removed, and I can protect the contralateral side of the frontal lobe, but the left side is not quite good. And this is the cosmetic appearance. Her eye are quite asymmetry, but she felt okay. This is my experience. I had most of the case of meningiomas, the olfactory group, random or tuberculous meningioma. And after I learned the minimally invasive technique, I switched from the traditional technique, try to use the minimally invasive. And I believe that the number of minimally invasive technique will go rapidly. And the complications are systemic and meningitis. These are the most common. based on an evidence from Professor Theodore Schwartz, they published a very great literature about the outcome of craniotomy and endoscopic endoscopic technique. It showed that the research rate between these approaches were very similar, but the visual improvement was slightly better for the endoscopic endoscopic technique. They also published the paper about the decision-making algorithm for minimal invasive approach for endoscopic. The key important factor involved the olfactory function and the lateral extension of the tumor. This is a very great paper. So for me, in conclusions, I think knowledge in anatomy and surgical technique are very important. And the key success for minimally invasive technique is the preoperative planning and also the discussion with the patient. I have a great opportunity to visit great Japanese professors many times, including Dr. Tanashi Watanabe in Nagoya, Professor Takeo Koto, and Professor Kenji Owata in Osaka. What I learned from them is the keyword of putting every attempt and always do the best job for the first time for every patient. This is like the famous Japanese idiom Ichigo Ichi. So thank you very much for inviting me. Hope I can see you again next time. Thank you.
Okay, thank you very much for giving me the opportunity to present my data. Today I would like to talk about glioma surgery, endoscopic surgery, and robotics. I have no conflict of interest with any corporate organizations relating to this presentation. Today's topics are introduction, anatomy and monitoring, endoscopic surgery, robotic navigation, and new treatments. First, introduction, mythological philosophy from Department of Neurosurgery, Harvard University School of Medicine, Shizuoka, Japan. I was a residency in Okayama University. I was a research fellow in Department of Molecular Medicine, Sapporo Medical University School of Medicine, and I experienced the postdoc in neurosurgery at Ohio State University. From 2020, I became a chairman in Ohio University School of Medicine. My biggest areas are brain tumors, immuno-oncology, gene therapy, oncolytic virus therapy, molecular targeted drug, scar-based surgery, neuroendoscopic surgery, scar-based surgery, neuroendoscopic surgery, pediatric neurosurgery, and so on. This is Harvard University School of Medicine. It has 600 beds here. In the Department of Neurosurgery, Harvard University School of Medicine, and 350 surgical cases per year, brain tumor, vascular disease, Parkinson's disease, supine, pain, pediatrics. For research, we are doing research for brain tumor, vascular disease, Parkinson's disease, or MR study. This shows our various projects for brain tumor therapy, molecular target drug, oncolytic virus, cardiac study, monitoring new navigation, gene therapy, and endoscopic surgery with full HD, OK, YK. For example, endoscopic surgeries have lately been gradually performed in neurosurgery to improve the accuracy and safety of endoscopic procedures. We are currently trialing 4K or 8K systems. We're using also 4K system. 4K is very nice and high definition. It is easy to detect tumor area normally. And also, I experienced the 8K system. This is the 7HS quality. definition, and we can know this as we can detect this view more 3D. Then there's a topic glioma surgery. Glioma management is mainly we need section and the treatment slide without CTF. However, we need to basically for surgery we need to cell resection. Next, we need anatomy and monitoring. Surgical anatomy has neural anatomy, functional anatomy, and anatomy. This is neural anatomy, and we are performing usually functional MRI, and we will also do trajectography. Next thing is endoscopic surgery. Recently, endoscopic surgery is very current and now increasing the number. So the advantages are systems of also to surgeon and education and training opportunities for staff, residents, and students. Specifically, surgery is a very easy to see the entire surgical field, and it is the utility of YA and we advocate for surgery. There are several examples of these of light and these microscope. For example, we expanded to OVI and it has also a function for surgery. So this is just an example of case 49 ascites so in that case we need to be careful for the area and for which then we choose something approach or contrast approach or transfusion approach. Then we choose the transfusion approach. I'll show you the video. Here is the fissure and cutting the arachnoid. And here is the temporal area, then we can know the area of the tumor. I'm calculating the area. And the centimeter we can cut here, then we could detect the tumor and we evaluate. We can know where I am with the navigation system. This is EIP. And finally, we could not detect by the airway. Then we need to this is the so another thing is this is algorithm surgery, we know surgical anatomy and we can change the surgery. We and recently we are using surgery. overcoming the problem, we analyze the procedure, several papers for procedure. Here is the code, and the electrical we are designing the compliance procedure. This is an example of email use as so this video we use augmented reality navigation system to see parking area and the navigation system where humor and non-superior services and first we need taking and here is this is we can detect this property is navigation system and this is a Pokemon. So now we have an idea. So that is a novel technique for fence post tube placement in glioma using robot-guided frameless new navigation technique under the exoscope surgery. And we use Kinebo 900. It has virtual memory function from exoscope position to the microscope position. Here is Kinebo and this navigation so making a plan for fence post tube. Here is, for example, anaplastic oligodendroglioma recurrent case. This is a preoperative MRI flare. Here is a tumor. We are planning two fence post tube like this. I'll show the video intraoperative view. Here is AutoGuide and robotics, and here is okay. So here is AutoGuide. Now projecting with robotics. So it is very easy and very accurately. and doing biopsy, then inserting the tube. And move to the next position. It is easy to move the next position. Then do biopsy and insert transport tube. So another thing is the skinnable can go to the position of microscope. Okay, this is the exoscopic view. So first position is easy to position, to move the position, and insert biopsy and transpose tube. And to the next step is the second position to the trajectory tumor boundary. Then by using this tube and tumor boundary of navigation system, we can take the tumor totally. This is a post-operative MRI here. So this transpose tube placement using our robot-guided frameless stereotactic technique with new navigation and an exoscope. Was highly accurate and allowed to more precise glioma resection. This method is a useful application of recent developments in robotics technology. So this paper was accepted in JNS case lessons recently. The last part, new treatments. There are several new treatments. For gene therapy induces new genes into a cancerous cell or the surrounding tissue to cause cell death. A wide range of genes and vectors are being used in clinical trials with successful outcomes. For example, our research for gene therapy, REG-DKK3, REG is a reduced expression in motile cell. This REG gene is a tumor suppressor gene, and it was found in Okayama University 2000. They are targeting a malignant glioma with adenovirus mediated. Then they are not expressed in tumor cells, glioma cells also, but not express normal cells here. Then we are putting this rate with adenovirus. So then this is an in vivo model. There is significant survival time, prolonged survival here than conventional adenoviruses. Then we performed the translational research to the phase 1/2A. Then now we are ongoing trial. Phase 1/2A of ADSG for more treatment of recurrent malignant glioma. Primary endpoint is to assess the safety. Secondly, one is evaluation of the efficacy. So this is in Japan, open label, single center, and phase 1/2A trial. Non-randomized and 3+3 design, dose escalation. The last one is cancer genomic medicine. So there are several NGS or cancer panel we are performing for the malignant glioma and other cancers. Then so we found NTRK fusion gene for one case. This is a high-grade glomerular tumor. So this patient will have molecular target drug for NTRK fusion gene. So this is today's topic of all of them. So I would like to thank to the staffs, Department of Neurosurgery, Hamad University School of Medicine, and the staffs also Department of Neurosurgery, Okai University School of Medicine University. Thank you very much for your attention.
My name is Tarek Dratli. I'm assistant professor at the Department of Neurosurgery in Dresden, Germany. So WHO grade 2 and 3 meningiomas are common and represent up to 25% of all meningiomas. They relapse very frequently in the first 10 years after surgery, and the genomic profile of these tumors is dominated by inactivation of the NF2 tumor suppressor gene, in addition to other genes that have been found to be frequently deleted or altered in high-grade meningiomas. For example, TER gene alterations, here are mainly TER promoter mutations that are frequent, and about 25% of high-grade meningiomas are acquired alterations. And also TER translocations has been described in a small subset of high-grade and aggressive meningiomas. We have also BAP1 mutations that are frequent in rhabdoid meningiomas and are also associated with poor outcome. Moreover, we have described dystrophin or DMD lesions in a subset of progressive and high-grade meningiomas, like in this case with a very aggressive meningioma that grew within 3 years. And those patients with this kind of lesions has shown a poor survival in the Kaplan-Meier curve. But despite this progress in identifying recurrently mutated genes in aggressive meningiomas, these genes are altered in fewer than 35% of high-grade or progressive meningiomas, suggesting the existence of additional aberrations in other cancer-related genes. But the problem that we face is that the majority of these genomic studies of high-grade meningiomas are underpowered to detect recurrent clinically actionable mutations because of the small number of samples included in the majority of these trials. So that was our motivation to perform a comprehensive genomic profiling of one of the largest sets of WHO grades 2 and 3 meningiomas to date. We have also included a small subset of progressive grade 1 meningiomas. The aim was to assess clinically actionable mutations that we can target with or that we can use for targeted treatment in patients with high-grade meningiomas. The samples originated from over 35 institutions in the US, and they were analyzed as a part of a clinical testing program to capture 406 cancer-related genes at Foundation 1 in Cambridge. The cohort is powered to examine clinical associations and gene-gene pathway interactions to investigate dominant pathways that are contributed to the development of aggressive meningiomas. Here you see the patient demographics. We gathered 850 high-grade and progressive meningioma samples, including 176 WHO grade 3, 441 grade 2, and 220 progressive grade 1 meningiomas. The median patient's age was 57 years. The ratio female to male was 1.2 to 1. Tumor locations included in about 1/3 of cases skull-based meningiomas. Half of the cases had convexity and supratentorial meningiomas. We had a small subset of tumors located in the spine, and also a small subset of distant metastases from meningiomas. Here you see the copy number alterations in our cohort, and as you see here, the most common copy number alteration was loss of chromosome 22q in roughly 85% of cases, followed by loss of chromosome 1p in about 70% of cases. We've also seen a couple of other alterations that were less common, for example, chromosome 18q, 14q loss, or 6q loss. NF2 mutations represented the most frequent gene mutation in about 55% of cases. The frequency of the NF2 mutation increased significantly with the WHO grade. So the higher the grade, the higher the frequency NF2 mutations. So the highest frequency was seen with 70% in grade 3, and the less was in grade 1 with 36% of cases. Male patients were significantly more affected by NF2 mutant meningiomas, so 65% versus roughly 50% in female patients, and that was significantly different. Other frequent genomic alterations that we saw in our cohort included, after NF2 mutations that or deletions that were located in CDK pathway coding genes, for example, CDKN2A or B, CDK4 or 6, in roughly 20% of cases. About 7% of the cases in our cohort included a TERT promoter mutation. We saw also frequent R801A mutations, KDM6A mutations, PTEN loss, TP53 mutations, SUFO, BAP1, and polybromine-1 mutations. And if you look here, you see that the majority of these cases occurred in WHO grade 3 or 2 meningiomas, and very infrequent in grade 1 meningiomas, whereas AKT1, PIK3CA, and smooth mutations were more common in the red bars meningiomas, so in grade 1 meningiomas, and very infrequent in higher grade meningiomas. This comprehensive genomic characterization suggested that high-grade progressive meningiomas could be separated into largely distinct classes. So we divided the tumors into 3 overall subclasses, and now I'm showing you the most important slide of this talk. So we divided the meningiomas into 3 subclasses. The first subclass that we called the canonical NF2 mutant subclass. So this group included about 50% of all meningioma cases in our cohort and represented the largest group of tumors. The vast majority of tumors showed chromosome 22 loss, roughly 100% of all cases, and about 75% had also loss of chromosome 1p. We observed also an enrichment and alterations of CDK into A and B deletions, and in terms of mutations, R801A, KDM6A, PTEN, SUFO mutations. The majority of mutations, or the majority of tumors in this cohort, were graded as grade 2 and 3, and the smallest part was, or portion of cases was in grade 1 tumors. but the male patients had more NF2 mutant cases than female patients, as reported before. And the second cohort that we called NF2 agnostic included 10% of cases. The median age, similar to the other one, was 60 years, was equal between females and females. Tumor location was a little bit more convexity than skull base. It included the majority of grade 3 meningiomas and also a subset of grade 2, but a very small fraction of patients with grade 1 meningiomas. TERT promoter mutations and TP53 mutations were the most common mutations in this NF2 agnostic group. Also, the majority of these cases have shown chromosome 22 loss, and 1p loss was even more common than the NF2 mutant canonical group. Also here, 1/3 of patients showed a deletion of CDKN2A or B during progression. The third subclass that we divided into 3 groups was the one group. This is an important group with about 5% of all cases, with a median age of 52 years, more females than males, more convexity meningiomas, more grade 3 than grade 1 or 2. And this subset of tumors had very frequent BAP1 mutations in rhabdoid meningiomas and polybromo 1 mutations in papillary meningiomas. Chromosome 22q loss was not as frequent as in the other group. Also, 1p loss wasn't that frequent. In a small set, also 5% of cases in a group that is dominated by grade 1 meningiomas and more skull-based located meningiomas with a median age of 52 years, we saw frequent AKT1, PIK3CA, and smoothing mutations, and also infrequent loss of 1p, and in half of cases, a chromosome 22q loss. In 30% of cases, we had a subset of patients with similar median age with 52 years, more dominantly female patients, equal convexity to skull-based locations, more grade 2 graded, but with unknown recurrent genetic alterations. So in this group, 30% of cases, we couldn't identify a driver gene. But here we saw in 60% of cases chromosome 22 loss and 1p loss, but nothing else that we could trace back to this kind of to this subset of mutation group. So as shown here, polybromo 1 is a gene that is highly interesting and is frequently altered in papillary meningiomas, and this is a paper that we published last year showing very frequent truncating mutations of polybromo 1 in papillary meningiomas. The interesting facts about polybromo 1 are, for example, that it resides on chromosome 3p21 adjacent to BAP1. So BAP1 again is frequently altered in rhabdoid meningiomas and polybromo 1 in papillary meningiomas. So it resides adjacent to BAP1. It encodes a BAF180 protein that is important as a subunit of the PBAF chromatin remodeling complex, and it has been described to be frequently altered. So polybromo 1 is frequently altered in clear cell renal cell cancers. So summarizing our data, the patterns of genomic alterations in high-grade progressive meningiomas commonly group these tumors into 3 different categories. The most common one, 50% of cases, is NF2-associated canonical group, and it frequently harbors CDKN2A and B alterations. The second group that we called NF2 agnostic group harbored frequent TERT promoter and TP53 mutations, in addition, of course, to CDKN2A and B deletions. The final subset is distinct from the canonical NF2 mutant associate pathway, was partially characterized by BAB polybromo alterations, mainly in rhabdoid and papillary meningiomas or skull-based disease. So our vision is, or we envision that, as with medulloblastomas, gliomas, and other CNS tumors, our finding will aid the transition towards a similarly integrated diagnostic approach for molecular subclassification of meningiomas. And of course, we think that the molecular subclasses of these aggressive meningiomas will have significant implications for the design of therapeutic trials, mainly for targeted treatment trials. So when you identify a gene that you could target by any kind of an antibody, that is the future for the treatment of aggressive and high-grade meningiomas. Those are the two publications that I've reported on in my talk. Hopefully you will enjoy reading them. Finally, I want to thank all my collaborators, mainly in the US, Daniel Cahill, Priscilla Brasianos, Dr. Wakimoto, and others who contributed to my work that I've shown you today. And I thank you very much for your attention, and please contact me if you have any questions to my talk or any kind of questions about meningiomas. I'm very happy to keep in touch with you and to talk with you on your research. So thank you very much, and please contact me if you have any questions. Have a great day. Thank you.
Hello, Dr. Lee.
So platform is open for the discussion. Any doubts or questions from the panelists or from moderators?
Adi, you don't have any question for panelists?
Hello, Professor Kato. It's early morning here.
Oh, really?
I'm glad to see Professor Grottenhoy. I have met him during my Acns courses.
Oh,
so
okay.
I'm really glad.
Hmm.
Yeah, I just have one more to finish. So I'm so glad that we have you here with your wonderful
It's
talk.
indeed, it's still night actually here. It is still dark, but then.
Yeah, here also it's quite dark and cold. And I'm so glad that you have joined our seminar. And thank you for your wonderful presentation. And we have learned a lot from your experience.
But technically didn't go well. There was hardly any sound. It started way too early, so half of the lecture was already gone before it actually, because there was still this ceremony for the Young Neurosurgeons Award. But that's okay. That's how it is.
Yeah, we had some technical issues.
Webinars. Yeah.
That was
Hello, Dr. Kazu.
Hello. He's apparently muted now.
No. Hello, Professor Kazu.
Yeah.
So yeah, your presentation is very interesting. So I wanted to ask you one question. So how many exoscope operation in your department every year? How about the situation in Japan?
Now just I'm like renting, so just trying to use, but we don't buy that yet. So, but I have experience to trying to use exoscope many types. So the so 4K vision is OVI, that is Olympus, and so size also 4K, and yeah, most of them are 4K visualization. Then it is easy to use. Now it's OVI system, and storage system is also very smaller. Then that is also very useful. And for glioma surgery, we need tumor boundary with navigation system. In that case, we are using microscope types like Zeiss or Leica. Like that. So.
Yeah, that's very interesting. So I'm interested in your presentation just now. So maybe in China, actually, in China right now, there's not too many exoscope operation. Yeah, it's maybe people know this concept. We haven't used in clinical right now.
We just started that using exoscope from 2017, 16 or 17.
16,
yeah,
17. Okay.
Yeah. Then now the number is very increasing. So many hospitals are trying to use or buying exoscope because a little cheaper.
More cheaper.
Yeah.
Cheaper. Yeah.
It's cheaper than an operating microscope. Personally, I found it still difficult. I wear glasses. So if I have to put 3D glasses over my glasses, it's I still find that very uncomfortable. I hope because in the gaming world, they now already have 3D screens. So there is a possibility that in the near future we will have 4K screens and cameras, and we don't need any 3D glasses. So that would be an advantage then to see. But I know that in the gaming industry that is already developed and it's now in their initial phase. And usually that's where the money goes and not to medicine.
Yeah.
But for the companies who develop this, much more money in gaming, but we can profit from that. Many developments in neurosurgery, technical developments, have been from the military, from space and air industry, and gaming. That's the way it goes. Yeah. So let's see.
At least we will have a new generation of young neurosurgeons who will be already trained for exoscope. I have a question for both of you, for Professor Gottenhoy and Professor from Japan. What is your current opinion about the limitation of exoscopic surgery and how to overcome limitations in deep-seated lesions, since you have also the great experience in endoscopic surgery? How to overcome the working in the deep lesions, as for example cellular tumors, etc. How can we go through
that? Well, please go ahead.
Okay. So that is a very good question. So yeah, so exoscope is very wide view, and so the near area is very nice, but the deeper area is a little bit it is hard to see because lightning is less. Then I think we need to combine with endoscope. Yeah. So surface area is exoscope. Then so deeper area is we're gonna use endoscope.
Yeah, I fully agree. The current systems are not even useful for, let's say, a standard pituitary case. You can't do that with an exoscope. So it's very nice for, you can even do some superficial spine, you can do spine cases, but you, and superficial brain, but any deep-seated, let's say, skull base, petroclival, and certainly endonasal approaches are simply not suitable. And then I said we have combined endoscopic endonasal with microscope, and why not with an exoscope then? I mean, there is one thing that people often don't see, but if you sit in a certain position, ergonomically with the exoscope, it becomes easier. So it is less tiring for the surgeon itself. The second part is if you are in a teaching hospital, much more of the team can really be part of it. They really see what you see. And when I look through the microscope, they don't see that. I mean, you have the tube, the observing tube, but it is never exactly the same quality of image. And now the whole team can have that same image. Maybe one of the advantages my colleagues say of wearing these glasses is that you are not distracted from the surrounding. You are fully immersed in that area. But we know that we have to take an instrument from the nurse, we have to put it into the field, and these are all the little things that are maybe disturbing them.
Okay, thank you. Thank you for your answer.
Okay. Good morning, good evening, good afternoon, or good whatever. It's a great pleasure to be part of WFNS Foundation and an honor to give a lecture on WFNS Foundation event. My task today are the intramedullary tumors. I have nothing to declare, and the outline of the lecture will be that first I will show you the series and the spectrum which we treat the diseases, then how I do it, that will be the main bulk of the lecture, then some general perspectives in spinal cord tumors, and of course conclusions at the end. So what did we do over the past 22 years? There were altogether 224 mass lesions within the spinal cord. Main bulk are the ependymomas, which compose nearly half of the patients, then gliomas, low grade, only one was anaplastic, hemangioblastomas, out of 34 cases, 3 were von Hippel-Lindau disease, and 33 cavernomas. All the other diseases were rather rare, so I will show you only these 4 main groups. How I do it? Cervical and lower thoracic in prone position, the same position as for posterior fossa. Only the lower thoracic and lumbar part I am coming from the side. It looks like that. This is the regular position for cervical spine. And here I would like to show you that you easily reach lower thoracic spine. This is the full-grown nurse of our department, and you still may sit in the regular position as for any other surgery. Only once you do not reach there, you just come from the side, and then you may help yourself by the inclination of the surgical table to have a good ergonomic access to the lesion. So, majority of the tumors are cervical. The specific group, Cora equina ependymomas, I didn't include them here unless they affected the spinal cord conus. Very few tumors are exophytic. I will show you a few of them. Majority of them are truly intramedullary tumors. What do they have in common is slow development of clinical symptoms. Majority of them are benign, and most of the patients are coming with pain only. It's like 75–80% of patients. Just some general remark for respective tumors. For ependymoma, it's a midline lesion usually, so you use the midline approach, and you do not perform myelotomy. You sharply open only the ependymoma. And at the end of surgery, at the end of resection, there's a question quite frequently, the question of anterior spinal artery, which you must not harm at all. Upper and lower aspect is difficult, but always cyst helps, and cysts are present really frequently. Low grades, there are partial or subtubular resections, leave the cyst wall behind. In hemangioblastoma, there is usually a very good plane of dissection. They behave like AVMs. Keep the draining vein at the very end of surgery and never ever enter the lesion. The bleeding is almost impossible to stop. Cavernomas, those are not midline approaches. Here it's usually through the surface area. Not always these spinal cord cavernomas are compact as they are in the brain. They may be like diffuse and sometimes difficult to distinguish what's still cavernoma and what is the surrounding tissue. As to the coagulation, only the lesion vessels, otherwise not at all. Whenever possible, avoid coagulation. Monitoring is a must. At present time, I don't think that there is any reason to operate on spinal cord tumor without monitoring. Monitoring is probably the most important. Intra-op MR, we have done several surgeries in intra-op settings. On one, it was helpful. Otherwise, it's not of use because spinal cord is not really that good target for imaging. We do always laminotomy, always one above and one below. The urotomy is either in the midline, in most most frequent approach. Very rare on the side of the tumor. Then insert the monitoring electrodes, dissect the arachnoid membrane, keep the arachnoid open with the hemoclip, define the lesion extent, define the midline. It's sometimes not that easy because spinal cord may be distorted by the tumor. The best mark are the entering vessels into the midline. Cut the ependema, and then open the cord. Open it like a book. It's rather most important maneuver to find the midline. Ependema duras is to keep the cord opened. It really helps very much. Bloodless field all the time. Find the tumor cord plane. When you find the tumor cord plane, then use it. And if it's difficult to define, then come from other direction, from other side, from above or from below, then suddenly the plane appears. Resect the tumor, obey the electrophysiology, of course, that's important, and suture the ependema. In all our cases of midline approach, we always suture the ependymoma, and not only, sometimes even in lateral approaches. So here's the laminotomy, which is performed, and we shall start with ependymoma. This is what I have said about the general rules. Insert the needle, the electrode, then dissect the arachnoid and keep it open with the hemoclip. It's rather helpful if the arachnoid doesn't hinder your approach. Use the scissors as much as possible because the sharp dissection is always better, not with the tumor itself, but sometimes even for the tumor dissection. And then define the midline. It may not be easy. In this case, you see it rather nicely. Then I do not hesitate to coagulate the dorsal vein. It doesn't make any, produce any deficit. And then just going through the midline, cutting the ependema only, as you see now. And then it's blunt dissection to reach the dorsal aspect of the tumor. These ependymomas are usually torpedo shaped, so if you would be able to find the okay, it's again the same thing. So over here, if you will be able to find the upper and lower aspect from the most bulky part of the tumor, again cutting the midline in this case and coagulating these tortuous veins on the surface. Then when you are opening the cord, you would like to preserve all the vessels which are running on the sides of the split cord. In fact, and here we are reaching the dorsal aspect of the tumor, which is exposed, and now it's only the question to find the proper plane of resection, which already is here, and you see that even in the anterior side of the tumor, the vessels are preserved. The vessels are preserved here on the lateral walls of the cavity, and at this stage, the most important is really anterior spinal cord artery, which must be preserved. Go forward. This is another ependymoma, and some of the tumors are not really midline, but they tend to grow in one side. In this case, it's on the left side of the spinal cord, and you see that the midline is being shifted to the right, so you must follow it to the right, preserving these vessels, and then just finding the true proper plane, keeping the cord open with ependymal neural stitches, and suddenly the tumor appears very nicely and very well defined in front of you, with the vessels on the side walls preserved, and now it's only the matter of tumor cord dissection. Another tumors, see how I'm looking for the plane of dissection, which is over here. It's usually shiny and very smooth. Once you find it, you just follow it, and if you lose it, at one point you would like to come from other side. Here we are on the anterior border. This is the anterior spinal artery, which must be preserved here. Even the ependyma on the anterior side had to be cut. Didn't matter. Another tumor which is on the side, which is in the right side of the cord, and you see that from the left part of the spinal cord only a tiny tissue remains. There are traversing vessels from one side to the other. It means that we are not in the proper midline, but it doesn't matter because we never ever entered the cord. And now the dissection continues in the full length of the lesion. Very nice plane of dissection at this point, and you still go on preserving those traversing vessels which remain there. Now coming from below, you are just lifting the tumor. All the manipulation is away from the neural tissue, not in the direction of the neural tissue, and you just are able to resect the tumor completely. And once this is done, the careful hemostasis without coagulation, just some flushing, just some floss seal may be used, and then the spinal cord will be closed with running suture with 8/0 nylon. The good instrument is a very sharp forceps, which really you can depend on, that they will hold, they will not slip, and you use it to release the tumor from the cord. There are various bands, and forward. This was rather curious case of ependymoma which grew exophytically and intramedullary. You see the image on your left hand side. It's difficult to say that it's exophytic or not. Here is one of the exophytic nodules, but there is quite a lot intramedullary above this nodule. The lower part of the tumor already has been resected, and now you see the bands which are sharply cut between the cord and the spinal cord tissue. You wouldn't have a single free moment in spinal cord surgery. The surgeon must be focused at all the time, because one mistake is one more above the norm. One mistake means paraplegia or quadriplegia. And once you resect this tumor, which was not really easy, it was an ugly ependymoma. You can even use some force as long as you know where the structures are and where is the plane of dissection. Now the spinal cord is already closed by the suture. This is a rare exophytic tumor. You see that it grows really exophytically, but always there is a point where the ependyma is affected. Another case like that, rather easy for resection, and one which ended up badly. This was the first tumor we've seen and resected. The attachment to the ependyma was very small. It was grade 2 ependymoma. A year later, the patient came back with cauda equina tumor, which we resected. In another year, the lady was back with the tumor in CC junction. This was resected, but still, in another year, the patient died due to supratentorial relapse of the disease. One of the large ependymomas, which is reaching even the oblongata. This is before and after surgery. So let's go to astrocytoma. This is a different matter. You not always are able to reach the total resection, unlike in ependymomas, but still the basic law of resection is exactly the same. You see that you are approaching the tumor through the midline. There are attaching suture between ependyma and dura. And once you define the tumor, you are looking for some interface. And usually in astrocytomas, there is a good plane of dissection at certain points, but not at all. So you must be very careful not to enter the spinal cord tissue and resect only the tumor tissue, again the traversing vessels. And this is by the end of surgery, where there are remnants of the tumor on the spinal cord's inner surface, but it's better to leave them behind, and it's better to get oriented according to electrophysiology. Once the potentials go down, it's better to quit. And suturing the ependyma in a usual manner as in all other cases. This is the only high grade we ever had. Even in these high grades, one can achieve gross total or subtotal resection, but it's not really that easy. You see the tumor already on the surface. It's a bloody even, but take a look that we really achieved rather nice resection. The patient was subjected to all the oncological treatment, but obviously in 2 years the patient died. This is partially exophytic tumor at CC junction. It's C1, C2. And it's important not to resect it on the first side. It's better to get very well oriented what spinal cord tissue, what's not. You see that the root of C1 is within the tumor, and this is the spinal cord tissue. This is not the tumor, despite the very similar look, and you may be able to resect it, and this is the final result. That was subtotal resection. Hemangioblastomas, those are nice lesions within the spinal cord, and they have exactly the same rules as the AVMs in other locations. Keep the draining vein as the last, at the very end. Find the proper plane of dissection. Do not enter the lesion. By no way don't enter it, because it's almost impossible to stop the bleeding. Unlike in AVMs, you manage. In hemangioblastomas, you usually don't. They quite frequently have very nice plane of dissection. It's something like a gelatinous tissue in the vicinity of the lesion, and as long as you follow this plane of dissection, the hemangioblastoma is rather easily resected unless you enter the lesion itself. Here's another one. Again, you see the MR on the left-hand side, the cyst, the hemangioma itself, and the draining vein. And again, same approach, this time not through the midline, but directly to the lesion, looking for the plane of dissection and keeping the draining vein as the last point of resection. Takes time, it's good to go slowly. Carefully, you see that the vein is already dark, and now even it's not midline approach, we suture the ependyma. Another one, not really a big one, but in the anterior part of the cord, here it's very, very helpful if you make the approach a little larger, one above, one below, opening the dura, finding the dentate ligaments, and use the dentate ligaments to rotate the cord anteriorly, and suddenly you have your anterior lateral quadrant just in front of you, and the surgery is rather straightforward. There were major draining veins at the upper portion of the lesion, but still the resection was performed in a usual manner, just outside the lesion itself, never entering the spinal cord tissue. You see that this is not the spinal cord tissue, only here we have the spinal cord tissue. This is the surrounding gliotic vein. Another hemangioblastoma, it can be said that it's in CC junction. Here is the angiography. This is before surgery and this is after surgery, and see that in the bed of the lesion all the vessels are preserved and the patient is perfectly well without deficit. Another hemangioblastoma sent to us under the diagnosis of AVM, which in the referral hospital was done according to the angiography. This is the hemangioblastoma, which is exophytic, but still with the hemangioma, you must expect that at one point it will be growing through the ependyma. It was perfectly true at this point in anterior quadrant of the cord. This is after the section. Cavernomas, they are nice, the cavernomas of the spinal cord, but they have some tricks and specifics. This is the same atypical vein as in brainstem cavernomas, for instance, so such a vein should be preserved. It's not frequent in the spinal cord cavernomas, but you may encounter it, and in this case it was here. Just find the border of the cavernoma and slightly inwards you would cut the ependyma. You see that the ependyma is cut, and then in a usual manner, going in the gliotic tissue around the cavernoma, you would like to resect it, but this is not always that easy in spinal cord, because spinal cord cavernomas looks like more diffuse lesions. Sometimes you are not sure whether you still see cavernoma or whether you see the gliotic tissue in the vicinity. It's like here you see that the cavernoma is not really a compact lesion. So sometimes they may be rather difficult to distinguish where is the proper plane of resection. Another one, which is partly exophytic but still covered by ependyma. Thus, ependyma will be cut only above the lesion, and then the whole lesion will be resected. And this is a compact one, it's a nice one, and this is the resection cavity. Another one, the lateral aspect of the cord before and after resection, and you see that this tissue remains behind, just to make sure that you never ever enter the spinal cord. This was a young lady with 2 cavernomas of her spinal cord and burning pain in thoracic 6 segment. So we went for them at once. This one was located in the anterior aspect of the cord. When we resected this one, the MEPs went down, so we stopped the procedure and came back in a week to resect the upper one. The video is only from this upper one, but this is the lower one which we wanted to see again because it was not really compact. And see that we are on the anterior aspect of the cord, which is rotated by 3 stitches via dentate ligament, and now the cord will go in its proper position, slowly turning back to the regular anatomical position. So even the anterior cavernomas may be easily approached, and this is the upper cavernoma which was approached through the midline. The lady now is free of her original pain. This is a young boy, he's 17, with cavernoma in the anterior part of his upper medulla or lower oblongata. He was asymptomatic only after the physical training. He has had a headache, so they had MR done, and he was a representative in ice hockey, which is very popular in my country. So the parents came in because he was kicked out of the team, of course, once they are diagnosed, and they wanted me to resect the cavernoma. I didn't want. I was very much afraid. This is the first approach. It's far lateral. This here is the cavernoma, but whenever we did any manipulation from the side, the MEPs and SEPs went down. So we quit the procedure, went away, and this was the second surgery going directly from posterior through the midline to the anterior part of the cord, just slowly removing the cavernoma, which fortunately in this case was very compact and very nicely delineated against the surrounding tissue. Here is the final steps of surgery. You see that we were really just below the CC junction. There's the cerebellum, and here is the midline approach, which is now sutured. And here are the images after the surgery. The spinal cord is virtually divided in two, but the boy is asymptomatic. And fortunately, he was accepted to the ice hockey team again. Another cavernoma, which is not really that well defined. It's more like a diffuse lesion because there's a lot of tissue in the vicinity of the regular cavernoma, which looks like cavernoma, which is not cavernoma, which is not the spinal cord. So this gives you some freedom of movement, these old bleedings probably, and you resect the cavernoma just as it is. But really, to be quite sure that one did a proper job, it's sometimes difficult suturing the ependyma at the end. So what about the whole series? We were able to resect the lesion radically in 72% of cases. In another 10% of cases, it was subtotal or gross total resection. So only in 12% of cases, the resection was partial. And in 6% of cases, we did biopsy, only that we didn't have the delivery to resect the tumor. I have stressed the importance of intra-op monitoring quite frequently, and this is how we proved that, or we all accepted the idea of intra-op monitoring, of course. But this is the historical control, and look that the radicality was 31% only once we started monitoring until 2009, but we started in 1998 or 9. You see that immediately the extent of surgery increased dramatically. It's of course statistically significant figure, and this is probably the most important image of my presentation. This is the McCormick grade 1 through 4, and see that operatively we have 47 patients in grade 1. 1 year postoperatively 51. There are no differences. The patient remains in the same McCormick grade as he came in. The improvements are rare, the deterioration even rarer. There is only one group where there is a change from McCormick 3, the patients went to McCormick 2 in the first 3 months after surgery. Then the changes in the grades are very, very rare and seldom. Fortunately, some 75% of our patients were McCormick 1 or 2, not wheelchair. They were really extremely rare, these patients. But this is the main fact I would like to convey, that the patient should be the same clinical condition after surgery as he was before. You cannot expect too much of an improvement. The perspective of the whole neurosurgical department, we had 224 spinal cord lesions, which compose only 0.3% of total surgery, so it's very negligible. It means that we have something like 10, 11 intramedullary lesions per year. It's one surgery per month, so it's by no means routine surgery, risk-free. It's a really seldom surgery, which always is very original and very, very carefully to be planned and executed. Definitely it is not spinal surgery. It's brain surgery, in fact, because all the experience you can get is from the brainstem and deep-seated lesions in the brain. It's low-grade ependymoma, hemangioblastomas, cavernomas of the brainstem, whatever. There is the experience which you transpose to the spinal cord. Extra-intelligence like meningiomas and schwannomas are nearly the same number, but they are completely different matters. So this is not the experience or the basics of experience for spinal cord tumors. The basic of experience are brainstem lesions. This is what my old boss told me, that any manipulation must be directed away from the neurostructures. I remember this for the past 40 years. I heed it, and I can tell you that this is probably the most important advice in neurosurgery I ever got. So in conclusion, the patient after the surgery should be in the same clinical condition as he was before. Please keep this in mind. Don't be too optimistic and offer improvement. Don't be too pessimistic and warn the patient about deterioration. Minor post-surgical deficits will improve. There are some deep sensation may be harmed by the approach, maybe some movement deterioration, but as long as the evoked potentials do not drop to zero, it always will improve. The lower the étage, the more difficult the resection. I really hate the conus lesions because it's almost impossible not to produce any deficit in urination or other functions like that. Once diagnosed of a surgery, there is nothing to wait for in spinal cord lesions, unless the patient is really high age and multi-failure, then you offer the surgery, because waiting for the deficit doesn't bring anything, and all these lesions do either grow or bleed or pose some risk for the patient. It's not surgical surgery in a way, it's a surgery directed by function, and quite frequently I like to say that the most important person in the OR is the electrophysiologist, because he warns you. Once he warns you, you go to the other side of the lesion, or you even quit for a while, trying to find the other place where the functions do not deteriorate, or ultimately you quit the resection. So this is the important guy in all those surgeries. So thank you very much for inviting me to this WFNS Foundation event, and thank you for your patience with my talk. Goodbye.
Hello, everyone. Good afternoon. Thank you, Professor Yoko Kato, Professor and the President of the Asia Congress of Neurological Surgeons, ACNS, invited me to share my experience about the interhemispheric approach for cellular and third ventricular tumor, especially in the pediatric patient. I am Mu Li Liang from Magai Memorial Hospital, Taipei, Taiwan. First, I introduce myself briefly. I completed my neurosurgical training in the Department of Neurosurgery, Taipei Veterans General Hospital, Taiwan, on 2002. Then I obtained the position as a staff of pediatric neurosurgery and followed the Professor Tai Tong Wang, the pioneer of pediatric neurosurgeon in Taiwan. In 2005, I received 1 year's fellowship training at the Hospital of Sick Children in Toronto, Canada, and the Arthur and the Sonia Levitt Brain Tumor Research Center, then back to our hospital for the clinical service for the children. Since 2020, I moved to the Mackay Children's Hospital, Taipei, Taiwan, and established the pediatric neuro-oncology multidisciplinary team and integrated the protocol-based surgery with the radiation and the chemotherapy for children with the challenging brain tumor. The topic I will share is the second common tumor location in children, next to the posterior fossa. According to the database, the cellular and the supracellular tumors accounts for 13 to 16% of all CNS tumor, which include different pathologies. The image of MRI usually show combined solid and cystic lesion with heterogeneous component, like in the left side figures. The average prediction accuracy rate is about 70 to 80% in the literature. Therefore, there are about 20 to 30% tumor did not correctly diagnosis if we did not have the pathology only by the image finding. For the large supracellular tumor, cystic part mostly is craniopharyngioma, a dermatinomatous type, is likely since the high prevalence in this age group. The average solid and cyst volume ratio is about 0.2 in our 25 cases analysis. However, the image, the similar finding of large cystic tumor, the pathology could be distinct to the craniopharyngioma, like this cystic glioma in the right side figure. Therefore, the pathology, the confirmation is very important. We should decide the extent of recession and further adjuvant treatment according to different pathology. Like a supracellular germ cell tumor, not only the surgery, the adjuvant treatment is very important, especially in the non-germinatus, the germ cell tumor. The route of approach is chosen by the surgeon's preference. For me, if the intracellular component is large, I choose the endonasal route, like the left side figure. If the supracellular part is bigger, concha type, or poor pneumotylation of sphenoid sinus, I choose the subfrontal or interhemispheric approach. Many routes of tumor located on the supracellular and the third ventricle could be applied, including many choices in the left side. And I prefer to use the anterior interhemispheric approach in the pediatric patient because the frontal lobe is not so deep. This approach is flexible. If the tumor is more extensively combined with anterior callosotomy, obtain the trajectory into the deeper third ventricle or even prepontine space. And also we could combine the subfrontal or even Terence or transient approach. We could obtain a more lateral side, the angle to the carotid triangle laterally. The surgical corridor and the surrounding neuromuscular structure that must be kept in mind. So the relation of optic nerve, the chiasma, carotid A1 and A2 segment is variable. We also must take care when the lesion or tumor had already shifted or wrapping the important structure from the original position. We should be aware there are many variations of recurrent artery of humor and the branches of ACA arteries. It is quite complex sometimes. 2 or 3 ACAM is possible. You should be very careful to identify individually. For the lesion located or extending into the anterior or posterior third ventricle, we could choose either anterior or posterior transcallosal approach to obtain a more wide angle inside the third ventricle. The anterior callosotomy starts from the tip of the rostrum and the granule of corpus callosum, depending on the lesion, and then we could perform the incision downward to the lamina terminalis and the anterior commissure. So the lower limit is the optic chiasma and the ACAM of ACA, and the colon of Phoenix and the foramen of Monroe is the posterior limit. The posterior callosotomy will follow the transforaminal or interphoneal approach. The two will dissect the callosotomy from the coronal suture plane 2 centimeters posteriorly and incise longitudinally between two pericallosal arteries. Either transforaminal or interphoneal route is the next step. The anatomic borders of third ventricle are shown in the figure. When we perform the anterior callosotomy, the bilateral colon of phonesis and the septum pellucida should be separated bilaterally to enter in this route to the third ventricle. If the craniotomy goes down to the frontal basal, the opened frontal sinus should be protected. I usually use the pericranial flap, reflect it and cover the open frontal sinus. The point is to preserve the blood supply from deep branch of supraorbital artery to keep the flap vital. The frontal basal approach was first proposed to treat ACAM annulus, a tumor close to this location in the literature. And through different trajectory, a wide range of midline lesion from the sella to the posterior part of third ventricle, even the pineal region tumor could be reached. Except the standard bicoronal scalp incision, we could also modify the incision to jagged fashion, like in the girl figure. For cases with the suprasellar tumor, the tumor had already elevated the ACAM, A1, and even the chiasma. We could choose the frontal basal approach through the pre- and the subchiasmatic route to remove the tumor totally. For tumor located retrochiasmatically, sometimes extending to the anterior third ventricle, we should go through anterior callosotomy interhemispheric and to open the lamina terminalis into the third ventricle. So this is a 6-year-old boy with cranial pharyngioma, compressed optic chiasma. We perform the right side interhemispheric approach. The cortical band could be preserved as much as possible. When we dissect the bifrontal lobe carefully along the midline, the olfactory nerve should be freed from the frontal lobe to preserve the olfactory. So the tumor wall was identified when we dissect the frontal lobe. And we could fenestrate the cystic wall first and aspirate the xanthomatous fluid for the decompression. After shrinkage of the tumor cyst, we could dissect the surrounding wall of the tumor gradually to protect the surrounding optic nerve and the optic chiasma. There are a lot of solid components inside the craniopharyngioma, as we know, a lot of calcification should be dissected and removed from the inside. And then we could shrinkage the solid part to remove the tumor wall piece by piece. After we remove most of the tumor, we have to take care the pituitary stalk is behind, just like in the image. So we remove the tumor beneath the aptichiasma more carefully, because sometimes the tumor will attach on the subventricular floor, tuber scenario. So the last piece of tumor is still there. So we have to dissect the last piece of tumor carefully to preserve the pituitary stalk and the tubular scenario on the subventricular floor. We use the sharp dissection to remove it very carefully. Let's damage the hypothalamus. So the pituitary stalk were well preserved from every angle and connected to the pituitary gland, just like in the video. So the pre and the post-operative MR image of every card show totally resection of the tumor and the well preservation of pituitary stalk on the figure below. For the tumor located on retrochiasmatic with extension to the posterior third ventricle or even the prepontine space, we have to perform the transcallosal to obtain more longitudinal trajectory to the deepest part of the tumor. This trajectory goes directly to the retrochiasmatic and the prepontine space. However, ACOM and the pituitary stalk should be very carefully identified and carefully protected through this approach. Okay, so this is the 15-year-old boy with a large third ventricular germ cell tumor. We performed the AIH and the anterior callosotomy, dissect through between the septum pellucida, and also open the lamina terminalis. So after we open the lamina terminalis, we could identify the tumor inside the ventricle, third ventricle. Fortunately, the tumor was solved, so we could use the QSAR to remove the tumor gradually till the near total resection of the tumor. At the last step, we use the angled mirror to identify if the retrochiasmatic space has any residual tumor. So this is the angled mirror to check the deepest part if our microscope cannot identify the retrochiasmatic. So post-operative image still show there is some residual tumor inside the pituitary fossa, which could be treated by the adjuvant therapy. So this is a more extended tumor, craniopharyngioma, into the subventricular and even the prepontine space. Even tumor extending like this through the interhemispheric translamina terminalis and combined with subfrontal approach, the tumor could be nearly total removed on the lower figure below. For the tumor located on the retrochiasmatic region, and which extension to the posterior third ventricle and the prepontine space. Sometimes the posterior transcallosal approach is applied and also a good choice. In this case, we perform the interphoneal route between the septum pellucida. Due to the presence of the fifth ventricle, there's still a space we could go into the third ventricle, just like in this case. The other choice is the transforaminal route. Could be used if the size of foramen of Monroe is large. We could carefully split the talon colloida between the fornix and the choroid plexus and the internal cerebral vein to enter the third ventricle. However, the corridor is smaller, so if the tumor is very solid, this approach is more difficult. Okay, for this tumor, craniosphenoid meningioma, this is a more solid tumor. In this situation, we always use bilateral interhemispheric approach. We open the dura, and then we suture ligate the anterior tip of the sagittal sinus and cut the falx. Then we dissect the bifrontal lobe into the deepest part of the tumor. When we open the bifrontal lobe completely, the tumor could be exposed. So the exposure is wider than the unilateral approach. For the solid and hard tumor, it will be more easier to remove it totally. So as we know, the meningioma is hard. We have to debulk the tumor centrally and then remove the tumor by the QSA. Then the tumor wall was pushed centrally to protect the surrounding neurovascular structure. In addition to decompressed tumor mass on the optic chiasma, the most important thing is to preserve the pituitary stalk in this area. So after we remove most of the tumor, we could identify the pituitary stalk behind the tumor. So this is the pituitary stalk we identify. So after we remove the tumor, we have to make sure the pituitary stalk is intact and well preserved. There is still a small piece, so we have to remove it. So the first, at the last step, after hemostasis, we will resuture back the falx in position before we close the dura. So this slide shows the post-operated MR image. We could see the tumor is totally removed, and the pituitary stalk is well preserved on the MR sagittal view. So this is very important for the long-term hormone and the neurocognitive function if we completely preserve the pituitary function in this area. So after we analyzed the last 10 years, we had already performed 25 cases craniopharyngioma operation through this anterior interhemispheric approach. The complication rate regarding to the perioperative stroke, visual deterioration, and the recent memory impairment is about 12%. So the pathology mostly is a demyelinomatous type. There are still 2 cases is papillary variant. And we could achieve a gross or total recession in about 80% of the cases. In the literature, the antegrade amnesia due to the phoneal damage is possible and will happen in around 20% of the cases. The other potential impairment include executive cognition and the behavioral problem. It sometimes happens. The other very important complication is the vascular insult. It did not happen so frequently. However, for the patient, they will cause the long-term dead sequelae of the patient. Mostly it happened is the recurrent artery of the humeral. It will result in the hemiparesis, aphasia, and the dysarthria if this area is located on the dominant hemisphere. Anosmia due to the damage of unilateral or bilateral olfactory nerve sometimes happened, depending on the elevation of frontal base. So we have to release the arachnoid nerve, arachnoid memory surrounding the olfactory nerve, and to free the nerve to obtain more space. And we don't want to elevate the frontal base directly because they will injure our olfactory nerve. The visual deterioration is always the risk for the tumor in this location. We have to protect the microvascularization of the optic nerve and the optic chiasma in every way to preserve the visual function. So sometimes when we use the intracystic injection for treat the cystic craniopharyngioma, the vision sometimes will be damaged due to the chemical meningitis. So we have to take care and be careful. The cystic fluid should not be leaked into the CSF space. Conclusion. The frontal, basal, and the anterior interhemispheric approach are optimal choice for the midnight cellular and the supracellular lesions with the variable pathology like a germ cell tumor, craniopharyngioma, or glioma, or even the meningioma in this location. For tumor extending to the prepontine and the third ventricular region, combined anterior collosotomy section provide a further trajectory to the retrochiasmatic or even prepontine space. It's very helpful to remove a large tumor in this area. So this is my talk. Thank you for your attention.
Hello, I'm Yasushi Shin from Osaka Police Hospital, Japan. 2030, I went to Charité in Berlin, and I met Professor Peter Baikozzi and Professor Bernard George. And I'm interested in the minimal invasive concept and keyhole surgery, so I went to Sydney. I met Professor Chariteo. Last year, I had organized a spine meeting jointly with Asia Pacific Cervical Spine Meeting. So I would like to show minimally invasive spine surgery in hybrid operation room. I have no financial relationships to disclose. There are some concepts for minimally invasive spine surgery, such as a small skin incision visualization, endoscope, exoscope, and practice system, image-guided surgery. With the dramatic progress of medical modalities and the growing need for high-resolution intraoperative imaging in minimally invasive surgery, hybrid operation room has been developed as a powerful tool for different surgical scenarios. We use Artist Zigo. Zigo is a 3D imaging system that provides full 360-degree rotational capability that can interface with an external navigation system. This imaging system can be interfaced with the external navigation system. Automatic registration. This is workflow depending on the pathology, preoperative simulation, and intraoperative CT, and integration and fusion. I will show these clinical applications: minimally invasive surgical approach, fixation, multimodality, endoscope and exoscope, and augmented reality, and full endoscopic spine surgery. For cervical anterior approach, we can easily use intraoperative navigation like this. Surgical level and three-dimensional orientation in the vertebral body. This is a case of adjacent segment disease. So I performed anterior decompression without fusion, so-called George approach. To avoid vertebral artery injury, the hybrid operation room is useful. For this retrojugular approach, so-called George approach, hybrid operation room is very useful. We can confirm the entry point of the vertebrectomy and vertebral to avoid vertebral artery injury. Hybrid operation room is very useful. This is another anterior approach, pyogenic spondylitis. We performed emergent anterior decompression and removed abscess. In chronic stage, we performed vertebrectomy. Now, we check the entry point anterior pedicle screw. This is iliac bone. In this case, we don't need the posterior approach. In this type of surgery, hybrid OR is very useful to avoid VA injury. Intraoperative CT imaging. Intraoperative 3D image is actually useful for this technique. This is a case of extradural anterior lipoma. This patient came from China. This is the second surgery. Large skin incision and adhesion at the midline. So I chose the posterolateral approach. This is a preoperative image. I chose the posterolateral transpedicular approach. For this approach, I use the exoscope. This is a head-up video surgery, so we can easily use the navigation pointer This is the ergonomic benefit. Interfascial dissection to the pedicle. Tumor exposure and bleeding control with a microscope. This is the very vascular-rich tumor. This is pedicle removal. We have to expose the tumor surface and we are bleeding control. Coagulate the vessels and tumor removal, unblock removal. Postoperative image. Tumor was completely removed. In this case, hybrid operation room is useful for integration of multi-modality, exoscope use and microscope, exoscope, navigation, very useful for these integration. This is a case of thoracic tumor. I show the augmented reality use. Check the navigation accuracy from the skin. This patient is cancer patient, so we want to perform the very, very minimally invasive surgery with a small skin incision and a small dissection. So I use the AR and the posterolateral approach with the interfascial approach. No muscle dissection. We use the interfascial space and expose the lamina. So I check the tumor margin during incision and the tumor resection carefully. So this is small surgical corridor. So no CSF leakage. Lastly, I show the full endoscopic spine surgery. Full endoscopic spine surgery represents a tool for the surgeon to provide target access to spinal pathology. But There is a steep learning curve with these endoscopic spine surgery. For endoscopic spine surgery is a totally sealed tubular approach, and excellent image quality, optimal lighting. This camping triangle is a very important entry point. Three-dimensional depth perception, these anatomies, preoperative simulation, measurement, distance to pathology is important. So we use hybrid operation room and automatic registration system to this approach. We set the entry point and the important anatomy marking. We could confirm the entry point from the skin. This is transforaminal approach. And to the superior articular facet, drilling of vertebra, upper part. The entry to the disc. In this case, it is difficult to use the inside-out method. So we use the outside-in method with the navigation. So removal. For cervical lesion, we can use endoscopic surgery, posterior foraminotomy. Mark the targeted anatomy. Is of radiculopathy. The difference is fixed at the carbon May field. We can confirm the entry point from the skin. And then touch the bottom. Cannula placement. It is difficult to identify the level with the X-ray, but 3D image enable us to identify the level easily. Removal. We can confirm the neural membrane. Drilling and the Kelson longeol. confirmed the position. We think preoperative simulation and recognition of the target anatomy is important. So, automatic registration system in hybrid operation room is useful. We showed these techniques in this paper. Hybrid operation room is useful not only for fixation surgery, but also for various surgical strategy, for accuracy, safety, and pinpoint surgery. Minimal invasive concept and techniques for spine surgery has been established. Hybrid operation room enable us to integrate those concepts based on anatomy and physiology.
Hello, colleagues. My name is Vladimir Beneš. I will soon be 43 years old, and I did most of my career so far. I spent in Liberec, in a regional hospital, doing neurosurgery, and since October of last year, I moved to Prague to Motol University Hospital, and I am now the head of department of the neurosurgical department, which is the largest neurosurgery taking care for children in the Republic. My main interest was vascular neurosurgery in Liberec. Now in Prague, I do mainly neuro-oncology, pediatric tumors, and intramedullary tumors as well. My message to young colleagues is not to be afraid of treating children. They have beautiful anatomy, you get no atherosclerosis, and you get no degenerative spine there. And you can take advantage of CNS plasticity in children when you have there is a lot of potential for improvement that you do not see in adults. So we can say that some of your mistakes are sort of forgiven. Now let's turn to my talk, which will be about multidisciplinary approach to pediatric neuro-oncological patient, obviously from the neurosurgeon's point of view. Just to put things into context, this is the map of the Czech Republic, where we have a lot of neurosurgical departments for 10 million inhabitants. In Prague, there are 5 of them. And in the year 2019, we did more than 33,000 surgeries, combined adult and children. When we look at the same map again, and here we see departments that have some kind of non-acute elective pediatric program, and this department did about 2% of all neurosurgical procedures. So, as you see in my department, we do the most of it. We shall see soon. As we know, from childhood cancer, about 20% are CNS tumors, which is the second most common tumor after leukemia in our country as well. So that translates approximately into 75 new patients every year. Unfortunately, CNS tumors in children have the dubious distinction of being the most lethal, and the 5-year-old survival is not in the top numbers as well. But still, about 80% of children with pediatric CNS tumor survive into adulthood. This is the breakdown of pediatric neuro-oncological surgeries in the Czech Republic according to department. This is our department. We do most surgeries than other departments combined, and this has been going on for a long time. In order to do this, you need to have a great background of the pediatric hospital, with all the associated pediatric specialties like neurology, oncology, anesthesiology, and intensive care. But we should not forget these social departments as well that take care of health hospital, of schooling when the children are hospitalized, family support group, and others. And as I said already, 80% of children reach adulthood, so you have to take care of them as adults as well, so they move into the other part of the hospital. Now let's have a look at our multidisciplinary approach. After the tumor is imagined in the local hospital or in our hospital, we hold a multidisciplinary tumor meeting where there is always neurosurgeon, pediatric oncologist, neuroradiologist, neurologist, and other specialties according to the particular case. We can request additional diagnostic, and the purpose of the meeting is to make a detailed treatment plan where we look to minimize the risks and maximize the chance for cure. This treatment plan is discussed with the patient or with the family, and this plan usually can consist of three main lines: observation, surgery, oncological treatment. Obviously, these three main lines can move one to the other. The effect of the treatment is assessed regularly at follow-up imaging, and this imaging is discussed again at the multidisciplinary meeting. So this is how it works in theory. Let's have a look, or this is how it should work in theory. Let's have a look how it goes in practice. And we shall start with observation. So this is a case of a 13-year-old boy with a non-specific headache with normal neurological exam. We see a low-grade glioma of the mesencephalon with a cystic component, and this has been followed for more than 3 years. And so far, we proceed conservatively. The patient is very well informed about the disease and about the treatment options. The risk, obviously, at this moment outweighs the benefits, and one day we shall probably have to marsupialize the cyst and maybe take a bit of histology here, but I believe that the cyst evacuation should be more than enough. Let's move into into the other part of the treatment plan, surgery. I will not be talking about the oncological treatment much, but I shall concentrate on the surgical arm. It's still the best solution for tumors, and we should aim for a radical resection wherever possible. However, this should not be done at the cost of quality of life. So we call this maximal safe resection, which and you should take advantage of all your surgical adjuncts that you have. That is interoperative monitoring. That's something I believe is the most important one. Image guidance and the other things like TUSA, microscope, and its gliolan and other things. We do not have interoperative MR so far, but we are not afraid of second look surgery, because you can always come back and do more, but you can never come back and do less. So don't be ashamed of second look surgeries. Okay, let's have a look at some of the surgical procedures or some of the surgeries that we can do for our patients. This is a typical diffuse infiltrative pontine glioma. The surgical treatment here should consist of CSF diversion via ETV or shunting, and biopsy is done only for experimental purposes. Otherwise, the patient should be referred to oncological therapy. Another case, 2-year-old girl who presented with 7th nerve palsy, and radical surgery was proposed elsewhere. Obviously, surgery in this region is very, very risky with regard to cerebral mutism. We performed a stereotactic biopsy, which turned out to be a ganglioglioma with BRAF mutation, and BRAF treatment inhibitors treatment was initiated for 2 years, and hopefully this will be the end of the treatment plan. Otherwise, Obviously, radical surgery would have been very risky in this region. Another case, a large suprasellar mass, which was proposed. The patient was proposed radical resection in another department. The family sought our advice, and we performed endoscopic biopsy only, and this turned out to be optical pathway glioma. And after chemotherapy with vincristine and carboplatin, the patient is doing really well. There's no visual change, and the tumor shrinked very extensively. Okay, and I will talk about more extensive resections now. As I said already, the main motto of surgery should be do no harm. So all our efforts are aiming at this motto. So this is a 12-year-old girl with a posterior fossa palocytic astrocytoma, or I should say peduncular astrocytoma, who presented with gait disturbances. We aim for maximal safe resection as guided by the intraoperative monitoring. We did DTI tractography before, so we see that the tracts are pushed anteriorly, or here it's actually, the tumor is actually splitting the left-sided pyramidal tract. Short operative video, supracellular approach, the arachnoid bands around the vein of Callan are dissected away from the tumor. Then we proceeded above the tumor to identify the cerebral peduncle. The tumor is dissected away from the PCA. Then the tumor is shrinked and debulked. Dissection proceeds away from the arachnoid bands and additional vessels in the incisura. Small part of the tumor is removed from the lateral ventricle over here, and here we see the part extending from the cerebral peduncle. Let me stop it here for a moment. This here is a clear margin so far, which later turned out not to be so clear, and we were stopped by the electrophysiologist. So this is the final view, and here is the postoperative MR, where probably here is a very small residual. We call this near total resection. The girl is doing rather fine. Another case is forced ventricular low-grade glioma that progressed very fast in a very short period of time. Again, suboccipital craniotomy, teloviral approach. Tumor is identified in the fourth ventricle, and we were unable to identify clear tumor margins safely here. So we resected the tumor with a CUSA. We sought rather extensively. There we were stopped by the intraoperative monitoring. The patient did well with transient diplopia. The resection was rather reasonable, and she turned out to be doing actually very, very fine. In intramedullary tumors, we always aim for gross total resection as long as we have a clear margin, clear interface between the spinal cord and tumor. Once this margin cannot be safely identified, we let the intraoperative monitoring guide us. So the motor evoked potentials and the D-wave are what you are looking for in your neurophysiologist. This is the most important part of the surgery, where we identify the median raphe, the midline. So it is not necessary to perform a myelotomy. You split the posterior columns away from each other, and you do it. You start at the healthy tissue, and you proceed over the whole extent of the tumor. And this is great. This is where you find a nice clear margin between the tumor and the spinal cord, and then you have a nice radical resection, and the patient is doing actually rather well, as we can see here. When we have the multidisciplinary approach concerns, or again, one of the specialties that have their say in our multidisciplinary approach are the neurologists, particularly in the setting of epilepsy generating tumors, as we see here. This is a low-grade glioma or ganglioglioma of the left frontal lobe that presented with seizures. We shouldn't, if we treated this oncologically and resected only the tumor, as we see here, that would be a clear mistake because this would not address the seizures. And this is where I'm really glad we have a great neurological department that concerns this epilepsy, because these complex cases is something that I'd rather leave someone who is more intelligent than me. So this is clearly epileptogenic focus here as well, and we get a very nice plan from them what they want us all to resect over here, and this is obviously checked during surgery by electrocorticography. So don't be afraid to ask them what all you should resect. So here the resection is rather supramarginal, more extensive than the tumor. And the other specialty that really should have its say is the oncology department or the oncologist, as can be demonstrated on this case. 2-year-old boy with anaplastic ependymoma who underwent subtotal resection in another country and presented with progression while undergoing chemotherapy. An extensive tumor in the posterior fossa in front of the brainstem, encompassing all cranial nerves, most of the arteries in the posterior fossa, and the oncologist specified that we should aim for as radical resection as possible. Otherwise, progression, in other words, death is certain, and we should hope for the plasticity of children's nervous system to take care of the cranial nerve palsies. So when we open the dura, we see a tumor almost everywhere, and this really encompasses all the cranial nerves in the P fossa. This was the initial view. This is the view at the end of the surgery. In the meantime, we had to dissect the tumor away from the vertebral basilar arch complex, arteriospinal arteries, lower cranial nerves, seventh nerves, all the way up to the PCA that we see here. So after nearly 16 hours, we were able to achieve gross total resection. However, at the cost of worsened lower cranial nerve palsy, which later required tracheostomy and percutaneous gastrostomy. However, in other respects, the patient is doing actually rather well. Concerning spinal cases, Ewing-like sarcoma done on emergency basis because of quadriparesis, resection of most of the part of the tumor in the spinal canal. This was not safe to resect. Here the IO intraoperative monitoring warned us against about C7 progressive worsening. So we did not resect this small piece of tumor. However, it is controlled with chemotherapy nowadays. Another spinal case, chordoma residual after gross total resection in other country, which was resected rather safely and nicely. So the last part of this multidisciplinary approach concerns regular and long-term follow-up imaging. Because of most of the patients reaching adulthood, we look for tumor progression, therapy side effects, and the outpatient clinic is concerned with residual deficit and cognition. What we are concerned about most are the secondary tumors the patients can present with, such as this foramen jugulare meningioma after radiotherapy for ependymoma in childhood, or this huge anterior-crinal process meningioma in a patient blind on the right eye who underwent Simpson grade 4 resection with residual in the cavernous sinus with transient hemiparesis. Or the last case that I will show, this atypical clivus meningioma that was resected with Simpson grade 2 resection. She had stable paresis of the lower cranial nerves, however developed new 6th nerve palsy. Otherwise, she's doing well, and I can look forward to resecting this small one over here. So hopefully our multidisciplinary approach has convinced you about the necessity of centralized care for childhood patients with intracranial or CNS tumors. You obviously need experienced physicians across multiple specialties, modern diagnostic background and equipment, and you need close cooperation within specialties. For me, the best is that the patients are sort of served on a silver platter, that the respective specialties do what they do their best, and I do not have to concern myself with some diagnostic or post-operative difficulties. This is obviously impossible to do without international cooperation, and it should all translate into high patient volume, higher experience, lower complication rates, and better outcomes. Thank you for your attention.
Hello everyone, my name is Yusuke Nishimura and I'm a staff physician and the chief of neurosurgical spine team in Nagoya University Hospital, Japan. I'm very honored to give a lecture at this great meeting. The topic of my talk is minimally invasive neurosurgical and microscopic spine surgery, focusing on anterior approach to the degenerative cervical spine. First, please let me introduce myself to everyone. I graduated from Nagoya University in 2001 and have been working in Nagoya University Hospital since 2006. After finishing neurosurgical residency in outside hospitals, along the way I worked in Toronto as a clinical fellow in University of Toronto from 2011 to 2013. I spent an excellent and wonderful time there with my family, and I had a great experience of spinal surgery under my great mentor, Dr. Howard Ginsberg. I also joined a basic research project on neurodegeneration under Dr. Michael Fehlings. I operated on more than 500 cases. I published 7 papers of clinical and basic research associated with my clinical fellowship in Toronto. This was a great experience for me. I'm keeping in touch with my mentor, Dr. Ginsberg, and I continuously send my juniors to Toronto. I would like young neurosurgeons to broaden your horizons and go into the new world beyond the border of your country. That would be a great experience like me, and it would change your life for the much better. Okay, I will go back to today's topic and start my talk. Spinal degeneration usually progresses from disc degeneration to facet osteoarthritis. Therefore, primary pathology exists in anterior element of the spine as shown in MRI. So adapting the anterior approach for the cervical spine is rational selection. What is minimally invasive anterior approach for cervical spine? We believe anterior transvertebral fibrotomy, abbreviated as ATVF, and standalone anterior cervical discectomy and fusion, abbreviated as ACDF, play significant roles in this field. If patients have cervical radiculopathy, we use ATVF or ACDF. If only the foraminal stenosis exists with a spinal cord compression, ATV is selected. But if there exists concurrent spinal cord compression on top of the foraminal stenosis, we select SDR. If patients have multiple canal stenosis on more than 3 levels, we select posterior laminoplasty. But in most of cases, we can localize 1 or 2 level pathology as responsible regions. So approximately more than 90% of cases operated via anterior approach in my clinical practice. First, we need to know the exact anatomy for anterior cervical approach. If we go to C3-4 level, we need to pay attention to the superior thyroid artery, because the superior laryngeal nerve is existing behind the artery. So we should retract the artery rostrally without doing surrounding dissection to preserve superior laryngeal nerve. If we approach C6-7 or C7-T1 level, we have to take care of recurrent nerves. Omohyoid muscle should be retracted caudally to avoid injury of the recurrent nerves. Sympathetic nerves are sitting on the surface of long scrotal muscle, and we should not dissect the ventral aspect of the muscle too far lateral. We also have to make sure of the location of vertebral artery before surgery, because the artery rarely takes tortuous course eroding the vertebral body. The epidural venous plexus is abundantly present at the lateral aspect of dura mater within spinal canal. We also should take notice of the superficial layer of posterior longitudinal ligament, abbreviated as PLL, fusing with the dura mater at the exit of nerve root within spinal canal. So we have to leave the PLL superficial layer intact in this area intraoperatively. So this is a surgical video for the anterior approach to the cervical spine. So this the surgeon is standing on the right side of the patient, and the skin is usually placed transversely, and the subcutaneous tissue is carefully dissected, and now we are cutting the platysmal muscle transversely. And now the superficial cervical fascia is dissected. Now we are getting into the medial aspect, along the medial aspect of sternocleidomastoidal muscle. Then along the way, we usually encounter the omohyoid muscle like this, and the omohyoid muscle should be retracted caudally to avoid injury of recurrent nerves. Now finger navigation is very useful, and now we are dissecting the prevertebral cervical fascia. And this is disc space. Disc space is exposed. The index level is confirmed with fluoroscopy, and the long screen muscle is dissected from the surface of vertebral body to the retractor. Okay, let's proceed to anterior transvertebral framiotomy, ATVF. ATVF is a surgical method intended to preserve the segmental motion of the C-spine without spinal fusion. We create a small hole 6 mm in the diameter, which is called keyhole, on the lateral surface of the vertebral body and drill all the way down to the neuroforamen. Drill trajectory is aimed caudally inside the vertebral body with intraoperative fluoroscopic guidance. The disc space is preserved all the way and herniated disc or osteophyte projected to the back of vertebral body is removed. We can leave the keyhole alone after decompression of the nerve root. We don't use spinal instrumentation. This technique is exclusively used for cervical radiculopathy without spinal cord compression as described earlier. Therefore, fusion-related problems are supposedly avoided. Load on adjacent segment is minimized compared to ACDF exposure, and the soft tissue damage are limited. This is a representative case 1. The herniated disc is seen as the foramen on the left at C6-7 level. We successfully operated on this patient with ATVF. Herniated disc was nicely removed through the keyhole. This is a surgical video of the case. So the surgeon is standing on the left side, and now we are creating a small hole called keyhole, 6 mm in diameter, and the hole gets bigger as we get deeper. Now we are taking out the herniated disc, migrated onto the PAL. Now we are taking out the herniated disc, and then we are opening the neuroforamen along the course of nerve root. So the nerve root is nicely visualized and decompressed. We analyzed surgical results of our own ATVF cases. We retrospectively investigated 50 cases of ATVF in Nagano University Hospital. 40 cases were operated on one level, 10 cases were operated on 2 levels. The average follow-up duration was 45 months. Clinical outcomes were evaluated with Adams criteria. 88% of cases were scored as successful outcomes. However, 2 cases received reduced surgery because one case had a deterioration of segmental cervical kyphosis at the operated segment, and another case had radiculopathy at a rostral adjacent level. Both cases were managed via stand-alone ACDF. We analyzed postoperative cervical spine alignment following the ATVF. C2-7 cover angle was unchanged postoperatively, but range of motion of C2-7 angle improved significantly. This improvement is considered functional recovery caused by pain relief. Segmental angle and range of motion of operated levels are maintained, indicating good neurological recovery with the spine fused. My colleague Dr. Takeuchi reported the successful application of ATVF to cervical thoracic junction C7T1 level The approach of ACTF to C71 level is usually deep and the trajectory is blocked by the sternum. However, ADVS trajectory to C71 is completely spared from the blocking by sternum, and a skin incision can be placed on the C67 level. Therefore, C8 radiculopathy is a good surgical indication for ADVF. Furthermore, we have proved the mechanical stability of the affected vertebral body, even with keyhole created using the finite element method. We have never seen vertebral body collapse following the ADVF. Next, I talk about standalone ACDF. So what is standalone ACDF? Many surgeons prefer to do ACDF supplemented with cervical plate. However, ACDF up to 2 levels are not necessary to go with cervical plate. Placement of anterior cervical plate requires wide soft tissue dissection and longer surgical time. Projection of plate may cause problems of esophagus. If we use the conventional ACDF technique, consisted of drilling of endoplate to make the trajectory wide and bigger for good visualization and easy manipulation, we have to place the plate to prevent sinking of the interbody fusion cage and shoulder arthrosis. We completely preserve the osseous endoplate using the bone longitudinal rotation technique to widen the narrow disc space, just like the technique of lumbar interbody fusion. The bone longitudinal is rotated with applying destruction force on destruction pin. We can place interbody fusion cage nicely with osseous endoplate completely maintained, so we don't need cervical plating with this technique. This is a representative case 2 high disc at C56 was nice treated with standalone ACTF. This is a surgical video of the case. So, as described earlier, we placed the transverse skin incision and we cut platysmal muscle and cervical fascia is dissected, and we get into the deep cervical fascia along the medial aspect of sternocleidomastoid mastoid muscle. Finger navigation is used to feel the pulsation of carotid artery, and now we getting into the deep cervical fascia, the prevertebral cervical fascia. So we are identifying the index level with fluoroscopy and cut the disc space with monopolar, and longoscopic muscle is dissected from the surface of vertebral body, and now we are applying the retractor. We are putting the destruction pin into the vertebral body. So we frequently use caisson punch to remove the osteophyte. Now we are using curette to remove the cartilages and the plate but we need to preserve the bony osteophyte, osseous and the plate. Now we are taking out the honey disc, which was migrated into the behind of POL. So this is honey disc, and disc was nicely removed, and dura is visualized. So we achieved hemostasis, and we are putting the interbody fusion cage, stand-alone interbody fusion cage, into the disc space. This is post-operative imaging. Discs. The patient made a good recovery following the surgery. This is a representative history with cervical myelopathy. C3, 4, and 4-5 spondylolisthesis and instability were the responsible pathology for this case. We operated on the patient with stand-alone ACDF. This is a surgical video after after finishing the approach. Now we are expanding the narrow disc space little by little, and this is a bone longeal rotation technique. So we are rotating. Now we are rotating the bone longeal with destruction, with applying destruction force under the destructor pin. And after enough removal of osteophyte, we put additional force to expand that narrow disc space. Now we are drilling the osteophyte, projecting into the spinal canal. So now taking out the protruded disc, cervical disc, and projected osteophytes at the back of vertebral body. So we got a nice decompression of spinal cord. This is post-operative imaging. Disc space at C3, 4, and 4-5 was opened up with interbody fusion cages inserted. Spinal cord was nicely decompressed. We retrospectively analyzed 112 cases with cervical degenerative disease in Nagoya University Hospital who were operated on with 1 or 2 level stand-alone ACDF. The mean follow-up duration was 24 months plus minus 9.5 now. 9.1 months. In terms of postoperative complications, there was one case of transient hoarseness, which was spontaneously resolved within a couple of weeks. 2 cases of adjacent segment disease needed additional surgery, such as ACDF or laminoplasty. 1 case of symptomatic arthrosis showed deterioration of cervical myelopathy and required posterior instrumental fusion. All cases made a significant improvement after reduced surgery. Postoperative cervical spine alignment is shown in the table. C27 core angle, segmental height and segmental angle on operated level significantly improved. C27 range of motion was reduced because of spinal segment fusion. Segmental height and angle of cranial adjacent level reduced significantly, suggesting progression of adjacent segment degeneration. We needed to investigate the long-term effect of increased load on adjacent segment. However, at least 2-year duration in this study. The implication was minimum. Clinical outcomes were excellent. The patient's satisfaction for standalone ACDF was very high. We also combined ADVF and standalone ACDF as hybrid surgery. We have reported this hybrid surgery to reduce the number of fuse levels. We usually do standalone ACDF at upper level and ATVF at lower level. We can apply this hybrid surgery to two continuous levels or separated levels. Our analysis revealed that degeneration of the level of ATVF was not accelerated even if ATVF is done next to the level of ACDF. So the degeneration of the level of ATVF was not accelerated even if the ATVF was performed caudal adjacent level of ACDF. So this is the last slide, and this is a conclusion. Anterior transvertebral foraminotomy, ATVF, and stand-alone anterior cervical decompression and fusion, standalone ACDF, are both minimally invasive surgical techniques. Anterior approach to the cervical spine should be placed at the center of the treatment of degenerative cervical spine. Thank you very much for your listening. Thank you.
Hi, I am very honored to be invited to give this lecture today. I am Masaki Iwasaki from Tokyo. I am graduated from Tohoku University School of Medicine and once studied on epilepsy and clinical neurophysiology at the Cleveland Clinic Foundation. And I am in the current position since 2016. I am specialized in functional neurosurgeries, shown here. The National Center of Neurology and Psychiatry is located in the suburban area of Tokyo. It consists of one hospital and two research institutes, one for neuroscience and another for mental health. This is my very first patient for hemispherotomy. He was 6 months old at the time and had very frequent seizures caused by hemimegalencephaly, which was not controlled even by continuous infusion of anti-epileptic drugs. He was operated and became seizure-free since then. He now goes to the middle school. If he didn't
receive surgery. He should not be like this. Surgery was the only one procedure to stop his seizures then. So I think the field of pediatric epilepsy surgery is very rewarding to us because the surgery is often life-changing for patients. So today I'm going to talk about our experience on pediatric, especially the infantile epilepsy surgery. The etiology of epilepsy in the children indicated for surgical treatment is quite different from the adult populations. So the malformation of cortical development is most frequent etiology, which occupy the 42% of all surgical cases. So MCD includes focal cortical dysplasia, hemimegalencephaly, and polymicrogyria. And the second frequent etiology is probably the low-grade epilepsy-associated tumors and hippocampal sclerosis and neurocutaneous syndromes, such as the tuberous sclerosis complex and Sturge-Weber syndrome, and urticaria and Rasmussen encephalitis and hypothalamic hamartoma. So this shows the age of epilepsy onset in relation to the etiology. So especially the hemispheric and diffuse malformation of cortical development cause very early onset severe epilepsy in patients. So this etiology occasionally causes a generalized epilepsy syndrome, such as Ohtahara syndrome or West syndrome, and also the patient experience a developmental and epileptic encephalopathy, which means the patient development is impaired by the presence of frequent seizures and electroencephalographic abnormalities. So in those patients, the early surgery is very important. So the chance of seizure freedom after epilepsy surgery is higher in children than in adults. So the many retrospective studies shows that results. Then early seizure control is believed to be important for the development and cognitive function in children with epilepsy. However, the multilobar surgeries, including hemispherotomy, accounts for 40 to 50% of infantile epilepsy surgeries. In those surgeries, the risk of hydrocephalus requiring shunting surgery is very high as 20%. So there are lots of big surgeries for small children. So the following talk is most of the results are based on our recent articles published in Journal of Neurosurgery Pediatrics. So this study included 75 cases of pediatric epilepsy surgery performed under 3 years of age in our institution. So this is a distribution of etiology of epilepsy. So the majority had a malformation of cortical development or hemimegalencephaly. And type of surgery included hemispherotomy and multilobar surgeries. These two procedures accounted for nearly 60% of all surgeries. So this is our surgical indication policy and patient background. So we usually offer early surgery when the patient body weight was larger than 5 kilograms or patient is older than 3 months of age and the patient have drug-resistant seizures. Median age of epilepsy onset was 30 days and median age at surgery is 6 months. and median body weight at surgery was 8.5 kilogram. So this shows the age distribution of our surgical cases. So most frequent age at surgery was between 3 and 4 months. So this shows we offer epilepsy surgery at quite early stage of disease. So in those patients, these two procedures are very important, the hemispherotomy and the posterior quadratic disconnection. These are the very important procedures in this age group. So I'm going to talk a little bit about hemispherotomy techniques. So hemispherotomy consists of the corpus callosotomy and disconnection of projection fibers. So this part. So then achieve hemispherotomy, there are two approaches. The horizontal approach, which approaches around the perisylvian area to cut the projection fibers here, and then cut the corpus callosum. Also, there are vertical approach was proposed by the Delandes. This comes from the near interhemispheric or paramedian area to enter the lateral ventricle, then cut the projection fiber just lateral to the thalamus, and also accomplish the corpus callosotomy here. Actually, we prefer the vertical approach, especially in children, because this procedure requires a smaller craniotomy and also the smaller length, shorter length of dissection compared with horizontal approach. A recent article just published in this year also showed that vertical hemispherotomy was more effective than lateral hemispherotomy in terms of the seizure rate of the seizure freedom. So in long-term follow-up, the chance of seizure freedom was statistically higher in the group of patients who received vertical hemispherotomy than those who received a lateral approach. So this is the procedure usually we perform in our institution, which is the interhemispheric vertical hemispherotomy. First, corpus callosotomy is performed via the interhemispheric space. Then remove small amount of medial frontal cortex. Then open the lateral ventricle. Then disconnect the projection fiber, I mean the internal capsule, just lateral to the thalamus, here, like this. And when you perform the craniotomy in infants, so you need a very, you need to be very careful. Usually we prepare the blood transfusion. Also, we keep central venous catheter, which is considered for securing a route for blood and or fluid transfusion. We usually use a horseshoe headrest with additional soft pad like this to prevent to develop a pressure ulcer. And we make a craniotomy on the anterior fontanelle, and we perform skin incision with monopolar cautery, and carefully check the bleeding for bloodless surgery. So this is an image of paramedian frontal craniotomy for hemispherotomy. This is a fontanelle, and we usually cut a bone like skull like this. then make a surgical field like this. So when you perform the hemispherotomy, vertical hemispherotomy, in the lateral ventricles, it is important to identify the thalamus and caudate. Usually, you have you can identify a small cleft between these two structures. This is a point where you can dissect the projection fibers. This is a location here, the caudate and thalamus, and you cut the white matter to this way. Actually, in the posterior view, you will see the inferior horn here. Then you cut the white matter from here by following the inferior horn at the bottom. So this incision makes white matter dissection just lateral to the thalamus. So this is an imaginary line of the dissection. I'm going to show with a video. This is a right interhemispheric vertical hemispherotomy. I'm now first perform the corpus callosotomy. I'm dissecting interhemispheric fissure, and I'm now aspirating the corpus callosum. So this is a cavity between the both septum pellucidum. Then I'm now cutting the genu of corpus callosum. This is, you see the anterocerebral arteries. Then this is the part of the splenium. So you perform the corpus callosotomy at the midline. Then anatomically, I achieved the complete corpus callosotomy. Then I'm now securing the anterocerebral artery like this. Then here, then I cut the small amount of medial frontal gyrus. Then I'm now opening the septum pellucidum on the right side to enter the lateral ventricle here. So you see the foramen of Monroe here. Then further, I remove the medial front parietal cortex here to extend the surgical field. Now you see the caudate and thalamus, and here I put the cottonoid is the space of the inferior horn. So this is lateral ventricle, and it continues to the temporal region anteriorly. Then again, this is a caudate and thalamus. Then I start to dissect from the posterior end of the thalamus and the caudate and the border. Yeah, I start to cut, then slowly aspirate the white matter with Kuzar. Yes. So this is, I'm making the dissection between thalamus and caudate. Then I'm aspirating the white matter. And also it's important to follow the inferior horn at the bottom of this dissection. Now you see the inferior horn, and also probably this is a hippocampus. So then now I move to the anterior part. This is a space after I removed the granule of corpus callosum, and I'm following now the anterior cerebral artery by dissecting the white matter from the frontal lobe. I'm following the ACA here proximally to find the this is a bifurcation point of internal cerebral artery. Here ICA and ACA and MCA laterally. Then finally I connect the dissection from the posterior part to the anterior part. Here so you see the ICE bifurcation here. Then from this point, the dissection I'm connecting the dissection to the posterior part. Then now this is a completely the thalamus is separated from the neocortex. But finally, I'm cutting the fingula here. This is a small procedure, but it's important to prevent the spread of seizure activity from the hippocampus. So this is the final view. This is here the thalamus and the cerebrum is was separated here. So this is the post-operative images of this procedure. The dissection was made at here and here and here, and small amount of the medial frontal cortex was removed here. This is a video of a patient who underwent hemispherotomy at her age of 4 years. When a patient is young enough and there is no major problems in the growth development, the patient is usually able to walk with an ankle-foot orthosis in spite of hemiparesis, as shown below. This is a post-operative video. The next, the important procedure is posterior quadratic disconnection, but for I do not have enough time to explain the procedure. If you are interested in this procedure, please look at this website, the OPEPARC. I uploaded the entire part of the video on this procedure. It's the free service, so if you are interested, please see this site. And the post-operative course, in our experience, so the rate of post-operative complication is not the minimum. So any sort of complication occurred in nearly 30% of patients, including DI and CSWS and sinus thrombosis. But there is no permanent deficit after the surgery, and there was no mortality. But the most frequent one was hydrocephalus, which occurred in 70% of the patient. But seizure outcome is very excellent. 80% of the patient became totally seizure-free 1 year after surgery, and 70% of the patient is still seizure-free at the last follow-up. And also the merit of surgical treatment is the patient can decrease the anti-seizure medications. The number of anti-seizure medication was significantly decreased after surgery. And also the 25% of the patients stopped taking any anti-seizure medication at the last follow-up. This shows the developmental outcome after surgery. The Postoperative development was highly dependent on the preoperative development and also on the seizure freedom. The patient with seizure freedom was better in terms of the development compared with the patient with residual seizures. And we performed multiple regression analysis for DQ 1 year after surgery. There are two factors for better DQ. The most important factor is preoperative DQ, and another one is the seizure freedom. But hydrocephalus have no influence on the post-operative development. And compared with previous studies on epilepsy surgery under 3 years of age, our result was better in terms of seizure-free rate, but complication rate, especially for shunting, was probably the risk was higher, relatively higher. That is probably because we offered epilepsy surgery at quite early age in those patients. So epilepsy surgery in infants, even before 3 months of age, was recently reported. This is called ultra early surgery. It's very rare, but known to be feasible. There was no mortality, and still the hemispheric surgeries were most common. And also they experienced the hydrocephalus, post-operative hydrocephalus in 25% of patients. But the chance of seizure freedom was very high in 66%. So in conclusion, the epilepsy surgery in the early pediatric stage is effective for controlling epileptic seizures and reducing the requirement of anti-seizure medications. And post-operative development is highly dependent on preoperative development. And seizure control also contributes to development 1 year after surgery. And the risk of postoperative hydrocephalus requiring CSF diversion surgery is greater than 10% in infantile epilepsy surgery. However, this has little impact on the patient's developmental outcome. So currently, we recommend epilepsy surgery as early as 3 months of age when the patient has drug-resistant seizures. Thank you.
Hello, everybody. My name is Rachel Grossman. I'm a neurosurgeon from Tel Aviv Medical Center. And I would like to thank you for the opportunity to be part of the ACNS Autumn Web Seminar. Just a few words about myself. I'm working as a vice chairman in the neurosurgery department in Tel Aviv Medical Center. And my main clinical interest is doing brain tumor surgeries. I use, in most cases, awake craniotomy with intraoperative mapping and monitoring of white matter tracts for high cognitive preservation, doing extended endonasal approach for treating pathologies such as craniopharyngioma and meningioma, and running multi-center clinical trials in this field. So if I have to choose a short message to the young neurosurgeon, I choose to quote Charlie Wilson from UCSF. He was a master in pituitary surgeries. And he said that the precondition is often forgotten in the excitement that comes with change is certainty that the new technology will improve the quality of clinical care for patients. If this precondition is not satisfied, the technology should be abandoned. And I think this is very true for the very exciting endoscopy approach that from one side give us a lot of opportunities, but probably we need to choose the right cases in order to succeed. So the principle of endoscopic approach is the idea that we actually bring the source of light into the surgical field. So we get a very wide exposure of the surgical field as opposed to very limited field of view when we deal with a microscopic approach. Also, we need to get used to a new perspective of the same anatomy when coming from below, from the nose. So this is the view that we get through the speculum in a microscopic approach. We can nicely see the sella turcica, and this is the view that we get when we use the endoscopic approach. We can see that we can get a much wider exposure, not just the area of the sella, but actually we can get the whole anterior skull base view. And this, of course, gives us much more opportunities to treat many pathologies. We use two different surgeons, two different disciplines, ENT surgeon and a neurosurgeon working side by side, four hands. Each one has its own focus. The ENT surgeon will take care of the paving the way through the nasal cavity to the area of the pathology. And in the end of the surgery, he will take care to close the skull defect, and the neurosurgery will take care of the intracranial pathology. Although this is a very exciting approach, we need to choose the right cases to use this approach, and it depends the tumor location, the corridor that we can have, and the extent of the pathology and the relation of the tumor to a very important structure that surrounds the pathology, such as the optic chiasm, the infundibulum, the third nerve, the third ventricle, and of course, the learning curve and the experience of the surgeon. So we're all familiar with the steep learning curve of this technology. And this is the endoscopy learning curve published by the Pittsburgh group. They divide it to 5 levels. Level 1 is the sinus surgeries. Level 2 is the intracellular pituitary cases. And level 3, more extended pituitary cases, and also extradural skull-base surgery. Level 4, we are talking about intradural skull-base pathologies such as craniopharyngioma and supracellular meningiomas. And level 5, very challenging, vascular surgeries. In case of tumors, we always aiming for gross total resection, but it's not always possible. So we need to balance between aiming for extent of resection, maximizing extent of resection, and preserving the quality of life. So we can see here that we need to get used to the new perspective when coming from below. So on the left side, you can see the very well-known anatomy of the anterior skull base. We're all familiar with when we operating through the transcranial approach. However, on the right side, we have the same region of the skull, but when coming from below. We also need to be aware to define the borders of this approach. It's a midline approach, very good for midline pathologies, but we need to be aware to the fact that we cannot probably go laterally to the clinoid or to the optic canal. So it's important to know the limitation of this approach. This is the view that we can get through pneumatized sphenoid sinus to the sella turcica, to the clivus. You can see the optico-carotid recess, and there is a bony line between the optic canal called the limbus of the sphenoid. Above this line, there is the planum sphenoidale, and below this line is the prechiasmatic sulcus. After bony removal, we can see this dural fold between the optic canals. Above this line will be the planum sphenoidale, and below this prechiasmatic sulcus, you can see the intercavernous sinus and the carotid running on the lateral side from the clivus through the cavernous sinus and the supraclinoid carotid. We need to know that if we open the dura of the planum, we will expose the area of the basal frontal lobe, the gyrus rectus. However, if we open the dura below this line, we will expose the infrachiasmatic space, where the area of pathologies such as the craniopharyngiomas or tuberculum cellar meningiomas. So it's different, completely different anatomical area. Most of the experience gaining with the endoscopic approach were based on the cases of pituitary adenomas. I will talk briefly about non-functioning pituitary adenoma. The goal is to perform maximal reduction of the tumor and, of course, to preserve the pituitary function. We usually start with the identify the pseudocapsule and try to dissect it, and then perform the tumor decompression. And in case the tumor is very soft, we sometimes can take out all the tumor. But in case the consistency of the tumor is very firm, or it's go laterally to the cavernous sinus, it's okay to leave tumor behind and to use postoperatively postoperative treatment such as dopamine agonist or stereotactic radiosurgery. So this is the case of a 30-year-old male who presented with a hypopituitarism and a headache, and he had also bitemporal hemianopsia and this huge pituitary adenoma. You can see that there is a very wide sella turcica. We expose the sella and we open here the dura. And you can see the tumor. We try to identify the dissected pseudocapsule of the tumor. Tumor decompression. Using the curettes. Now we dissect the tumor from the diaphragma sella. And here you can see the last piece of the tumor, and the diaphragma is freely. We usually do inspection in 30-degree endoscope to see that there is no tumor remnant, and this is the postoperative MRI. So when we look at the literature of the past decades, many clinical series compare the endoscopic versus the microsurgical transsphenoidal surgery in case of looking for superiority of the techniques, but there was no superiority to any one of these technique. But despite the lack of any evidence for superiority, endoscopic surgery became the standard of care in most pituitary centers to treat pituitary adenoma. And I think the reason is that it gives us a lot of options and opportunities in terms of surgical approach, even to other pathology, except from pituitary surgeries. So craniopharyngioma is another pathology, originated usually from the infundibular hypothalamic axis, located in many cases in the retrochiasmatic area. It's a very challenging area, also for open approach, but also for endoscopic and the nasal approach. The most important goal when we treat this pathology that we need to remember is to preserve the quality of life of the patient. We need to remember that postoperative panhypopituitarism can be managed very good with medication. However, hypothalamic injury is devastating and in most cases irreversible. So there are many classifications for chronic pharyngiomas. Most of them relate to the infundibulum or to the floor of the third ventricle. Here you can see two cases of craniopharyngioma. They are similar in size. However, on the left side, you can see craniopharyngioma, which probably the preferable approach will be through endoscopic endonasal approach. And on the right side, the craniopharyngioma is located within the third ventricle, which means that if we choose the endoscopic approach, we need to invade the floor of the third ventricle, and this is something that we don't want to do. So on the right side, probably we want to approach the tumor via the translamina or a transcallosal approach. So this is a case of a 65 years old female with a craniopharyngioma involved the floor of the third ventricle. Actually, it was located behind the chiasma, retrochiasmatic. It was a very challenging case. You can definitely see the optic chiasm. And after we gently dissected the tumor, take it out. And you can get a very nice view of the third ventricle. You can see the foramen of Monroe. You can see the hypothalamus and even the third nerve on the side. So when comparing the endoscopic and the nasal approach versus the open transcranial approach for treating craniopharyngioma, we can see a better visual preservation for the endoscopic and the nasal approach and higher rate of gross total resection. A more debatable and controversial pathology is our meningiomas. Probably the key to success when treating meningiomas is a very good and wise patient selection. And the concept of treating meningioma with an endoscopic and the nasal approach is to convert very complicated skull-based meningiomas into convexity meningioma by early approaching the insertion of the meningioma by doing early devascularization. And this is a case of tuberculum sella meningioma. In the nasal approach, but still in this selected group of patients had a very good visual preservation compared to the open approach. And another thing is that they had less flare changes in the brain parenchyma, probably because of less brain manipulation. Chordoma is another midline pathology, can be located extradurally or intradurally. In this case, we choose to use the endoscopic and the nasal approach, transclival. And after dura opening, we can definitely see the tumor, and we have a very nice view of the brainstem and the basilar artery with the perforators. The last case is a case of a 28 years old female who presented with heavy paralysis and cranial nerve deficit. She has pontine bleeding from a cavernoma, and we figure out that we can approach this cavernoma when coming from below. And we use the transclival approach. You can see here the pneumatized, the exposure of the clivus, treating the clivus. This is the sella. Exposing the dura. We use the ultrasound Doppler in this case to identify the basilar artery. We open the dura carefully, and the basilar artery just in the middle. And you can see very nicely the pons. We monitor the surface, and then we get through and identify the hematoma and the cavernoma itself, and we take it out. And this is the postoperative MRI of this woman. You can see the postoperative pyramidal tract, the corticospinal tract, and the bones after the cavernoma resection. Just a few words about the closure technique. We use in the last decade the nasoseptal flap, which decreased dramatically the rate of CSF leak in extended cases, not in every pituitary cases. We usually use the multi-layer closure technique. We don't use the lumbar drain in every case, just in the cases of a very high chance for a CSF leak. I will stop here. Thank you very much for your attention, and see you in Israel.
Okay, so I think we should start our discussion for this session. Hello, everybody. I think we listened to very interesting talks in this session, very challenging cases. Is there any question from the audience? You have a question for Professor Iwasaki. Is Professor Iwasaki connected? Professor Iwasaki? Maybe he's not connected. Okay, so a question from for Professor Grossman. Is Professor Grossman here?
Hello.
Yes. Hello. Thank you for your very nice presentation. I think you showed challenging cases, and I appreciated the review of the different stages for the learning curve. I think this is very important to know for young neurosurgeons. So I would like to ask you about the importance of a cadaver lab for this kind of surgery, and the importance of working with ENT colleagues. What do you think about collaboration with ENT colleagues? I don't know if you usually operate with them or if you are completely independent in the approach, but I know in some institutions, there is this collaboration between different colleagues. So what's your opinion about this?
So first of all, hello everybody, and thank you for the opportunity to be here. I'm right now in Boston, so it's 3 a.m. in the morning.
Very early.
Regarding, yes, regarding your question, so it is probably very important to do the cadaver lab work, although it was not my route. I did not have much experience in cadavers. I just learned more and more how to operate and to use the endoscopy tool in pituitary cases. Just after a large amount of cases, we felt confident to go to the next level, to the next step. We are working with the ENT surgeon. We have actually in our center 2 ENT surgeons that we're working on a daily basis. And it's it's really important to feel confident and to work in harmony and to get used to work together. It's not a simple issue. Although it may sound like, but it's really important to get used to work in a team together, and it takes a while.
Thank you very much. I see Professor Yasushi Shin.
Yes.
Hello, how are you doing?
Hi.
Long
I'm glad
time
to
no
see you again.
It's nice to see you.
Yes.
Thank you for your talk.
Thank you.
I was wondering, I was talking in the last months with some young neurosurgeons here in Italy, and we were talking about minimally invasive spinal surgery.
Yes.
So they were telling me we feel like happy from one side because we have the opportunity to perform this minimally invasive spinal surgery, which is good because you have anatomical control by X-rays intraoperatively, but they feel uncomfortable to the other side because they think they kind of missed the experience of open spinal surgery. So they feel like it's easier to shift from open spinal surgery to minimally invasive spinal surgery, but it's not so easy to do the opposite. To learn open surgery if you start with minimally invasive surgery. What's your opinion about this?
Yes. I think open surgery technique and mini open surgery technique is a microscopic technique is very important. So my opinion, I think spine surgeon needs a variety of techniques. So we have to choose some procedure depending on the pathology, I think.
Yes, thank you. Is there any other question? I see Adi, Liu are connected. Do you want to add some comments?
Actually, thank you, Dr. Alberto. I had a question for Professor Benesch, but he's not here. But maybe Professor Benesch Jr. can discuss a little bit about the approach for the spinal cord tumors. Since we have seen that Professor Benesch does unilateral laminotomy on the level up and level below, my question is also for the audience: have you found any limitation of unilateral approach, and when do you consider laminectomy, or in all cases you are using unilateral approach? And the second question is also for the audience: if you have, for example, lateral cavernoma, lateral spinal cord cavernoma, do you also go through the midline myelotomy, or you would consider a lateral opening if you have the cavernoma which is almost on the surface? Thank you for your answers.
Okay, well, we prefer laminotomy, bilateral laminotomy, one level below, one level above, and I have not found any limitations of this approach, and I believe that more of an approach is better than if you run into any problems, then it's better to have a bigger approach. And concerning laminectomy, we do laminectomy in cases when we encounter a tumor that is not resectable, and we perform duroplasty and laminectomy as well, and refer the patient to the oncological department, obviously, depending on histology. So peroperative biopsy is mandatory in these cases, and we amend our approach according to this. Regarding the second question of cavernoma, we approach these when they are almost at the surface directly. If the best is when they are protruding on the surface or are just directly beneath that. That's when we attack them directly.
Thank you. Thank you for your answers.
So, hi, Ari. Maybe I think if there is a Nishimura, he's a spinal neurosurgeon from Nagoya University. If he is, Nishimura Sensei,
yes,
can you answer his question?
Yeah. What?
Dr. Ari, please repeat.
I'm asking the same question, like as Dr. Benesh has already answered. When do you consider lateral approach? As also, I agree that all the subsurface lesions like cavernomas can be resected through the lateral approach. We shouldn't go for midline myelotomy. And I have the third question for you, please. If you find during the surgery that you have high-grade astrocytoma, large high-grade astrocytoma of the spinal cord, do you consider to, I can say, quit surgery on the base of the near total resection, or you still are trying to achieve complete resection? If it's a high-grade glioma, do you consider to just stop with the surgery and send the patient to the oncology?
No, I usually try to remove all of spinal cord tumor, all component of the spinal tumor, even in the even if the tumor is a high-grade glioma, and because the surgical outcome of spinal high-grade glioma is much better when we remove almost all of the tumor. So I always try to take out the tumor as much as possible. And if the cavernoma is located on the surface, lateral surface of a spinal cord, we usually use the direct approach to take out the cavernoma, dorsal root entry zone approach. So that it's not difficult approach, and you can find the exit of the dorsal nerve root and cut the surface. And usually the cavernoma is very close to the surface of the spinal cord, so we can take out the tumor without damaging the spinal cord if you take that approach.
Okay, thank you. Thank you so much. I'm not going to take more of time. Maybe some other colleagues have a question.
Good morning to all participants in the autumn seminar of the WFNS. It is my pleasure to speak about Professor Kano, and it is an honor to have to deliver this memorial lecture. Professor Kano left us on the 6th of August this year and left a very, very valuable legacy. And I would like really to talk about what he has left to us. Professor Kano was constantly championing the provision of proper neurosurgical care to the patients in Asia. He was always insisting that it is our duty to improve that care and to support it with all our means. This was a clear line of action through all his life. Our world has not been the same in the 70s when Professor Kano was a young man, and at the times when he was starting his career, the background was completely different. In the 70s, we were emerging from a period of post-war recovery. There were different ways of thinking, very stereotyped. The transnational, trans-border cooperation was not so active. We were witnessing the Cold War. And at those times, the young generation was starting to feeling that something has to change. In those times, also the consideration of what the future has to be was also going to change. In those times, in Japan and all around the world, the new generation was having completely new view of what we have to do, how much more we will be integrated in the world. Definitely, neurosurgery is strongly dependent on the economic development of a country where it is performed. And if you look again at those times in the 70s, progressing to the 90s, we have a rapidly recovering Japan in the 70s, followed by the 4 other Asian powers, South Korea, Taiwan, Hong Kong, Singapore, and finally by the 2 giants of China and India. Tendency to urbanization, and unfortunately, gradual separation between rich and poor. Neurosurgery was not the direct outcome of the economic development, much more child mortality, infectious diseases, well, longevity was increasing. But neurosurgery had to be supported in a special way in those times. So this kind of highly specialized and complex medical treatment really benefits from the economic development. Where was neurosurgery those times? In the major developed countries, Europe, Japan, America, it was definitely coupled with technological progress. Microscopes were going on, scanners, and whatever you imagine. In Asia, which is more a cultural concept because of its diversity, there were different economic statuses in different places, diverse traditions, history, social, and political background. So each Asian country was having its specific conditions, and neurosurgery had to develop in its specific way. So the middle and low income countries were having really difficulties in developing proper level of neurosurgical care for their population. Certainly there was no magic solution, and it had to be some kind of all resources engaged. We had the possibility of, as much as possible, adapt the neurosurgical practice to the economic level of the country. But those new generation thinkers understood that international cooperation may play a very important role. So solution for neurosurgery was going to be certainly both national and international. At that time of the stage was going to appear Professor Kano. Well, this generation to which he belongs has been becoming socially active, particularly in the late 70s, 80s, and 90s. And the way of their thinking was essential. He was born in a small city, Kuwana, not far away from Nagoya, Mie Prefecture. An excellent student, entered Keio University, graduated it in 1965, then joined the Department of Neurosurgery and completed his residency until 1972, always with excellence and with a special prize about tumor research. And Professor Kano, in this excellent start that he had with a lot of promising future, was looking for realization. At that time was created a relatively unusual new type of university, Fujita Health University, in the outskirts of Nagoya, which is intending very rapidly to promote the most advanced level of medicine. And they decided that the best option for them will be to recruit a very, very potentially strong in the future, promising young neurosurgeon. Professor Kano completely, Dr. Kano at those times, completely matched those criteria. So he started working with the Department of Neurosurgery in 1972, 3, 4. Then was created the Department of Neurosurgery. Those efforts were supported also by the Ministry of Health, which was interested in creating centers, emergency centers for tackling the most important socially impacting disease like cerebrovascular disease, head injury. And this department very rapidly evolved to even a teaching institution with a residency program. That kind of rapid progress was also rapid progress of the mind. His vision of what can be done in neurosurgery was very rapidly expanding, and he was definitely understanding that what he is intending to build in Japan can be built also in many other countries in Asia. At that time also, financial expansion was very clear. Japan was gaining economic power, and the international understanding of the role of Japan was also progressing rapidly. Japan's role was becoming more and more significant. What were needing the neurosurgeons? There were different problems, but one of the main problems was the severe shortage of neurosurgeons. If trained, they were of the similar skills and knowledge like those in the advanced countries. However, they were very limited in number, and the poor patient was not able to reach them. By performing even uncomplicated surgery managed with simple technology, it was supposed that they will really have a social impact and they will really be able to help society overcome the deficiency of neurosurgical care. Neurosurgeons had to be retained. They were intending to leave if they are not satisfied with what they do. So somehow the meaningful practice had to be created in the Asian countries. Okay. How he formulated his goals is goals for improving neurosurgery, and particularly the neurosurgeons of Asia. They needed education, they needed proper practice of neurosurgery, and they need to be supported for these two things. They needed some equipment and instrumentation. Very often the lack is very frustrating. They needed to do some research, even at their own level, in their own conditions. And they needed to be socialized with their peers. They had to be in a community, which was very stimulating, very competitive, and very motivating the quality of practice. What resulted was a big endeavor in creating a new community of neurosurgery in Asia. Until the very, very beginnings of this endeavor, Asian neurosurgeons were rarely attending any kind of international meetings. They were somehow excommunicated from the major neurosurgical meetings and societies around the world because of probably financial reasons. That made the problem even deeper once they were not able, after performing, to sustain their own practice in the proper way. So Professor Kano decided to establish a communication between those who can help, which were the powerful economic entity in Japan, like big corporations, and the young neurosurgeons who are going to benefit through education and in Japan. In this way was created the Asian Congress of Neurological Surgeons. But let us again say a few words about its initiation. There was a small meeting, small to say just a couple of days in 1993, which attended approximately 100 participants, mainly teachers from Japan and young neurosurgeons from Asia, which was extremely successful. That was acclaimed and appreciated. When the young neurosurgeons returned home, they were really, really motivated. And that kind of socializing among peers and educating the junior specialists was having a very strong impact. This actually showed that the ideas of Professor Kano can be really bring to reality. This success immediately translated into continuing their activities. Professor Kano was having supports also in Japan by Professor Hashi, Ota, and also we had the support of some major corporations, including Toyota, which was financing a lot of the activities, financing even the stay and the training during that period of Japan. So every 2 years, these meetings continued repeating. They were really a success. They are a success even now when we are bidding for the 2024 meeting, which will be number 16. And that is an established society in the world. These 15 meetings were really having each of them its own image, but in general, I just will show you one random of them, which was in Istanbul on the 9th meeting of the Asian Congress of Neurological Surgeons, which looked like a gathering of several hundred neurosurgeons, of them a big number of eminent teachers with some pre-meeting courses, including Professor Yassergil demonstrating white matter anatomy, and many neurosurgeons, 45, were supported during the stay there, invited speakers, big number, 500 presentations, a lot of posters, everything like a major international meeting, but only and mainly for the purpose of the young generation of neurosurgeons in Asia. Well, what was giving all this to the young neurosurgeons? They were having the opportunity to learn, to have the highest level of mention. You saw Professor Yassergil over there. And there was interaction in between the generations, no cost. Particularly the hands-on courses are extremely expensive. So that was really opportunity for them. And finally, they can show what they're achieving. That is also very motivating. Well, 3 days, 5 days, 2 days, courses every 2 years, that was definitely not enough to provide a more solid training. Neurosurgery has to be practiced after the whole continuity of the diagnosis and treatment is managed, learned, and attended at least for a certain period of time. In Japan, there is no provision for foreigners to be trained in the full courses, so because of the language and other reasons, but different options have been searched, 6 months, 2 years, just a week and repeated. Finally was established a form of 3 months fellowship, may be extended. And Fujita Health University became the base, the learning institution, which was supporting later on a numerous cohort of foreign neurosurgical fellows. It is like a society already. These 3-month fellowships were giving full exposure to all kinds of activities. That was giving them the access to some subspecialty in which they were engaged whole day, full day, 24. They were laboratory training opportunities. They were maintaining relationships after they finished their fellowship. And this kind of benefits were not less than any major fellowship that you can do in Western Europe and the United States, which were much, much limited in number, and the access to them was much more difficult. Well, the training was, on one side, definitely very efficient. On the other side, it was a way of learning about the new practice of neurosurgery that will happen in Asia, the dedication to the patients, the socializing. At the same time, the fellows were giving the opportunity to integrate in the Japanese community, having the chances to attend local meetings and so on. So their life completely supported by the institutions were really made to excel in that level. Many of these fellows had the chance to further on establish other relationship and even perform research projects, which was very important into the further development of research in their own countries. Now, beyond the ACNS, Professor Kano was extremely active in doing many other kind of activities. And these activities were, if not partially, if not completely, partially at least, dedicated also to the young neurosurgeons. One of them was the interim WFNS meeting in Nagoya, which was an enormous meeting. Together with the Asian Australasian Congress, there were 3,000 participants. Out of them were about 250 young neurosurgeons. There were 44 educational meetings. It was a huge, huge event for the neurosurgical community in the world. And this kind of activity really opened a lot opened the eyes, opened the opportunities that connections made for the young neurosurgeons of Asia. Further on, the WFNS much closer associated its activities. Professor Kano was much more integrated and became later on an honorary president of the WFNS. And in this way, the young neurosurgeons had the access to cadavers, skull-based teleconferences, exchange programs, and other kind of activities that were still made on worldwide basis, but not so much widely accessible to the Asian colleagues. Professor Kano was often visiting Asia. He was regularly visiting many countries. For 1 year, for instance, he did India, Cambodia, Mongolia, Bangladesh, Vietnam, making courses. On one occasion in 2006, he managed even to visit Pyongyang. That was really a broad access. Very often where he was bringing instruments and some kind of simple equipment with himself. He was very, very strongly supported by Professor Sano and Professor Kato, who were also bringing instrumentation, even with their own means and financial means and resources. So this kind of permanent academic relations were established with many institutions. This is just a short list of them, and in many of these institutions, he was having an individual contribution. He was going and lecturing and performing some kind of specific teaching on a course, and so on. Meanwhile, while at home, with other fellows and colleagues and supporters, he created several books. Those were written with the dedication to the young Asian neurosurgeons. They were created with the purpose of being applicable to the conditions in which Asian neurosurgeons practice. And many of them really were provided free to the young neurosurgeons. This kind of, here I'm just demonstrating 6 of them, but there are more, and really they are a great legacy for the achievement of the team of Professor Kano. Another major achievement was the Asian Journal of Neurosurgery. As an idea conceived like in the 90s when we discussed with Professor Kano, when I moved to work into the Fujita institution in between 2005 and 2008, was possible finally to have the Asian Journal appearing as a separate printed form of journal for the Asian Congress of Neurological Surgeons. Until now, it is having a great success. It is now in its 16th volume, issue 3, and it is aiming both to educate and stimulate the scientific innovation of young neurosurgeons. Professor Kano had always 2 great supporters who were working together with him, and these were Professor Sano and Professor Kano, both world-renowned vascular neurosurgeons who have dedicated a lot of their professional and free time to the work with Asian neurosurgeons and world young neurosurgeons. Professor Kato now is in charge of the Asian Congress of Neurological Surgery, supporting as a foundation a lot of young neurosurgeons, doing extremely active role in the WFNS. Well, Professor Kano was world-renowned, globally recognized neurosurgeon, and he left also a line of legacy of values that he was really not stepping back from through all his life. He had clear recognition all around. This is a list of many of the awarded honors and titles. There is no limit of that. I will say that this is a very, very long list all around the world. He had the international recognition in Asia, where often he was really celebrated in different institutions and communities. He was having worldwide recognition at the WFNS, the American Association and the Congress of Neurological Surgeons, with the most distinguished honors from these organizations. In Japan, he was highly, highly appreciated. This is a special award from the Japanese emperor he received in 2015 for his achievement in bringing the role to the medical development in Asia. His activities in acclaim were not a way of the normal life of a neurosurgeon. Here I just summarize until 2007, when I was still in Fujita, what is the number? 4,514 cases he has operated himself. That means more than 200 and so surgeries for more than 20 years. That is a pretty big number. It's a very busy neurosurgeon, while doing everything that I was speaking about. So establishing such kind of personal action, personal demonstration, and teaching others by what you do, it was really the personal example, the role model, which was very important for him. Other activities too. JIMCO, International Medical Cooperation, supplying Asia with additional support, promotion of different other kind of social and broad public. Speaking to the public too was considered for him important. He supported the Neurosurgical Association, not so formally in Japan, like the Brain Congress of Brain Tumor Surgery, Commerce Society, where he was deeply interested because of the dorsal column stimulation. He received numerous general awards for his achievement, for his contribution to science. For instance, for the dorsal column stimulation, for interest in common it is a special honoris causa doctorship in Poland, one of a very renowned university. But finally, Professor Kano was all never forgetting about the poor patients in Asia. They were saying, okay, those third come from the underdeveloped country. Who is going to support them? We have to provide them neurosurgeons who are going to care for them, irrespective of what the overall tendency of neurosurgical science is. He was very critical and analytical of himself. He was saying, okay, in the 30s, I was doing surgeries. I wanted to learn them. In the 40s, I was starting to care, okay, my patient have to do well after surgery. In the 50s, I wanted to do the greatest ones, the most complicated. In the 60s, suddenly I decided that probably the most important is what is the psychological outcome. Are there really these people returning to their normal life? Are really the patients and the families happy after what we have done? What was the real impact on human life? Until the end, Professor Kano was interested in science, in what the world is doing, what the new things have happened. He was constantly intending to write down what he thought was very, very important. He left a lot of achievements, a great legacy, both material and moral. And really, we can say that he left a lot of significant contributions to Asian neurosurgery, which will never forget him. He really lived an amazing life. What a life. Thank you very much.
Dear Chairman, dear colleagues, thank you so much for this opportunity to have a talk today on this very exciting topic. I want to attribute my talk to Professor Alexander Potapov, who left us this May. He was an innovator to inspire many great ideas. 30 years ago, he initiated a Department of Computer Sciences at Burdenko Neurosurgery Institute, which is in Moscow, Russia. In recent years, he strongly supported the advancement of artificial intelligence in neurosurgery. Our intuition about artificial intelligence is a computer that can learn and think like a human. The question about the ability of machine to think was raised by Alan Turing, one of the pioneers of computer sciences. Why does this idea become so popular today? Well, we are living in the era of data. Today, we collect data much faster than we can extract solid knowledge from it. So it would be great to have a tool to proceed with the data we generate, to make them work more effectively for us, to improve the efficiency of its secondary usage. The good news is that lots of mathematical methods have been developed for these problems already. With the growth in computer power, the implementation of these methods was brought to life. Today, we have a cost-efficient way to store, transfer, and compute a massive amount of data in a way that was never possible before. But if we are talking about advanced mathematics only, why is it called intelligence, in particular artificial? Because it can deal with data usually preceded by humans. Finally, what makes artificial intelligence promising in different areas is success stories in business and science and in those areas where you can get enough data. Probably the image of artificial intelligence that is being formed today mainly by mass media is far from reality. What is artificial intelligence in technical sense? A formal definition for artificial intelligence may be a mathematical solution which automates intellectual tasks normally performed by humans. At the same time, the term artificial intelligence is used to name a branch of computer science that focuses on creating intelligent machines that act like human beings. In that way, it implies many smart technologies with human-like behavior.
Artificial intelligence has gone through various periods of heyday and decline of interest in its history. There are two main popular paradigms of artificial intelligence used to solve some intellectual tasks. Historically, the first paradigm in this field was a symbolic AI. That is the approach based on explicit representation of knowledge. In this approach, you need some predefined, human-readable knowledge to build a solution and program it explicitly. Symbolic AI was the dominant paradigm of artificial intelligence research from the mid-1950s until the late 1980s. For instance, these technologies were used to create software that played chess. Machine learning is the second and modern paradigm of AI based on the idea that you can learn the solution from data. So, in symbolic paradigm, you apply the rules to the data through a classic programming and you get the answer to your question. In machine learning, you feed the data into the machine that solves complex equations, and then you get the mathematical model that produces the answer to your questions. How does it work? Machine learning is not equal to human learning. It is much more primitive. Let's simplify and treat machine learning as a process of solving equations. We have data, there are some x's, the response, there are y's. You solve equations and calculate the parameters for the model that maps x's into y's. This learning process is also called training. It is all about calculations. That was a classic example of supervised learning. Supervised learning is learning a model that maps input data to an output based on example input-output pairs. Unsupervised learning is learning regularities directly from data without any examples in the output.
Today, machine learning is the cornerstone technology of artificial intelligence. Literally, it is learning regularities from data in a form of mathematical model. In other words, a model is learned from data.
In data analysis, we deal with three general types of models defined by their purpose. The first one is a descriptive type. The purpose of a descriptive model is to describe or illustrate characteristics of some data. The analysis might have no other purpose than to visually emphasize some trends or artifacts in the data. The second type is inferential. The goal of an inferential model is to produce a decision for a research question or to test a specific hypothesis in the way that statistical tests are used. In many but not all cases, a qualitative statement is produced, for example, whether a difference between groups was statistically significant or not. The third type is predictive. This type is strongly associated with artificial intelligence. In artificial intelligence studies, data are typically modeled to produce the most accurate prediction for new data that the model has never seen. Here, the primary goal is that the predicted values have the highest possible fidelity to the true values of the new data. Supervised and unsupervised models fall into this category.
Conventionally, we classify all machine learning models into shallow learning and deep learning based on model architecture. In deep learning, a learning process is organized in layers, and that models are typically called artificial neural networks.
A standard modeling process requires lots of steps in which firstly you get data, do the exploratory analysis, try simple straightforward solution, for instance shallow modeling, then test, measure performance, get back to data preprocessing, feature engineering, then rebuild your model, measure performance, etc. The typical modeling process starts with exploratory data analysis. The understanding gained from exploratory analysis results in the creation of specific data features that make it easier to model the observed data accurately. We call this process feature engineering. This can include complex methodologies. A variety of models could be generated and their performance is compared. Some models require parameter tuning, where some structural parameters are required to be specified or optimized. To create a good optimized model which will generalize well to new data, in an experiment we usually split the data into 3 blocks. The first one is training sample used to build the model, the second one is validation sample used for parameter tuning, and the third one is test sample which is used to evaluate the model once. Finally, we evaluate the model using performance metrics. Here I'm showing the most popular metrics for classification and regression models. When reporting the model quality, it is a good practice to provide several metrics in a complex. For instance, you have a great area under ROC curve, good accuracy, very high specificity, but low sensitivity. In cases where sensitivity is important, for instance in diagnostics, such model won't perform well.
What are the general examples of AI in our life? These are computer vision, speech and voice recognition, text reading and understanding, and machine translation. What are the goals of using this computer behavior in medicine? The most obvious and general purpose is the automation of medical processes. Imagine a computer that can read medical records, judge medical images, and suggest clinical solutions much faster and more confidently than a doctor can do nowadays. That might be helpful. Today, neurosurgery is a complex discipline which development is dependent on the close integration of clinical and fundamental neurosciences and technologies. These are basic optical technologies, intraoperative neuroimaging and neuronavigation, metabolic diagnostics, awake surgery, intraoperative neuromonitoring, digital and additive technologies, high-precision stereotactic radiosurgery and radiotherapy. At the same time, neurosurgery is the only clinical discipline that provides direct access to the living human brain for clinical research. Implementing a bunch of technologies, neurosurgery routinely generates a lot of data that can potentially hide valuable information on how our nervous system functions and breaks. Therefore, the secondary use of this information resources is absolutely justified, but not a very simple task. And that is why I would like to draw the attention of the audience to the importance of using data science, artificial intelligence, in the field of neurosurgery for the advancement of brain sciences, including brain pathology. What are the current use cases of artificial intelligence in neurosurgery? What is the rationale for investing in that type of technology? To answer these questions, we conducted a systematic review of the original research articles evaluating AI in neurosurgery, complemented with topic modeling to objectify our findings. On this slide, you see a tremendous increase in the number of publications on AI in neurosurgery in the recent years. The majority of studies were conducted in neuro-oncology, functional neurosurgery, vascular, spinal neurosurgery, and traumatic brain injury. Let me briefly show you a few examples.
Let's start with neuro-oncology. The main goals of using artificial intelligence in neuro-oncology were non-invasive malignancy grading. The graph that appeared is a set of words specific for the topic. I'm underlining the most important. Next comes non-invasive molecular diagnostics, brain segmentation and volumetric analysis, and prediction of treatment complications and outcomes.
The most obvious AI application in neurosurgery is image analysis. For instance, in a paper by Zhu and co-authors, machine learning algorithms were trained to guess IDH1 status in glial tumors based on MRI. Another example is a work from Burdenko Neurosurgery Center. A computer can learn how to automatically delineate small tumors when planning a radiosurgery. You see that the auto-segmentation in this example is pretty close to manual segmentation. This slide shows the work of an algorithm that automatically delineates the glial brain tumor. This work is being carried out now in our global project to predict the clinical manifestations of glioma, first of all motor deficit, according to MRI data.
Differential diagnostics is a topical issue in medical image analysis. This slide shows an example of a fairly successful solution to differentiate true tumor progression and radionecrosis after radiation therapy for brain metastasis. The value at the area under the ROC curve close to 1 indicates that the authors managed to find a useful model for such a problem. Less popular but important task is a real-time modeling of tissue deformation in image-guided neurosurgery. Here you see the example by Tanuti and co-authors.
This is a study of automatic acromegaly detection from facial photographs, an interesting example of non-invasive diagnostics. So, as it is illustrated with the research in neuro-oncology, the first reason to adopt artificial intelligence in neurosurgery is the transition to the most non-invasive and safe technologies. Imagine a non-invasive tumor biopsy. You will say, it's just a fantasy. I will agree with you today, but who knows what's coming on tomorrow?
In functional neurosurgery, epilepsy diagnostics, outcome prediction, automated seizure detection, and Parkinson's disease diagnostics were the main issues in using artificial intelligence.
Here are some examples from functional neurosurgery where EEG, electrocorticography, biosensors, in addition to MRI, became very important data sources. This is a typical study aimed at detection of seizure onset in patients using intracranial EEG. Another example is a focal cortical dysplasia detection using MRI and machine learning. And on the right, you see a study with accelerometer-based wearable sensors used to detect tonic-clonic seizures. So the second rationale for artificial intelligence is a new evidence-based way to assess risks for adverse events. That is an essential component of decision support.
The majority of artificial intelligence studies in vascular surgery can be grouped by 4 main subjects: aneurysm studies, intracranial carotid stenosis, arteriovenous malformations, and intracranial hemorrhage, and there is a variety of topics in vascular neurosurgery. A typical task for machine learning in this field is image-based vessel segmentation. However, there are some examples of studies using heterogeneous data, including clinical text, images, laboratory data, etc.
Machine learning can account for much more factors than an expert can handle. That is the third argument. The fourth one is related. Considering patients' details in a model is a way of evidence-based personalization of care. At Burdenko, we are doing a project on automatic intracranial hemorrhage classification. Imagine that machine can take over a part of the doctor's routine. For example, annotate a medical image automatically with detection of hemorrhage subtype, or count the number of lesions, or measure their volume. That is an intellectual job, but still a clinical routine. Imagine how much time could be saved for a doctor.
Now let's get a couple of examples from spinal surgery. We identified 5 main tasks for using artificial intelligence in spinal surgery. It's non-invasive ICP estimation, discharge disposition, prediction, gait classification, complications prediction, and outcome prediction. For instance, a big set of clinical features was used to predict post-operative complications in spinal surgery. And of course, image analysis was also utilized, for instance, to detect spinal deformities.
One more very interesting example in spinal neurosurgery, the generation of synthetic CT scans from magnetic resonance imaging. That technology might prevent unnecessary radiation exposure, reduce time to treatment, and save costs.
Artificial intelligence can recognize critical anatomic landmarks in real time when doing neuronavigation. That is only an animal study, but a future human application is quite possible. Artificial intelligence may be applied not only to clinical data, but to scientific knowledge as well. This is the example of service utilizing artificial intelligence to study trends in scientific publications devoted to spinal neurosurgery.
So, digital technology can simplify diagnostic procedures and shorten the time between disease manifestation and best treatment administration. If we substitute some of the expensive technologies to digital, if we take some work off the doctor, this also leads to cost savings.
Finally, the tasks for machine learning in traumatic brain injury were quite traditional. They were mortality prediction, ICP, ABP, CPP on autoregulation analysis, consciousness impairment, and TBI severity diagnostics and TBI outcome prediction.
As we see, the typical sources of big data in neurosurgery are medical images, which have billions of data points, genome sequencing, terabytes of data, biosensors, including the devices in intensive care units, and medical records, which are much smaller in volume but underestimated. I represent the Burdenko Neurosurgery Center, which is the biggest neurosurgical facility in Russia and one of the biggest in the world. You see the amount of data we collect due to our surgical activity. That is why the application of artificial intelligence is absolutely reasonable in our center. And I would like to share some personal experience in AI development in neurosurgery. At Burdenko Neurosurgery Center, we have a laboratory of biomedical informatics and artificial intelligence. We are well equipped with a supercomputer and data storage. I want to show some of our work as an example of how a specialized artificial intelligence team can be incorporated into neurosurgical facility. One of our projects is devoted to the length of stay prediction based on narrative text data from electronic health records. We were surprised by how informative unstructured text could be in solving complex tasks as accurately as humans. One of our key directions in artificial intelligence is automatic medical text processing. We propose an algorithm to extract information from unstructured medical texts, which was published and patented. And here you see the quality of this method for paresis detection in clinical notes and identification of pulmonary embolism in medical records. We saw that using the combination of machine learning and human expertise can augment information extraction from texts. We also made an algorithm for scientific literature classification and received Best Paper awards at European conferences in medical informatics in 2020 and 2021. We are working on glioma classification by MRI patterns and prediction of postoperative paresis in glioma surgery by preoperative MRI. If you are interested in details of our studies, you are very welcome to find them in PubMed. So what did we learn from our current personal experience with AI research in neurosurgery? Let me share some key points. AI in neurosurgery is technologies that should be critically appraised with evidence-based research practices. When building a model, try to get data that will represent the patterns you are trying to capture with your model. The data should not only be big, but representative as well. Sometimes we won't see enough representative patterns even in considerable body of data. Data scientists are crazy about getting high-performance metrics for their model. But what we should never forget is that your model should generalize well. It would be helpful only if it can handle data it never saw before. That is a huge challenge, typically frustrating people trying to implement AI into medical practice. And yes, we evaluate models using performance metrics, but they should be appropriate for a task. Here I'm showing the most popular metrics for classification and regression models. It's important to report several metrics when presenting the model's quality. It's a good practice. For instance, you have a great area under ROC curve, good accuracy, high specificity, but sensitivity is a bit low. In the cases where sensitivity is important, for instance, in diagnostics, such model won't perform well, even though it has a large area under the ROC curve. What about a professional attitude to AI in neurosurgery? What should we expect from AI today? Basically, what AI is believed to do is to facilitate, speed up, and improve accuracy in neurosurgical routine and research. But being just a technology, it cannot replace a medical expert in responsible decision making, at least not today. Today, we are still in research progress. So in conclusion, the use of artificial intelligence is becoming a trend in clinical neuroscience and a separate niche in neurosurgery. However, the study series are not that big today, and the clinical utility of AI in neurosurgery is still a subject for evaluation. Today, we can't imagine all the benefits AI can bring into neurosurgery, but obviously it could be any efficiency you may imagine coming from automation. And this list is going to be continued. I would say that our current commitment is to add up to this list and figure out in which cases artificial intelligence is most useful. That is the rationale for research in this field. Ladies and gentlemen, thank you so much for your attention.
Ladies and gentlemen, my name is Nasser El-Ghandour. I am president of the Egyptian Society of Neurological Surgeons. I'm general secretary of the Continental Association of African Neurosurgical Societies, and I'm treasurer of the World Federation of Neurosurgical Societies. I speak today about the impact of COVID-19 pandemic on neurosurgery education. Introduction. The coronavirus pandemic has affected all aspects of human existence with social and psychological repercussions that generations have not witnessed before. As the virus is projected to afflict large portions of the world population, clinical research at all levels has been suspended. Conferences have migrated from the classroom to the digital screen. As a result of this major change in the method of education, and with the eruption of virtual learning, many important questions arise. What's the impact of COVID-19 pandemic on neurosurgical education? Can virtual learning totally replace in-person meetings? What are the limitations or challenges of virtual learning? What's the opinion of neurosurgeons about this new platform? In order to answer these questions, we performed 2 surveys. One of them is global, and the second one is continental. We first speak about the global survey. We started our survey May 21 and closed June 4, 2020. We obtained neurosurgeons' contact information from professional associations. We also utilized open access social media-based surveys, Facebook and Telegram. The survey was translated into 7 languages: Chinese, English, Italian, French, German, Portuguese, and Spanish. It was administered through Google Forms and WeChat. Methods. The survey has 3 components. The first component is participation in virtual learning before and after COVID-19 pandemic. The second component about the opinion concerning turning neurosurgical education to be virtual. The third component is about the future perspectives concerning the process of virtual learning. Data analysis was performed using the chi-square, Fisher exact tests, and the multivariate logistic regression analysis. Results. We had a total number of respondents of 891 covering 96 countries. 165 of our respondents were from the African continent. The survey is concerned about the process of education and training, including both junior and senior neurosurgeons. The World Bank classification was used in order to categorize the countries according to income into low, lower middle, upper middle, and high income countries. This bar graph shows the incidence of participation in the survey among the different categories. The World Bank classification was again used in order to categorize the countries depending on geographical distribution. The bar graph shows the incidence of participation among the different regions. This bar graph shows the incidence of participation in the survey according to practice session. And as we can notice that the academic practice constituted the maximum participation with 48.5% incidence. This bar graph shows the incidence of participation in the survey according to the specialty. And as we can see that general neurosurgeons constituted the maximum participation with an incidence of 74.3%. This bar graph shows the incidence of participation of faculty and the trainees of neurosurgery in the survey. Now we are going to speak about the first component in the survey, which is a comparison between the period before and after COVID-19. This shows the incidence of participation in virtual learning among the respondents before and after COVID-19. And as we can notice that the incidence of participation in virtual learning was increased from 44.9% to 78.3%. This shows the incidence of paying fees in virtual learning before and after COVID. And as we can notice that the incidence increased from 51.3% to 79.8%. This shows the incidence of participation in virtual learning according to organizations. International organizations constituted the maximum percentage with an incidence of 63.2%. Now we move to the second component of the survey, which is concerned about the opinion concerning technical neurosurgical education to be virtual. When respondents were asked, could virtual learning totally replace on-site meetings, 32.9% answered yes, whereas 54.7% answered no, and 12.5% didn't give any answer. Are you interested to attend the virtual learning meetings? 74.3% of the respondents said yes, 22.2% said maybe, whereas 3.5% said no. This bar graph shows which subspecialties who don't benefit from virtual learning. The third component of the survey is concerned about the future participation in virtual learning and future perspectives. When respondents were asked, do you expect an increase in virtual learning in the future? 69.7% said yes, whereas 9.9% said that it will remain the same, and 2.2% said that it will decrease. When respondents were asked if they can pay fee for virtual learning in the future, 13.7% said yes, whereas 64.1% said it depends on the amount, on the content of the activity, and 16.9% said no, whereas 5.3% said that they don't know. What are the factors that influence participation in virtual learning? And as we can notice from this bar graph, the three most common factors are the cost, time flexibility, and speakers list. Could virtual learning alter neurosurgical education in the future? 62.4% said yes, 17.6% said no, 20% didn't give any answer. One of the privileges of this survey that it was possible to perform multivariate logistic regression analysis because the number of respondents was high. Speaking about sub-Saharan Africa, the multivariate logistic regression models shows two important significant results. When the results were compared to North America, sub-Saharan Africans said that virtual learning can alter education. Sub-Saharan Africans said that they are willing to pay in the process of virtual learning. The results of this survey were published in the Neurosurgical Focus in the December 2020 issue. Now we move to the African Continental Survey. This survey was created by the African Young Neurosurgeons. It started April 16 and closed May 21, 2020. It was disseminated by the Secretary of Acns through emails to the 5 African regions, North, South, East, West, and Central Africa. And this was distributed to the second vice presidents in these regions. We also utilized open access social media-based surveys, Facebook, Twitter, and Telegram. The survey was administered through the Google Forms. Results. The survey was concerned about neurosurgeons during training, and it was concerned about the impact during the period of COVID-19 pandemic over the process of training, income, and clinical activity. It was not concerned about the impact on the future. The total number of respondents were 123, covering 23 countries. This map shows the incidence of contribution in the survey among the African continent. The countries which contributed to the survey are colored in green color. This bar graph shows the incidence of contributing African countries in the survey. And as we can notice that the maximum contribution was from Nigeria and South Africa. This shows the incidence of previous exposure among the registrants to COVID-19. And as we can notice from this bar graph that 47 of the respondents said that they have not been exposed to COVID positive patients to the best of their knowledge, whereas 35 respondents said that they were exposed to COVID positive patients in the emergency department. What about the impact on training? Departmental teaching was cancelled in 43.9%. There was a shift to online teaching in 43.9%. Examinations were postponed in 57.7%, and it was cancelled in 19.5%. Trainees were re-employed in 11.4%. Training rotation was suspended in 7.3%, and trainees were sent home in 3.3%. This shows the monthly income in United States dollars among the respondents in this survey. What about the impact on the income? Fortunately, there wasn't any effect on the income in 84.6%, whereas there was a drop in the income in 9.8%. It shows the impact of COVID-19 pandemic on the clinical activity. And as we can see from this bar graph that the clinical activities was reduced in the clinics in 45.5%, and cancelled in 61%, whereas the clinical activities were reduced in elective surgery in 91.9% and in 74.8% in the emergency surgery. The results of this survey were published in the World Neurosurgery in November 2020. Look at this table, it summarizes the difference between both surveys, the global survey and the African continental survey. The global survey was concerned about education and training, whereas the continental survey was concerned about residential training. The first one included juniors and seniors, whereas the second survey was mainly including African young neurosurgeons. We had total number of respondents of 891 in the global survey as compared to 123 respondents in the continental survey. The results of the first survey were published in the Neurosurgical Focus. The results of the continental survey were published in the World Neurosurgery. The first one was concerned about the impact of COVID-19 pandemic during the period of pandemic and in the future, whereas the second one was concerned about the impact of COVID-19 pandemic only during the period of the COVID-19 pandemic. The first survey was concerned about virtual learning, whereas the second survey was concerned about training programs. The high incidence of contribution in the global survey allowed us to do multivariate logistic regression analysis, which was not possible to be performed in the continental survey due to the small number of contributions. Apart from these conclusions, let me tell you my personal opinion. After organizing 53 webinars as treasurer or second vice president of the World Federation of Neurosurgical Societies during the COVID-19 pandemic, and all these webinars were organized in collaboration with the Continental Association of African Neurosurgical Societies and the Egyptian Society of Neurological Surgeons, I can say that it is possible to tolerate a webinar for 2 to 3 hours. However, a complete scientific congress for 2 to 3 days, each day for 8 hours, it will be exhausting because I cannot lean forward over my laptop or PC computer system for such amount of hours for 3 days. I also believe that social events is considered to be an important part in all our neurosurgical events, and it is very important in order to develop and maintain friendship between all of us. However, the virtual learning has many advantages. One of these advantages is money saving. And so it is suitable for developing countries because for candidates in order to travel overseas, to go in order to participate in a meeting in another continent, it will be very costly for our candidates in Africa and the Middle East. Another advantage is that it is time saving, and this allows eminent faculty to contribute in the process of neurosurgical education, whereas some eminent professors of neurosurgery they do not have the enough time in order to travel overseas to educate candidates in the lower and middle income countries. However, my personal opinion is that virtual learning is not considered to be the proper way of developing neurosurgical skills. We still need the cadaveric labs, and we still need the hands-on workshops. Virtual learning can be considered to be a proper way of education in other specialties, maybe dermatology or internal medicine. But in our specialty, which depends mainly on developing skills, still we need the cadaveric labs and the hands-on workshops. There are also many important challenges which are facing the process of virtual learning. The first challenge is credibility, which is very important. In order to calculate the number of hours for any candidates, how to develop credibility in order to calculate this number of hours. Is it the proper way for certification, or only it is considered to be a very good way of education? The second challenge is the coordination between events in order to avoid overlap, as we can notice that there is overlap between different events occurring on the same day and sometimes exactly at the same time, which is going to decrease the benefit which candidates can develop from these activities. Another challenge is the coordination between the 5 time zones in the 5 continents. For a webinar extending for 2 to 3 hours, there is not going to be any problem. However, for a scientific event which extends for a full day, for 8 hours, for a few days, we are going to encounter the problem of the difference in time zones between the 5 continents. For example, there is 12 hours difference between United States of America or the Latin American continent and the Japan country or the Asian continent. And this will consequently result in that some speakers should make their presentations as video presentations, recorded MP4 videos. And this is one of the drawbacks which will not allow for live interaction between the candidates and the faculty or allow for live discussion. In conclusion, COVID-19 pandemic is considered to be a turning point in the process of neurosurgical education. It's the actual beginning of virtual learning. Virtual learning cannot totally replace real meetings, but it can be used as an alternative method in any future crisis. The long-term impact of virtual learning on the process of neurosurgical education is still not evident. It seems that virtual learning and in-person learning soon will be integrated in a new type or a new method of neurosurgical education, what we call the hybrid meetings. I'm also glad with my team that we performed one of the earliest global surveys about the impact of COVID-19 pandemic on neurosurgical practice, and the results of this survey were published in the Neurosurgery. Let us not forget our brothers and sisters neurosurgeons who have fallen while fighting against COVID-19 pandemic. Unfortunately, 5 of them are from Egypt. I'm glad and honored to be a contributor over this publication, which honors our neurosurgeons colleagues who lost their life while fighting against COVID-19 pandemic. Our thoughts, actions, prayers are with all of them and all their families. Let me end my talk by sending my prayers to all of them to be in heaven and to rest in peace. Thank you.
My talk is about the new concept of hydrocephalus and CSF physiology. I have no conflict of interest or disclosure. So today's contents is shown in the slide. The first topic is what is CSF? So what is CSF? CSF is a fluid in the subcutaneous space, ventricle, and central canal. So it is named as a fluid in a certain space. So this concept is the same as naming of the blood, and then blood is named in the name of the fluid in the vessel. The right side is blood model, the running water pool, it's circulating. Left side is CSF model. It's based on classical theory. CSF is producing chlorplexus and the flow go to the alveoli and absorb. But nowadays we know the CSF is produced in capillary and both and absorbed capillary also, and there's another route such as the dominant route. So can you say this is circulation? And also, can you calculate the production rate of the blood? It's impossible because only the blood itself is only the fluid in the vessels, and the important thing is blood pressure and the blood volume and the content of the blood. The same as CSF, we cannot say CSF production rate. Why? So CSF formation rate is written in a textbook like this. So 3 times exchange a day, so about 5 meters per day. But when and how these data are obtained, it's very old data, very difficult to measure the true value, I think now. So this is the many reports about the production rate of the CSF, production volume of the CSF in the paper. There have been many reports measuring CSF production rate, but all the data obtained based on classical theory, which is all the CSF come from chlorplexus and absorbed alveoli. Therefore, there are not true CSF production rate. And the evidence that shows CSF comes not only the chlorplexus hydrocephalus can be controlled by cartilization of chlorplexus. CSF formation rate of the plectocartilage group is 70% with normal, and chemical composition of CSF did not change after the chlorplexectomy. So It is clear that the CSF comes from not only cold plexus. So the Dr. Klarica in Croatia, he is a pharmacologist. He performed experiment of the CSF, about the CSF formation rate. He using the cat, and he cannulated and obstruct the aqueduct duct and observed the pulsation of the CSF level. And then CSF permanently only pulsatile, but no single drop of CSF was observed overcome the normal level of the high pressure. And he concluded the classical CSF circulation theory was wrong. And his hypothesis is all the CSF is come from the capillary. So the driving force of the gradient of the hydrostatic pressure in arterial capillary, and the fluid is absorbed in the venous capillary by osmotic pressure. And this is the extracellular self is equal to the CSF. However, he cannot explain this situation, why the ventricle is enlarged in case of the acute obstructive hydrocephalus with posterior saucer. This is one of the misunderstanding, cause of misunderstanding. I will answer later. Then now, many data shows the CSF product is not produced only the cold plexus, and this classical theory is wrong. So the CSF does not circulate like this. This is another misunderstanding picture. So what is the measurement of RRC stenography finding? So it is believed that the radioisotope from injected in the lumbar cervical space go to the upward and on the surface of the brain and absorbed in the alveolar villi. However, in the other viewpoint, you can see only the diffusion of the tracers. High ratio activity means congestion of tracer. So it is not identical to absorb water of CSF. So now we can say CSF does not circulate, and true CSF production rate and volume are unknown. So water is CSF equal? No, it's not equal. So the next topic is water in the brain and CSF space is turnover. I told you. So water turnover, water movement from the artery to brain is observed in many experiments more than 50 years ago. So extraction of the water from the arterial blood during the single pass is estimated about 58% in dogs and about 90% in primate. And then this curve shows a relation between the CSF and the extraction rate of the water molecule in some conditions. Even if osmotic blood pressure of the fluid is different, for example, saline to more urea distilled water, and then or the BBD disruption, all points are on the same curve here. So interestingly, it's not affected by the osmotic pressure, and also it's not affected by the BBB destruction. All the situation, extraction rate is the same. It's very interesting. Again, 85 to 90% of the water molecules are extracted from the artery into brain tissue by a single pass. Movement of water, now I can say, movement of the water molecule is very fast. This is a property of water molecules which allow its O15 PET for CSF measurement. Then we performed the dynamic PET study to analyze the water molecule movement for the normal volunteers. Then we set the box of interest as in this slide. So many areas of the brains and also CSF spaces, for example, lateral ventricle, cerebral fissure, and preponderant system. And then we measure the radioactivity changes. And this is the data. So this steep increase is seen in the brain itself. So the largest point peak was shown in the basal ganglia and gray matter. White matter is the peak is very delayed. And these three curves is the radioactivity in CSF spaces. The black is lateral ventricle, and the brown is Schirmer fissure, and also the pink is prepotential stem. So check precisely. The level of the lateral ventricle about 13% of the whole brain activity in the end of the measurement about 13 minutes. So compared to the lateral ventricle, Schirmer fissure and also the prepotential stem much larger, show much larger activity compared to lateral ventricle. So this means that these water molecules not come from the lateral ventricle, maybe they come from the brain surface. This slide shows the report from the Niigata University, Japan. They measured the water influx in the CSF spaces using a 7 decile MRI label, and water was labeled by the O70, so this is a cold isotope. And they used the animals, which is wild-type mice, and also Acapone-1 knockout and 4 knockout mouses. And this is the pattern of the signal intensity in the CSF spaces. And compared to the wild type, Acapone-1 showed a similar pattern. However, the Acapone-4 knockout showed a completely different pattern. So this means that the main route of water influx into ventricle is not by Acapone-1 but by Acapone-4, supporting the capillary theory by Clarika. So now we know the water is not equal to CSF, and the movement of water molecule is based on the PET study very fast and free and passive and bidirectional, and which factor regulate and control water movement and distribution. The most important factor is osmotic pressure. The content, the osmolarity of CSF keeps and controls the fluid volume and distribution in ventricles and cerebral spaces. This slide shows the very interesting topic. So, from the arachnoid trabecular cells, a certain protein we call protein D synthase, in other words, the beta trace was produced and secreted into the CSF space in the subclinic spaces. The function of this protein is as a kind of scavenger, but the other function might be the protein itself may become osmolarite and then keep the CSF in the interactive spaces. This is a hypothesis. Next topic is about fluid movement in brain and CSF spaces. So this is a schema of the neural fluid movement in the central nervous system. Firstly, we have to say nearly free communication of the molecule movement between ICS and extracellular space and CSF spaces and subclinic spaces. And then maybe there is no objection that the fluid comes from arteries through BBB or BCB, corpuscles or the capillary. There are two exit routes of neural fluid and its content. One is venous drainage and the other is lymphatic drainage. The main drainage route is capillary, and corpuscles also absorb CSF, but some amount of CSF should be drainage into the lymphatic drainage system from CSF spaces and also brain tissue directly. Recently, there's another hypothesis of the drainage system from the brain tissue. So it's called lymphatic system by Edith. This hypothesis is a high molecular waste molecules drainage system from the brain tissue, and the CSF go into the brain from the CSF space and wash out the waste molecules with the water into the CSF spaces. Again, I show the CSF donors route. So there are many pathways. So capillary, corpuscles, alveoli, all these pathway is into venous drainage. If venous drainage obstructs, what's happened? We know such kind of situation in clinically. One example, sinus thrombosis and the dural AVF involving SSS. Other time, venous pressure increased and result in the increase of ICP. However, we never see the ventricular dilatation. So, venous drainage route obstruction is not the cause of hydrocephalus. Another pathway is lymphatic drainage system. The main are lymphatics, perivascular space, and nasal lymphatics and nerve root sheaths. So, there is only two routes of CSF drainage system. So this is a possible cause of the hydrocephalus. And then I explain the two lymphatic drainage systems. One is drainage route from CSF space directly, and the second is the drainage route from the brain parenchyma. And from the CSF space, in the skull base through the ethmoidal bone and goes through the nasal lymphatics and leads to the cervical lymph node. The other is from the spinal nerve root and go into the epidural lymphatic networks. And the second drainage route is from parenchyma. So this interstitial fluid waste is drained from this pathway. So this is through the perivascular space of the arteries, and then goes cervical carotid artery and cervical lymph node. This slide shows the drug node route from the CSF mainly in the skull base. And this is a common drainage route in rodent, but it is questionable whether it is the same in human or not. In primate, nerve root sheath might be a main route of CSF lymphatic drainage. It has already been shown histologically, CSF goes out through lymphatic capillaries in the dura to epidural lymphatic network and paravertebral lymph node. In monkey, distribution of epidural lymphatic network are shown. The distribution is mainly in the cervical nerve roots. In human, cervical and upper thoracic nerve roots are important. The left slide showed the dye injected into the intracephally, and also the center slide showed the ICT images in human. The right image is the water distribution shown by MRI. Perivascular lymphatic drainage of interstitial fluid and solute from the brain is shown. Interstitial fluid and solute, shown green, diffuse through the narrow extracellular spaces of the brain, brain parenchyma, and drain along the basement membrane between the smooth muscle cells. The left shows the morphology of bilirubin space and perivascular space. The right showed the precise anatomy of it. The schema shows the perivascular space. The stoma pore present the CSF-facing leptomeningeal lining cell that have been identified on the outer surface of the artery in the subclonal space. There are fenestration gap cleft on the CSF-facing pia lining cell of the brain surface. The perivascular space, a fluid compartment within the outer outer walls of the blood vessel that include a vascular connective tissue space. The fluorescently labeled molecules were interstitially injected. It revealed the prominent perivascular signal along the all vessels. this showed the movement the molecules from the CSF space to the perivascular space. The slide showed the schema of the neurovascular unit. The slide showed the extracellular space of the perivascular space. In some areas, astrocyte coverage is loose and there is room. And then there is a communication between the extracellular space and the perivascular space. The next topic is a role of lymphatic drainage system. The role of the lymphatic drainage system has already shown more than 60 years ago. Large molecules cannot be washed out from the brain through the capillary, so the lymphatic drainage system is necessary. So large and water-insoluble metabolites should be drainage from the washed out from the lymphatic drainage system. So imagine in case of subacute hemorrhage, the subacute have disappeared within 1 or 2 weeks, but this washout is due to by a lymphatic drainage system. Maybe it is impossible to absorb all the clot from the capillary or the alveolar villi. Now I tell you the very interesting story in case of subacute hemorrhage patient. So LPDGS is one of the major constituents of the human CSF protein. It is 6 to 10% of the protein. And the function is about syncytin D2 and so on, and also the fact as a carrier protein. But this is a protein expressed in the CSF spaces might be affected by the SAH, and we checked it. And the left side graph showed the concentration of LPGS after the SH in CSF. So it increased significantly after the 3 or 5 days after the SH. And then the LPGS was collected and purified, and after the 7 days, CSF showed that the color is light green compared to the CSF after the 2 months is watery clear. So this we think this is CSF in LPGS combined something. And the substance combined to the LPGS was determined by the mass spectroscopy, and it was the bilirubin. And bilirubin is converted to bilirubin easily. So we checked the cytotoxicity of bilirubin using the culture neural cell, and it's the bilirubin have the cell cytotoxicity in dose-dependent manner, and it was inhibited by the LPGS concentration in dose-dependent manner. So we discussed that the role of the LPDDS is in case of the SS patient, combined bilirubin washout from CSF spaces as a carrier protein, and also that reduce the concentration bilirubin and for the protection effect. This is the physiological function of the protein that exists in CSF spaces. And also has a washout system, role of the washout carrier protein system. The next topic is the lymphatic system. This is a lymphatic system that supports interstitial solute and fluid clearance from the brain. So the solute is washed by the convection flow from the arterial side to the venous side. So arterial bulk flow is come from the para-arterial vascular space, and the fluid with solute was washed out through paravenous space. This is the hypothesis, and also they showed the relationship with the acapulin 4. So might be some the control is done by the astrocyte end of it. The lymphatic system is a very attractive system, but has some questions. So what is the driving force? And diffusion of bulk flow, they say that the convection flow, and the direction is true from the artery to vein, and from why the fluid from CSF to CSF should be flow, and water from Wilhelm Robin space to brain, and what is the role of alcohol for, and no mention about the perivascular drainage system by Vera. Arterial perivascular drainage is supported by experimental and clinical evidence. In glymphatic system, paravascular arterial space is Wilhelm Robin space, and paravascular venous space is unclear, and paravascular venous drainage is also unclear. Recently, many meningeal lymphatic vessels are found in primate and also human in along the parasagittal sinus. Many review papers describe the relationship between meningeal vessels and paravascular venous drainage of the lymphatic system. However, there has been no historical evidence the connection between the meningeal vessels and the CSF space or paravascular venous routes directly. We know aragonal barrier cells are tightly connected with the tight junction, making the outer brain barrier, so no leak from the CSF from this tight junction of the aragonal brain barrier. This is the summary of the lymphatic drainage system in the cranium. There has already been shown many drainage routes now. For example, from the skull base toward through the nasal lymphatics toward cervical lymph node. This is a perivascular drainage system, arterial perivascular drainage system toward the internal cardiac artery and lymphatic node or cervical node. This also from the CSF to the arterial wall, the movement of the molecules, and many lymphatic vessels is shown in along the sagittal sinus, as a parasagittal dura, and also they are prominent in the conference and skull base. This is a summary of the lymphatic drainage system in the spinal canal. So cervical spine and upper cervical and upper thoracic spine. So in human monkey. So we have to pay more attention toward these areas. So this is a summary of the neural fluid movement in the central nervous system. I put on a glymphatic system on this figure. So here the glymphatic system. So in the glymphatic system, as water has come from the CSF spaces and go out to the CSF spaces and wash out the brain content toward the CSF space. And now that there's a question is there any route exists or not into the lymphatic drainage system, lymphatic vessels? Then the question to be solved in lymphatic drainage. So the first, which is the main route of the lymphatic drainage system? Skull base, meningeal lymphatic vessels, nerve root, perivascular, arterial, and paravascular venous system. And also, what percentage of the renal fluid does the lymphatic drainage account for? Histological evidence between CSF space and meningeal lymphatic vessels should be shown. Further study is needed to clarify the relationship to disease or relation to disease or aging. The last topic is the mechanism of ventricular dilatation and also the new concept of hydrocephalus. Now, what is the definition of hydrocephalus? It is the symptomatic ventricular dilatation with the increase of the CSF volume or the changes of the fluid distribution in CNS. So, it is caused by malabsorption of CSF mainly. And then there is no objection because the shunt can improve it. So, all hydrocephalus is obstructive hydrocephalus. So the problem is, the point is where is the obstruction site? What is the cause of it? So hydrocephalus again, where is the obstruction site? And one of the causes that the obstructed obstruction of the lymphatic drainage system, not by the obstruction of the venous drainage system. The another classification of the hydrocephalus is communicating and non-communicating. This is obstruction between the ventricles and the CSF spaces. And the other concept of the hydrocephalus I call the relative obstruction. This is the high protein hydrocephalus caused by the acoustic neuroma, meningitis, and so on. As the mechanism of ventricular dilatation, bulk flow theory and hydrodynamic theory are famous. But now, the classical theory was denied because CSF does not circulate. So, then, how do you explain this situation of obstructive hydrocephalus caused by the posterior fossa tumor? We have another hypothesis of the mechanism of ventricular dilatation. We call it pulsation disturbance theory. This is a model of brain and ventricle. In the systolic phase, the brain pulsates. Then, interventricular pressure increases and CSF moves to the outside to compensate the pressure increase. Reacting force of the ventricle wall also increases. And in the same situation, if CSF pulsation is blocked, interventricular reacting force toward the ventricular wall increases. Then ventricular dilatation occurs to reduce reacting force. So in the text, this mechanism is as follows. The interventricular CSF cannot move freely by brain pulsation, no pressure compensation. Force to the ventricular wall in the unit area increases. Then ventricles dilate to reduce the force of the wall in the unit area until the same level of the force from the outside brain. This slide shows the relationship between the obstruction site of the CSF pulsation and dilated ventricles. In the normal condition, in the systolic phase, CSF flows toward caudal direction because intracranial volume changes are much larger compared to the spinal cavity. In the diastolic phase, CSF flows toward rostral direction. In case of aqueductal occlusion, CSF pulsation is obstructed at the aqueduct and intraventricular pressure increases. And then lateral and third ventricle are enlarged, but no change of the fourth ventricle and cervical space. So this is the example. So in the case of the posterior fossa tumor obstruction hydrocephalus, there is no increase of lateral and third ventricle, but no increase of the fourth ventricle cervical spaces. This is another example, the LOBA, long-standing overt ventriculomegaly in adult. Completely the same. The lateral ventricle, third ventricle is enlarged, but no increase of the cervical spaces. So next, in case of the obstruction of the cervical spaces, cause, for example, the secondary NPH after SAH, at that time, the CSF pulsation is disturbed at the exit of towards the cervical space. So, interventricular pressure, all the interventricular pressure, lateral ventricle, third ventricle, aqueduct, fourth ventricle is increased, and then all the ventricles is enlarged, but no increase of cervical space. So this is the example. All these SH cases, SH with hydrocephalic cases, show the increase of all the ventricular system, but no increase of the size of the dilatation of the subacromial space. So then we think about the INPH. It's called the DASH type. So in INPH, all the ventricular system and also the cerebral fissure is increased, but the tightness of occurred in the top of the brain. So in this hydrocephalus, we hypothesize the obstruction of lymphatic drainage, and then at that time, all the ventricular system cervical spaces CSF pulsation increase, and then all the ventricular system and cervical spaces are enlarged. So enlargement of cervical spaces occur, but are not completely equal to the DASH because the DASH has the tight high convexity of the sulci. But this was explained by the Dr. Yamada in Shiga University. So he explained in NPH patient, the inferior horn of the lateral ventricle is directly connected to the basal system at the inferior choroidal point of the choroidal fissure and the yellow area, and then water hammer increases into the toward the lateral ventricle toward upward, and then tight convexity occur, he explained. So now a hypothesis of the mechanism of ventricular dilatation is pulsation disturbance theory. The where is the obstructive site? The central and proximal side of the CSF spaces and ventricles from the pulsation generator must enlarge. So subjects for the further study, ventricular size would be controlled by the pulsation disturbance and contents is also right. So control of these two mechanisms, these factors, is very important, and malcontrol could result in a ventricular dilatation. Thank you for your attention.
Thank you for such wonderful lectures. And now I request all our attendee to ask questions if they have any. And you can also write in chat box if you have any questions. Please feel free to ask.
So can I talk?
Yeah, yes.
Hi, Ishu, how are you?
Good evening, ma'am. I am good.
Thank you for sharing the session. And I want to ask Dr. Gleb Danilov. Thank you very much for a nice lecture from Moscow. And we are focused on the new technology about AI or deep learning, etc. So, but how fast of the work or resolution or solution of the problem can you tell us? Gleb?
Professor Danilov, are you there?
Yes.
Hello, Professor Kat. Hello, all
Hi.
colleagues. Thank you so much for having me here, and thank you. That's a great honor and privilege to be present and have a talk. Thank you so much. I have some problems with internet connection, and I'm not sure that I've got the question. Would you kindly repeat it?
So with recent advancement of the AI and also the machine learning or deep learning, or so how fast, what's the advantage of the speed of our work? So can you tell us about some speed of the, how fast it can be done or the get solution?
The question is how fast.
So, okay, so what is the biggest advantage for neurosurgical the work with the AI? So it means the accuracy or faster surgery or whatever.
I think his internet is not working properly.
Yeah, I think so. I think so.
Yeah, you are mute, Professor Dani.
Thank you. Yeah, I'll have to answer. So if I've got you right, how can the artificial intelligence speed up the processes in neurosurgery? Is that correct?
Yes, right.
Yeah, so it can be achieved in many ways, as I believe. For instance, it can speed up some routines. Let us see the example of neuroradiologists. They have sometimes they have to delineate a lot of small tumors using their time and computer. So this process can be automated, and we have some experience in that. And we saw that a machine can delineate all the tumors for a neuroradiologist to save him time just to correct the contours of tumor. That is quite achievable, and that is a straightforward application of artificial intelligence. Another way is, for instance, to calculate the number of lesions through computer vision. Another example, for instance, which we believe is important, is an automated collection of information of adverse events through reading of text notes, clinical notes. That is research that I'm concentrated on, and we saw that the natural language processing technologies can achieve unbelievable results in extracting valuable information. So you can collect data with such a computer assistance on a real-time basis that can speed up dramatically and improve the accuracy of this process dramatically. But the thing is that nowadays, AI is still a subject for research and evaluation. So you'll probably won't hear some great advances of its clinical implementation, and there are some reasonable limitations for that. For instance, the accuracy in many processes is still not that high. It cannot compete with human, and the generalization of the artificial intelligence model is still a limitation. But speeding up is a very good point.
Thanks so much. It's a great talk. Thank you.
Thank you so much. Thank you.
Thank you very much.
Are there any questions? I would like to ask Professor Mitusite Mase.
Hi there.
Professor Mase, are you there? Professor Mase?
Yes, yes.
Yes, yeah.
Yes, can hear you.
Thank you so much for such wonderful talk, and it was enlightening because there are now new concepts of hydrocephalus. Previously, we believed that there is no lymphatic drainage of brain, and now we are finding lymphatics in brain. Sir, Professor, I want to ask the new by these new concepts of hydrocephalus, how will the treatment strategy will change for the hydrocephalus? Like, will we do you have any idea, like, or in your mind that these new methods can be used in future, because shunt failure is a dreaded complication, and every neurosurgeon is always fearful from this complication, and it happens.
Okay, so I can say that already the shunt surgery have already effective, and but this is very, I think the it's not the complete solve of this situation, and also the acute in case of acute hydrocephalus intracranial pressure increase at that time, drainage is effective, and maybe this is mechanical disturbance of brain function, but in the normal pressure hydrocephalus, the ICP is not already high. So I think that we cannot exactly explain why the INP patient's symptoms occur itself. So still the hydrocephalus has many unknown strategy or unknown problem. So in future, of course, the shunt is very simple and good treatment, but I think we have to control the water molecule movement or the metabolite washer, or such kind of the internal and functional thing, and then not by shunt is I think the aim of this treatment with hydrocephalus.
Thank you. And Professor, what about medicines like acetazolamide and aldactone, spironolactone? Those we are using, but they are effective for some time, and then, however, they affect the water production in like CSF production. Despite that, they become non-effective after some time. So why so? Like,
I think that. So I think maybe I cannot say exact. I cannot say exactly, but maybe it's not simple like that. If the increase of water production only the control of the water production, it cannot be controlled the hydrocephalus and also the symptoms that it's caused by hydrocephalus. I'm sorry.
No problem. We are looking for the answers. Thank you, Professor. Thank you.
Thank you.
Dr. Adi, do you want to ask? Do you have any comments, please?
I'm sorry to interrupt for the good discussion, but I think we are scheduled for the next session, and that will be a live presentation session where we have Professor Ibrahim Bey, who is going to talk on the radical excision of rhinopharyngoma, his personal experience. So we'll have this talk, and then if anybody has any question, we can come back to the question again. So
sure.
May I request Professor to share his screen and start his presentation, please?
Can you see my slides? Hello?
Yes, Professor, we can see your slides.
Okay, I'll proceed. Thank you very much for the invitation. It's a great pleasure and honor to be with you today. This is the Farah Medical Campus where I work in Amman, Jordan. This is the Petra of Jordan. This is Dead Sea of Jordan, where it is the lowest point of Earth. It says here 420 meters, now it's 460 meters because of recession of water. It's a very scenery area. You can float on the surface of the water and have a mud treatment for your skin. Just a few minutes away from the baptism site where Jesus Christ was baptized by John the Baptist. It's a well-known heritage site, and popes visited us frequently there. And this is Mount Nebo, just about 10 minutes away from the Dead Sea. And this is the mosaic maps of Madaba, one of the oldest maps of the Holy Land. And this is the countryside of Jordan, of which people know very little about. This is the Jordan Valley. And this is the downtown Amman, which is the capital of Jordan. So it's only 30 minutes between Amman, the capital, over the hills of Amman and the Dead Sea. And this is where I live. And in winter, like now, we're having heavy winter, and we have usually every year snow that can be really heavy. This is the Black Iris symbol of Jordan. I'll just proceed now with the presentation. We know all that there are so many treatment modalities for the craniopharyngiomas, but surgery remains the mainstay. And the debate for now and for many years to come will persist regarding whether to go for radical excision or for partial excision. So partial excision with radiotherapy versus radical resection. I go for this one. So this is my presentation. Collected about 114 cases over this period of time, mostly children. This is the distribution. Majority are children. This is the youngest and oldest of my patients. And the majority of my cases were either solid or mixed. Very few were cystic. And the problem was that the size, more than 4 centimeters, was the majority. really big, something like 70-something cases of bigger size. And these are the cases on the sagittal cuts. They are really giant. Some of them in the sagittal views. This is what we get in this part of the world, the giants of giants. This is the coronal sections. And again, the size is really giant. And this really is a challenge for this kind of pathology. And the axial. So what to do with these giants of giants? The only way is to go for surgery, and the only way is to try to eradicate the tumor completely if you can. So I arranged my cases according to that there was no involvement of the hypothalamus, which was 12 cases, or whether the hypothalamus was elevated or distorted but still visible, 9 cases, or hypothalamus was involved and no longer is visible. This is the majority of cases. And the concern here is that the hypothalamus, this 5 grams of brain tissue that controls our life and metabolism and everything, are arranged in groups, anterior, middle, and posterior group. And then if you look at them laterally, they are arranged paraventricular and middle and then lateral groups. So these nuclei control really the essence of our life. So this is the thalamus, this is the hypothalamus. So it is the little bit of the lateral wall and the floor of the third ventricle. And if you look at it from above, if you just sort of walk from anterior to posterior, you can come across the mammillary bodies and then go to the aqueduct of Sylvius and in the pineal region. So these are the nuclei of the hypothalamus in 3D. So all the cases of my cases will have a good history, physical images, visual assessment, endocrine assessment, and a psychological assessment, every single case. Endocrine include everything of the hormonal assessment, CT to see if there's any calcification, any destruction, MRI, of course, with all the sequences to get an idea about the size and the morphology, and MRA to see the relationship of the arteries and the veins for the MRP with the tumor. We do full ophthalmological examination for all patients, including acuity, visual fields, optical OCT, and fundoscopy. And I use the German method of assessing visual acuity and the visual field defect. You combine them together and you get an ophthalmic score, which is really very convenient to see whether your case is getting better or worse. And sometimes you go for visual evoked potentials. As I said, I insist that I do psychological assessment, especially Karnofsky Performance Scale and the memory assessment for each and every patient. This is the categories of the patient regarding the preoperative endocrine status. They may have none, which is very few, or they may have DI, partial hypopit, total hypopit, DI and partial hypopit, or DI and total hypopit, and so on. So this is the classification. And then in particular, for the hormonal type of the pituitary, hypogonadism or hypoadrenalism or growth hormone deficiency or hyperprolactinemia or DI. Regarding adults and children, preoperative. Also, to notice whether there's any hypothalamic manifestations preoperatively, like obesity. Only few of my patients had obesity, 2 in adults and 12 in children, preoperative. And as you look into the visual assessment, and some of these patients may not have any visual defects at all, and some of them they will have. Again, hydrocephalus was seen in 10 adults and 22 kids, in addition to other neurological manifestations. I use the subfrontal, terional, and interhemispheric transbasal, and I'll just go with you through the steps of the surgery as I do it. This is the terional approach, and this the relationship of the tumor with the cranial nerves, trying to remove the tumor with the arachnoid away from the optic nerve to preserve the blood supply. And in this case, which is the interhemispheric transbasal, you can see that the chiasm is really infiltrated by the tumor heavily. These are the kind of cases that I would not go for radical excision. Like in this case, it is really infiltrated, the chiasm and the tract are totally invaded. Here, I'm using the ultrasonic aspirator for these very calcific cases. Again, this is a beautiful view of a very infiltrating tumor going through the chiasm and the tract, and you can see the ACOM complex. This in particular was a fenestrated ACOM. And then we come to the lamina terminalis. Sometimes the tumor would just present to you through the lamina terminalis, like in here. Of course, here you have preserved the olfactory tracts bilaterally, and you can actually attack right, left, and center. So it's a very versatile approach, the transbasal interhemispheric. This is kind of lamina terminalis that I came across, various types of patients. Tumor here again presenting through the lamina terminalis. And once you are there, you open the lamina terminalis in the least vascular area and you evacuate the fluid content if it is there. And to me, evacuation of the content is nothing. You are not doing any justice for the patient if you stop there, because this fluid is going to come back within 2-3 weeks' time. So it is part of surgery, but it is not the main part. Here we are opening the lamina terminalis. The fluid comes out. And then you try to dissect and find a plane of cleavage with the important structures that you are dealing with. So you go and try to find a plane of cleavage and then proceed from there. If I find a plane of cleavage, I continue. If I don't find a plane of cleavage, I stop. But I'm there with the intention of radical excision. So here, you remove masses of the tumor from there. Having evacuated the fluid, there are still loads and loads of the tumor that you should not leave there for radiotherapy. Radiotherapy is related to the volume of the tumor left there. And if you leave large volumes of the tumor, radiotherapy is going to fail. And if the radiotherapy failed, then it is disaster. So you find a plane of cleavage and try to remove as much as you can of these tumors. Different patients, different cases. Here's the last piece attached to the glycost membrane. In relation to the thalamus and hypothalamus and midbrain, sometimes, as I'm saying here, that you find a gliotic border, like in here. You can see the gliotic border. You can see the border of the hypothalamus and then separate it from the tumor. So the notion and the teaching that you cannot eradicate the craniopharyngioma completely is not on. You can, but just go and look for the plane of cleavage. So this is glycost membrane and this is midbrain, as you can see it. These are mammillary bodies as seen through the lamina terminalis. And also you can see, of course, the basilar artery and its branches. So this is the final view. It's a beautiful view. You have preserved the olfactory tracts, you have preserved the stalk, and here you can see that internal carotid is seen and so on. Also, you can see the aqueduct. Regarding the stalk, if it is tumorous, I take it out. If the stalk is not tumorous, then I preserve it. In this view, through the tribunal, you can separate the tumor from the stalk, so I preserve it. Here we are separating the tumor from the stalk through the transbasal approach, and still there is a small piece of the tumor attached to the stalk, so I separate them, cut them, so the stalk is freed completely. And then I found a tumor here in this particular case going through diaphragma celli into the cella. I follow that in and remove it completely. So if the stalk is tumorous, it's nonsense to keep it. If the stalk is not tumorous, you keep it. Relationship with the vascular system, internal carotid. I've rarely find adhesions with the internal carotid. I only found it in 1 or 2 cases in the 114 cases. Most of the time it is not. Here we are removing the tumor and you can see the basilar artery and its termination and its perforators, which we can preserve and achieve radical excision. These are all still pictures from my cases. I'm putting them because if there's no time to show you the videos, at least we have seen the still pictures. Histology, we do all kind of immunostaining for all of these cases, and we've published this paper in the Journal of the American Pathology, differential expression of immunohistochemistry markers for epithelial squamous cells in adamantomas, and also published our work in the lamina terminalis approach for third ventricular cranopharyngoma in the Journal of Skull-Base Surgery. As you know, recently there has been talk about the BRAF gene mutation in the papillary type and the beta-catenin mutation in the adamantinoma type, and we've also been following that. And my pathologist would provide me with these slides showing the beta-catenin positive in the nucleus and in the cytoplasm of the adamantinoma. Cytoplasm, beta-catenin in the nucleus. So these are the collection of beta-catenin in our patients. And the recent publication from the WHO classification of tumors of central nervous system 2021 speaks about that we are not talking about subtypes of cranopharyngoma. The adamantinoma and the papillary type are two distinct types regarding the pathology, the morphology, and the gene mutations. We've done the beta-catenin, the papillary type, and it is negative, while the BRAF is positive in these papillary types. So maybe this is a promising option for a targeted pharmacological treatment. I looked into literature and found 2 papers only on the use of BRAF in the papillary cranopharyngoma. That's from Boston, showing you day 0, day 17, day 34, how this is responding to BRAF. And also a paper from England, a pronounced response of papillary cranopharyngiomas to treatment with the BRAF inhibitors. My personal series, again, back to it, I achieved a gross total resection in 36 out of 48. Now, I go in with the intention of a gross total resection. I've never went in with the idea of just taking a biopsy or evacuate the fluid and just refer for radiotherapy. The state of mind I go in, I want to do radical excision. Can or I can't, this depends on what I see during surgery. So I achieved total radical excision, was total in 36 of adults and 52 in kids. Subtotal here. And if you look at the radical resection, I had recurrence in 11. Again, that tells you, even with the radical excision, recurrence can occur. We know this, it is well-known fact, but you go for radical excision if you can. In this group of radical excision, I had 2 mortalities. In the subtotal resection, I had recurrence in 16 and the mortality in 1. Let me show you some of these recurrent cases. This little girl of 3 years with this massive, giant, again, cranopharyngiomas. This is preoperative, this is postoperative. We've removed it completely. And she was well. That was 2005. We lost her for 2 years and she came back 2 years later. Even after radical excision like this, she came back 2 years later with this extensive recurrence. What should you do? No radiation, you go in and take it out again. And that's what we did, radical excision, no radiotherapy. And we followed her up. After 6 years, she has become a beautiful young woman with no recurrence and no radiotherapy and no shunts. Another